Perfect. Yeah, so basically, what I've found over the years is that it's not necessarily my knowledge base that caregivers are really tuning into. It's how I talk about the condition and how confidently and the language that I use and whether they can engage with the language that I'm using. So spending a lot of your energy actually making sure that you can communicate effectively with your client base is really, really important. So we've created these slides here so that you can just refer back to them. You'll get these as a PDF. You can have a look through and you can just think about, yeah, okay, I could say that better. I could stick to the point more, etc. So what medications are best for treating my dog with arthritis? We know that. And unfortunately, many people just get focused on the medications at the expense of all the other interventions, which you could argue are as, if not more powerful. What can I do to help my dog at home? What can I do to help my dog at home? Good one. Can arthritis be cured? Etc. So they are available for you, as will all of the slides. Anything to add, Evie?
No, I think that's your basic ones. I think just at the beginning, when I first started doing clinics, it was more you kind of make yourself a script so that you have something to fall back on. You feel like you don't have to have all the knowledge in your head, and owners will always throw questions at you that you're not expecting. Um, so having a script or like things that you can bounce back on is really useful, because then also the owner's like, oh, okay, they're really like, you don't have to know everything. If you look prepared for the consult, that counts for a lot as well. So if you just go, hang on, bear with me a second, I have done some research into this, I'll just look back at my notes and we can answer that question fully together.
Yeah, yeah, because you have quite a big kind of like resource kit, don't you?
Yeah, yeah.
Yeah. So biggest thing out of the whole of the day is going to be like really focusing on your communication skills, making sure that you use appropriate lingo for the caregiver. Now we have an amazing group of advisors, and this is one of our advisors, Dr. Karen Perry. And hopefully this video will play and it'll just give you a perspective. She's an orthopedic surgeon from Michigan State University. She's now a professor. Dear friend, absolutely adore her. She has been really fascinated by osteoarthritis, specifically feline osteoarthritis for a while. But what I love about this is she's an orthopedic surgeon where you kind of get the impression the animals come in, they get chopped, chunked, and checked, they're out, and that's all the orthopedic surgeon does. But she has a lot of interest in OA, and I think she puts how difficult it is to manage quite succinctly in this video. So let me play it. Come on.
Don't have any sound with it.
Hi, I'm Dr. Karen Perry, Assistant Professor in Orthopedics and Section Head of Small Animal Surgery at Michigan State University. In this brief video for canine arthritis management, I would like to touch on 3 areas where, if we placed more emphasis, I feel we could achieve better results for our patients. Firstly, I think we need to recognise just how challenging this condition can be. Because we manage osteoarthritis very commonly, it is often presumed that this should be straightforward. However, achieving optimal results for these patients can be very difficult. Secondly, I would like to emphasize the importance of multimodal treatment plans tailored to the individual patient. And thirdly, discuss a critical but often overlooked component of osteoarthritis management: monitoring. Treatment of osteoarthritis can be a substantial challenge. It often feels like you are repeatedly trying to hit a moving target, and to be honest, that is often genuinely the case. There is no cure for osteoarthritis. Even with joint replacement, the osteoarthritis that exists in other joints will require ongoing management. Traditionally, the aim of treatment has been to palliate the painful symptoms of the condition. However, this can be deceptively difficult to achieve, as the goal is often variable, both within and between patients. This means that even with one patient, that patient may be experiencing different severities and types of pain at different times of day, and this may require alteration of their therapeutic regimen. There are many reasons why this is. Firstly, there is a variable degree of pathologic change, both within the bone and the soft tissue. Secondly, the severity of discomfort is often inconsistent with the degree of pathologic or radiographic change. In fact, we have no test that accurately predicts how severely a patient's osteoarthritis will affect them clinically. We have all seen those patients with dramatic changes on radiographs who appear relatively unaffected by their condition, and patients with almost no radiographic change who are severely painful and lame. Thirdly, symptom severity is related to the recent use or stress that is placed upon the articular and periarticular tissues, generally when representing that moving target that we mentioned earlier. And fourthly, patients suffering from osteoarthritis will experience both chronic pain, characterized as a dull ache, and acute sharp shooting pains. And these different types of pain will likely respond to different analgesics and treatment modalities. So, what does this mean? The wide range of factors affecting joint health and pain status make it difficult to provide a specific recommendation for the treatment of osteoarthritis that is applicable in all situations. In order to achieve satisfactory relief under these extensively variable conditions, multimodal therapy will almost always be required, and treatment plans must be tailored to the individual patient. This is one situation where one size definitely does not fit all. Owners must be counselled from the outset that arthritis is likely to be a lifelong process that will have to be managed. There will be flare-ups, dictating alterations in therapy, and these will become more frequent and likely increase in severity as the patient ages. However, there are many things we can do, more becoming available all the time, and with a balancing act between exercise modification, weight management, medications, physical rehabilitation, maybe eventual surgery, we can substantially improve the dog's quality of life. One often overlooked component of an osteoarthritis management protocol is monitoring. Our multimodal treatment strategy will need to be tailored to the individual and altered over time, and only through monitoring can the clinician know what is working and when changes need to be made. Monitoring may include subjective and objective measurements, including goniometry to look at the joint range of motion, measurement of limb circumference to assess muscle mass, lameness scoring, and, if available, force plate analysis. Questionnaires can be useful in assessing how treatments have affected quality of life, and they have been proven to demonstrate changes in response to treatment. There are many available, but one example for dogs would be the Canine Brief Pain Inventory. Activity monitors and accelerometers can also assist with monitoring treatment efficacy and can actually be a really fun way of incentivizing owners to continue with treatment. You could try setting up a leaderboard, for example, of the most active dogs in your arthritis treatment group. As alluded to here, not only does monitoring help a clinician with decision-making in whether to continue a given medication, add another, alter diet, or advise rehabilitation, it also helps in keeping owners motivated, hereby maximizing their compliance during management of this lifelong condition. So, as you can see, while management of osteoarthritis certainly can be challenging in many respects, if we institute appropriate monitoring, make decisions based on the results of such monitoring, and build a multimodal, tailored treatment plan for each individual patient, I think we will start to see higher success rates and a greater percentage of these cases returning to an optimal quality of life. I'm Dr. Karen for Canine Arthritis Management. You can follow me at Karen L. Perry K for interesting cases, Q&As, and posts about all things orthopedic.
There you go. So that's Karen, legend Karen. Hopefully that just gives you that feeling of, right, this is meant to be hard. I think, unfortunately, there can be a tendency for people to go, oh yeah, well, OA's easy, just put them on Metacam. What else you can do? And I think it can really knock your confidence when you know deep down, actually, no, it's really difficult. It's a juggling act. It's a changing juggling act. So we hope that Professor Karen has given you that confidence in that she said it's a moving target. So very briefly, we'll just quickly introduce ourselves. so that you feel that you can ask us anything throughout the day. I'm Hannah. I set up CAM, and I'm proud to say that CAM has grown significantly. I think we now have about 8 people in the core team. We've got education outreach, education officer, social media, podcast is coming out, web designers, fundraising, project management, there's loads more. So it's quite a growing team, and we're now actually not just the UK, we're very much branching out into many other countries, Australia, New Zealand, America, Europe, etc. Evie, introduce yourself.
I am Evie, I'm a registered veterinary nurse. I'm currently working in practice at the moment, and I also work for CAM as lots of different things. Yeah, I've got a massive passion for OA, have done since the beginning of my training really, and was lucky enough to work with Hannah for a year in practice, which is where she coached me on how to set up pain clinics, and I now run successful pain clinics within my practice.
Perfect. So what we're hoping to do is basically encourage you to have the mantra, arthritis is not the end of the road, it's just the start of a new direction. Sounds daft. It's a simple phrase, but it can be really emotionally empowering for owners to use things like that on your socials, on your waiting room board. Obviously, when you say it in person, it sounds a bit weird. Hey, don't worry, arthritis is not the end of the road. Tailor it, but using that kind of mantra in your socials, in your education materials can be really empowering for an owner, because arthritis is it's a bizarre thing, because when people say arthritis, there's an apathy towards it, but there's also a real negative, oh, it's doom and gloom, they've got arthritis, it's downhill from now. Which you would think that oh, they've got arthritis, it's downhill from now, they'd feel really enthused to catch it early and do more about it. But unfortunately, there's a little bit of a paradigm there, which is crazy. I'll just explain my journey just so you can understand possibly how my brain thinks. But I was working in practice, and it was around about 2013. And one afternoon, in my little windowless consult room, I had back-to-back euthanasias. And 2 of the euthanasias were dogs that were otherwise healthy, but they couldn't stand anymore. So teeth are good, eyes are good, heart are good, chest clear, abdomen fine, but they had minimal muscle mass on the back legs and they couldn't stand, and they were there to be euthanized. They'd been seen annually. You could see from the clinical records that they'd been vaccinated on an annual basis. And I thought to myself, you know, this doesn't make any sense comparative to what I do for, you know, urine screening, blood screening, you know, getting dogs on hypothyroid medication, diabetes medication, vaccination, anti-parasiticides, etc. I was like, how can we miss this? At the same time, I was working in a practice where my colleague was intent on saying the opposite of what I said. So I am quite passionate about making sure that we deal with any problems that you might have in practice that affect your confidence and your enthusiasm. But I had just started my interest in chronic pain, and I would spend a lot of time with my clients trying to give them the advice that they needed, to find that my colleagues, when they'd seen them the next time around, would go, oh, don't worry about that. Yeah, you don't need to do that. And you're like, I've just spent ages getting them to start monitoring, or I've just got them on a weight loss plan, or I've just got them to modify their exercise. And so to have somebody else saying the polar opposite was extremely difficult. Had that grim like awareness that the volume of the body is mostly musculoskeletal, you know, tissue. That's the big volume, and we know so little about it as veterinarians. And I was a bit embarrassed that I was a one-trick pony talking about dispensing non-steroidals and putting them on breast. And it felt very bizarre to say that for, be it a carpal pain, shoulder pain, back pain, hip pain. Like, seem to say the same thing for everything. And it felt very insufficient. But I was also getting a huge amount of referral letters from the complementary therapists in and around the area. So whether it was hydrotherapy or physiotherapy, and I realized I really didn't know anything about them. And, you know, you feel very uneasy referring your client, your case, to not only a discipline you don't understand, but also a therapist that you've never met, and a system you don't know how they run. Is it once a week, once every 2 weeks? How does it all come together? My dog was also struggling. So my dog, yeah, I learned the hard way. I learned very much the hard way. So this is Holly. Holly is pacing in this video. She's got a drop tail, ears back. She's obviously quite damn uncomfortable. I developed something called supraspinatus tendinopathy, which I've got again. It's horrendous. You can't sleep very well. You get tired. You get irritable. You start becoming socially isolated. You're grumpy at work. You don't want to go out. You become what's called kinesiophobic. You don't want to do things that might hurt, like putting a jumper on hurts. So I'm like, I don't want to do it. And I started translating that into the animals that I was seeing. If they felt how I felt, no wonder they behaved differently. No wonder they were harder to manage. No wonder, you know, they start developing these habits of aversion or avoidance. And then sadly, I also lost a friend. She developed a condition called dysesthesia. Well, that's the description of the signs, which basically means her brain misinterpreted signaling. So touch felt like burning, and even just changes in temperature on her skin would feel like searing heat. And she ended up choosing to take her own life. That is a kind of chronic pain type presentation. And I started thinking to myself, how many of the animals that we see who really don't want to be handled, don't want to be touched, don't want to be lifted, are they feeling like she felt? So I felt very motivated to try and create a resource to give these animals a chance of having a quality of life, because chronic pain tends to stay. So we hope that many of our translations from the human world will resonate with you. As I say, we're trying to empower you and give you the courage and the confidence and the conviction to get your OA clinics up and running, no matter the obstacle. But taking some work, stuff from the human world works really well. Living with chronic pain makes day-to-day life difficult. It touches every single part of my life, from hygiene to cooking, to relationships to sleeping. I've been living with chronic pain since kindergarten. Now, we all know that osteoarthritis is a young dog disease. We know we've got more and more data coming out that many of these dogs live with pain from a lot younger than we give them credit. So this really resonated with me. We've also got many breeds that have predispositions that develop OA or other chronic pain related conditions. Let's think of a really topical one at the moment. French bulldogs get a load of attention about being brachycephalic. What about the spinal problems that they're born with? So many of these animals are actually living with pain. So you don't see change. If they were born with these malformations, their experience of pain is going to be prevalent very early in their life. So when saying to no, so have you seen any change? They're like, no, he's always been like that. So we have to take that into account. These are very, again, I think they're thought-provoking. You never know how you're going to feel in the morning. Now, how many of our clients come into us and say, oh, he was all right yesterday. Oh, I feel a fraud. He's fine today. I shouldn't have come in. I'm sorry to waste your time. And how many owners are likely to see that their dog is a bit sore in the morning, but by the afternoon they seem okay, so go, oh, it can't be that bad. But pain fluctuates throughout the day. Some days are easier than others. People without pain don't understand. Now, I think I've proven that. You know, Cam has been driven because of my pain experience. I thought, I don't want to live with this for life. This is not how I'm in my 30s, can't even put a jumper on, and I haven't slept for weeks. And I think we do find that many people don't understand another person's pain, let alone animals' pain. By the end of the day, you're going to be very convinced that managing pain is way more than the medications that we prescribe. And something that really bugs me is when people say, yeah, we're going to make them pain-free. I'm like, oh, how do you know that? We're not even good at detecting pain, let alone being able to say we got rid of all pain. So I'm a bit funny about when people say, oh, we're going to get rid of his pain. I'm a little bit academic. We're going to manage his pain so his quality of life comes back. Pain changes everything. And I think we all understand that. You'll see this little gremlin throughout our lectures. It's a story behind Todd. So Todd basically is our little lecture character. And the reason being is many years ago, there was a big trend and everybody was developing characters. So you had the British Gas advert, you had the meerkats, you had the AA dog, RAC dog, whatever it is, and the fan. So I was thinking, well, if this is how people engage, if this is how we grab people's attention, I'm going to get a gremlin. So Todd is our OA gremlin. I would eventually like to turn him into a stress ball. And I'd like all clinics around the country to have a Todd that they can have in their room and they can just squeeze Todd when it's getting difficult. But Todd is supposed to be there as the gremlin that sits on your shoulder and says, say something. It's very easy in our line of work with 15-minute consults, people coming and going so quickly, to turn a blind eye to something that could be difficult or not want to be talked about. And I see that a lot. I don't mean to be rude, but I've locumed for years. And I see a lot those things that the owner's not aware is a problem. Animal seems to be coping okay. Is it worth rocking the boat? This is worth rocking the boat about. So we have now got a little break. So soon, I know, but it's our opportunity to hear your stories. It gives us an idea of what kind of content to make sure that we cover today. So Evie, are you in the house? I'm going to let you lead this section. So it's nurse to nurse.
Nurse to nurse. So throughout the day, we have 3 sections. We have the vent, the build, what's the other one called?
The confidence.
The confidence, yeah. So the vent, the build, the confidence. The vent is where we need to get off our chest blockers that we may be coming against in practice, that you're finding it difficult to either set up your pain clinic or implement things within your practice to make it more OA friendly. The build is where we're going to take those things that really annoy us, and then we're going to come up with strategies that make it a bit better. And then the confidence is where we're going to boost you guys up and make you feel like when you go on Monday, you've got the confidence to go in and go, look, we are putting yoga mats down, or we need to start doing this pain clinic, or we need to start using more objective monitoring in our practice. So we'll start with the vent this morning. I'll start by venting because I love a good vent. But probably the first blocker that I came against when working in practice with Hannah was we unfortunately didn't have a supportive team around us. Even though we had the guru of OA with us, they still didn't believe, well, they didn't see what we saw, and it became quite frustrating. You felt like you were hitting your head against a wall a bit. You put yoga mats down or a floor runner so the dog wouldn't slip, and they'd look at you like you're overreacting. Oh, we've never used that before. You don't need that. So that was a massive blocker for me in setting up my clinics. So yeah, if anyone else has anything they would like to add to that, anything that they might have come up against in practice or what they fear they might come up against in practice, please unmute yourself and let us know.
Hi.
Hello, you all right, Charlotte?
Yeah, good, thanks. So I'm a new grad, so I haven't spent a lot of time working in practice before, but I can draw from my own dog that has OA. Mm-hmm. So you go see a vet and they agree that your dog might have arthritis, but there is very limited knowledge about where to refer to. As a client, I had no idea where to go, and they just wanted to refer me to the RVC for maybe a pain assessment, which is a 4-month wait and super expensive. But where these multimodal therapies, where to go, who's trusted, what's best, which laser's best, like none of the vets that I saw really know where, like how to piece together this multimodal thing. And I'm not sure what role the nurse can play in that if there isn't a buy-in from the vet.
Yeah, completely. It can, like I said, you need to have a supportive team behind you to make it move forward. Me and Hannah have discussed this so many times with lots of people where they've come up against exactly the same thing as us. I think if you can find at least one other staff member in your practice that is passionate about it, can see it, understands it, so maybe go back, do a lunch and learn with your practice, and say, look, I really want to share my knowledge that I learned on my CPD this weekend. We did the practice training as a practice, which helped massively, and all the nurses in my practice now are like, I can't unsee it. It's everywhere. It's every owner that comes in. It's every dog that I see walking down the street. So as long as you have one person behind you, they that then can understand the importance, and you can start building this multimodal approach to kind of have a template that you can use in practice for patients like your dog. But yeah, I understand it is frustrating, and as an owner as well, the amount of owners we see on Holly's Army that are like, I don't know which way to turn. We're chucking all these meds and it's not doing anything, and I'm just so confused. So I can see it's frustrating from a nurse's point of view, but also an owner's. I think with getting your vet on board as a nurse, you need to make it as easy as possible. Vets, some of them like to be awkward, but some of them don't mean to be awkward. That everyone's under pressure in the vets, and I think that's something we need to remember. They're being chucked 15-minute appointments to get through all these patients, plus make referrals, call back lab reports, things like that. So I think if you are wanting to set up these pain clinics, what's worked for me to get my vet on board is like, right, I will go through the list of patients you've had today, any that have been prescribed Librela, Metacam, Previcox, Rimadyl, anything like that. I will ring up and say, look, you've had this prescribed to you today, because we're suspicious there's some pain going on. Would you like to come in for a pain clinic? So you're taking that workload and making that work. That's worked really well for me because I haven't put more workload on the vet.
We offer practice training. So just to explain, I started doing lunch and learns back in about 2014, off my own back, total freak. So I would go and offer my services to local practices, which meant that I did a lot of driving at my own expense. And I found them quite demoralizing. You get an hour with a team that are more interested in the donuts than the actual content. And I thought, okay, right, strategy 2. So then we started tailoring our CPD to the individuals. So we did vet training and we did reception training and nurse training. And I realized then all we were doing was creating isolated pods in a practice. So it would be like training you guys up and you go back and no one has your passion. No one's listened to what you've heard. So then we were like, right, we've been in all of this. We're not doing this anymore. We now do practice trainings. So what we hope is that this nurse clinic, we give you our time and attention, and then hopefully you will be able to go back to your practice and say, look, I think this is something the whole team will get something out of. And then we have seen it work time and time again. If everybody can start to see the same cases, so they see how many there are, then you start to get that team feeling. And if everybody's heard the same content, they say the same thing, they offer the clients continuity. So there is a practice training angle to us. We have recorded online, so a practice can do it at their own pace. There's 4 modules for reception, 10 modules for nurses, and 10 modules for vets. And a practice can sign up and they can do it over their own time frame. Generally, we encourage people to reward the practice on completion. So we say to the practice owner, make them a target. And at that target point, you're going to pay for a practice dinner, or you're going to get pizzas in for lunch, or something great is going to happen that everybody has completed the training. But we also offer them live. Again, I'm back in the country. So we are willing to go to practices anywhere in the UK within reason and do practice trainings. And it's a whole day event. I tend to take reception first so that the nurses can man reception, take them for an hour and a half. Then I put them back. And then I take the nurses for an hour and a half to 2 hours. And then I put them back. And then I take the whole team for an hour. And then I take the vets last, because I want them to be quiet in the beginning because I don't want them to know anything, because they tend to be really confident and think that they understand the topic when they don't. So I actually leave them to the last part of the day with intention. So that is available as well.
Does anyone have anything else they want to add to the vent?
Be anything.
Anything? Just something that's pissed you off during the week that you want to get off your chest. We're not judging. An annoying boss, an annoying head nurse, anything.
Other things that were used to frustrate us, we can list them. You'd go into the room that you'd equipped with your resources and they wouldn't be there anymore. Someone had just moved them. So your mats couldn't find them. So it just added time. And then as soon as you had a situation, so for me, trying to lead by example, if I go to get my yoga mat or my rubber mat, it's not there. And then I'm being forced into a corner to do a consultation in a manner that I don't believe is correct anymore. And then it looks like you're not practicing what you preach because, oh, you don't do it all the time, Hannah. So I don't know why you think it's that important, because I've seen you 3 consults this morning you did without a yoga mat on the floor. I'm like, because you little bastards freaking stole my yoga mats, you know? And it was just all those little things, they begin to stack up. And over time, you end up becoming resentful. You begin isolated. And I went through a phase of becoming really, really resentful to my nursing team, which was, you know, it's hard. It's really, really hard. Other things that used to piss me off was everything else seemed to always be more important. So Evie would have, you know, back-to-back consults for the afternoon, pain focus, and then they'd be like, no, you're gonna have to cancel them all because George is not here and you need to go and do anesthetics. And so it would always be the first thing to have to budge. And that really frustrated me, because pain in this situation leads to death. You know, you're not going to just cancel all of your diabetic or all of your heart clinics, but for some reason it was always the first thing that used to be budged to the side.
Another thing that annoys me is
Here we go.
Clients drive me crazy some days. I was covering reception the other day and I had a phone call from a client and she said, oh, can I book my dog in? It's not urgent. It could be in the next few weeks. He's just in pain. Just in pain. I was like, okay, how do you know that? Oh, well, he's not weight bearing on 2 legs. It's like, right, well, do you want to come straight in? Like, that just makes me mad. Or one of my lovely pain clinic clients who I love to bits, but I just wanted to pull my hair out at this point. We were actually really tight myofascia in her neck and just really uncomfortable, could hardly, it was literally like robot walking. No pain relief was touching it. We started doing laser and massage, and the owner would come back every other day for this. And I kept saying, like, have you done the home improvements? Yeah, I've done all that. I can't understand why it's not working. We've got the new orthopedic bed. We got the ramp up into the car, things like that. I was then walking my own dog in the park and saw her. She was sat on a bench and the dog jumped up on her legs, just 2 front feet. And she put her hands behind the back of the head, you know, like people do. And then the dog like clambers up like that. So she was basically hauling the dog every time it jumped up at her. And I was like, surprise, I'm here. Change that, please.
Yeah, we all have them, but this what we hope to do from the day, and generally by this afternoon you're all able to talk much more openly, because knowledge is one thing, but being able to put it into practice is another. And we have to accept that there are many obstacles for you being able to do that. And we hope that by everybody sharing their frustrations, you don't feel alone. It's not only you dealing with them. So think about your vents. If you've got things to share, we can come back to it later. But if no one else has got anything they want to share now, we'll crack on. Anybody else? Don't feel inhibited. You can say anything you want.
Can I add another one?
Of
Yeah.
course you can.
Came across a dog, 12-year-old, who's just been diagnosed with Cushing's. So it's obviously seen a vet recently, on meds with that, but can barely stand up. I couldn't even, this is my friend's dog, I couldn't even look at her. I mean, she's pushing through it. She's so happy, but she can barely walk. And there's obviously no home adaptations or anything because the vet clearly hasn't, I mean, you would expect any vet that saw that dog to immediately discuss OA. And obviously that hadn't been done. So it's that frustration, but also it's angry, and also you feel really stupid, like helpless to do something. Like, oh well, I'm just a nurse, and a vet has clearly seen this animal recently, assessed this animal recently. And also the other thing is, like, you don't want to offend or provoke or make the owners like come up against the owners by saying your animal's in a lot of pain. Like, well, that's embarrassing to bring up, I find. And also, yeah, like I said, so the vet has seen the animal, hasn't been like, who are you to kind of bring this up and put this huge thing in their lives that isn't already there? That makes sense.
Yeah.
No, it's really complex, and I've just been doing some work with Boehringer about how we can potentially change the parameters of that consultation for the vet. And something that I think you possibly will kind of go, oh yeah, of course. There's a real pressure on vets to diagnose in a consult, in a small box room, 15 minutes, maybe 3 people, 4 people in that room, and come up with the definitive diagnosis and a definitive treatment plan. And I think when they've come in for something else that they're dealing with, and to bring this in and to bring something else in, it's just too much. So we're looking at ways that we can say to the vet sector, don't put that pressure on yourself. Just introduce the concept that the dog's got discomfort. So we've been working on videos for what's called pain screening. So instead of vets thinking that they've got to do the clinical exam, the neurological exam, the orthopedic exam, and go, it's definitely left elbow, this degree of discomfort, this degree of restriction, and this is the ultimate plan, to give that vet permission to go, there is discomfort here. I think both me and you can see this. What we're going to do is we're going to start slow and build from here. So it almost gives them the opportunity to kind of moderate what their expectations of themselves are. You know, that's still a massive achievement for that dog with Cushing's, for that vet to just introduce the concept. Look, I think we've got Cushing's, but we've also got other things going on, and we can both agree there's signs of discomfort here. So we're going to park it, but we're not leaving it alone. We're going to come back to it. And that sounds so trivial. You're probably going, what? Oh, isn't that logical? But I think we've got to understand that vet mentality of the expectations that are being placed upon them for those consultation sessions. So that's in the pipeline. That will be on its way. But all of these things, yeah.
Sorry, I just want to add, don't feel like you don't have a voice as a nurse, because you definitely do. And if you are concerned, we still take our oath when we qualify as nurses that we're there utmost for the animal's welfare. And if a dog is in pain or discomfort, their welfare standards are not okay, and that is something we need to speak up about. One of my nurses that I work with came up with a really good point and said, basically, ignoring a dog in pain that is limping and not saying anything to the vet is as bad as leaving them in a shitty kennel for hours and just ignoring it. I know it can be hard as a nurse, and you feel like the vet's going to say, oh, who are you to say that? So that is where your objective monitoring comes in. And you can, if you see that client coming in, you can then go out and go, oh, is Rusty always walking like that? Should we just do some objective monitoring for a couple of weeks and just see how you get on? And if you want to come in and talk about like home adaptations as he's getting a bit older and things like that, and things to make things a bit easier, then I'd be more than happy to do that. You could do it as a phone call, or you could get them to come back into the practice. And then if they carry out the objective monitoring tools, that's something you can then take to the vet and say, look, I'm really worried about this dog. He's scored such and such an objective monitoring, and I think he is really struggling. I think it's something that needs to be addressed.
I think what an ideal situation, and Claire, I am going to come to your question about corporate and money and stuff. And in an ideal world, what will happen after today is you guys are going to go, right, okay, yeah, I'm committed. I'm gonna do something about this. And then the first step is to find your colleague at work, your colleague or colleagues. And what we really try and encourage people to do is to find a vet, nurse, receptionist team, one of each. So you've got that vet that you know you can always talk to, and you can say, hey, I've seen a couple. Can I get you to have a look at their case reports? Can I take your advice on, you know, what we should do next? Can I hand them to you and get that vet and you to start working as a team, ideally. Reception are brilliant because they can preempt, so they can do exactly what Evie's just said. If Rusty's in the waiting room, they can go, hey, should we put Matt down for Rusty? He's really struggling today, isn't he? You better mention that to the vet when you pop in for your vaccine. You know, tell them that he's had difficulty standing up, so that they make sure that they include that in the examination. So powerful what reception can do. So, you know, influential. Now, Claire, about the corporates and money making, that's another vent for me, is that there is so much money in this. I was talking to Alan from Veterinary Dynamics about how could I do a presentation that goes live, so anybody could watch it, where we could talk about the finances of good chronic pain management. And he was like, it's a tricky one, Anna, isn't it? Because it's emotive. And if you look like you're trying to make money out of a horrid terminal disease, you're going to look like an arsehole. And I was like, I know, I am going to look like an arsehole, but I really need these practices to see that there is a huge amount of money to be made in good pain management. Because if they live longer, they're going to buy more drugs, they have more screens, they buy more food, they'll engage with more services. Why? It's a no-brainer. So there's this thing, I did some practice management years ago. It's a lot harder to get a new client to the practice than it is to utilize the clients that you have and get them to manage their pets' cases more efficiently for turnover reasons. There is less turnover in getting a new client into a practice than there is utilizing the clients that you already have. Now we can extrapolate that into chronic pain management. It is less beneficial to get new clients. It's better to be using the clients that you've got more effectively to generate turnover. So there is a lot of money to be made in chronic pain management. For example, I worked in Scotland for a while doing stem cells. A stem cell case in Scotland with all the diagnostics, that come in about $8,000, you know. Then they come back 3 months for a top up, and they come back every year for a top up. A couple of grand to go. I'm not talking small fry, are we? But if you got these dogs on a prescription diet, so Hills JD, got some weight loss in it, Hills JD mobility, they're going to be buying that consistently. You know, it's ridiculous how people don't see that this is a really profitable area of vet medicine. I did actually do some work for Lindbells years ago. I did something called the OA Start Gun, and I'm happy to share it with you guys. So it's 5 mini presentations. And one's, why is OA management good for the dog? Why is it good for the client? Why is it good for the team? And why is it good for the practice? And it's the practice one talks about finances. So if that is of use to you, that is available. I believe it's still on Lindbells Academy.
Can I just also add to that as well? So my best friend works in an IVC practice, and she has been pushing for 2 years to start her own pain and rehab clinic. They have now, so end of last year, they offered her half a day a week to try and set up these clinics and get them running. And she's now given 3 days a week, and she's literally back to back in these pain clinics. They are something that's needed. She went to them with a business plan. So like Hannah said, it is going to make the practice money, and that's at the end of the day what the big bosses, that's what they want to hear. So I would put together a business plan about how much you're going to charge for these consults. You will then be needing a vet maybe to come in and check, so that's an extra charge. Again, the food, you could have the toys out the front, so make sure that they're OA friendly. So you could have a look on the CAM shop. We've got all our OA friendly and endorsed products, but things like licky mats or snuffle mats or harnesses,
Help them up harnesses,
help
yeah.
them up harnesses, things like that, that you could then be like, look, we should probably add this into it. They go out, they buy that, they then come in for another clinic. These clinics are something that's needed. The amount of times we do tea and chats in our member zone, and comments on Holly's Army, and people are constantly wanting support from their practice, and they're also wanting to know where to go because their practice doesn't offer it. So it is something that is needed, and that should be something that's put into the business plan about the emotional side for the owner, and having continuity of care and things like that.
Yeah, and also if you are going to do a business plan, include the fact that the dog will live longer. So a dog that might only be on a 6 months trajectory suddenly lives 18 months. That's a massive turnover opportunity. Blood and urine screening, remember that as well. And also we know that many clients after their dog is euthanized may actually seek another practice to go to. But if they've received really incredible palliative care for their last dog, they're going to say, do you know what, I'd never go anywhere else. I want to stay at this practice. So your business plan should not just be focused on the individual. It should be focused on the potential as well. But we can help you do that. That's not a problem.
Yeah, definitely. To Helen, to your question, we run through a lot of templates and questions when we actually go through setting up your nurse clinic. So should we leave that question for now, because it will get answered today, and we'll come back to that later if that's okay.
Amazing. Cool. Venting is allowed at any point. The next emotional outlet will be the build. So we can take some of these vents and we can carry on building potential solutions for you. But we're now going to crack on. Now, has anybody got a specific area that they desperately want to talk about? Because we have got pharmaceuticals, but we feel it's a bit dry. So instead, what we've got is a lecture that really promotes a greater understanding about chronic pain and gives you ideas of how to start getting your team members that are very focused on acute pain to start thinking chronic pain is as important. So tell me if there's specifics before we launch into that. Happy for me to lead, and then we can see where the inspiration goes. Adjunctive therapies, yeah, we will do that. That comes later today in this afternoon. All right, let's do this one.
Nutrition and weight loss.
Yeah, we can deal with that. That's no problem.
That also we go through that later as well. So that's fab.
So this is the lecture that I delivered for the Pain Management Forum, IVAPM, Missouri. No, I can't remember where I was, Indianapolis. And I actually went really well. So I'm using it again. And what I'm going to try and do is start expanding your field of view of where chronic pain features in practice. So we're going to do chronic pain in an acute setting, and that's not just the context of an ECC type setting, so an emergency setting, but also the fact that we know that osteoarthritis is an acute on chronic condition. What our objectives are going to be: understand the importance of identifying and accommodating chronic pain within acute presentations. So these are dogs and cats that have arrived for an acute reason, but we still can have a chronic condition behind the scenes. I want you to be able to explain and support the importance of chronic pain consideration in these acute presentations to your colleagues. I want to gain confidence in a systematic approach to managing these acute deteriorations. And I want to give you confidence to start adding to your care plan how to manage these acute decompensations. So believe it or not, there's very little in the literature to guide human management of acute deteriorations in chronic pain, let alone in the vet sector. But what we can find is that, for example, in a hospital in Italy, and this is a paper from 2021, between 10 and 40% of patients that were admitted to an emergency department were being admitted because of chronic pain related So acute decompensations of a chronic pain state. That's a huge percentage of people arriving at A&E. In Australia 2012, between 12 and 16% of total emergency department visits were related to background chronic pain that had decompensated. And 7% were people that were coming into these acute settings on a regular basis. So a huge strain on the healthcare systems. Because chronic pain with acute deteriorations actually requires a lot of multimodal management and understanding, it's a very complex condition to manage. And in an acute setting, it's not the place to have these lengthy conversations, which is really demonstrative of what we have in first opinion practice. And this was leading to dissatisfaction for both the patients, but also for the care teams who were feeling frustrated and demoralized. So it's evident that an emergency department is not the ideal setting for managing patients with chronic pain. However, it is the last resort for many who do present and who will continue to present should their pain persist. Well, this is what is actually happening in first opinion practice. We're having these animals that come in with these acute deteriorations, but they've actually got a very complex chronic pain process behind it. And they're being managed as if they are an acute presentation. They're given the time, the energy, and the enthusiasm as if it's a curative transient condition. It's not. Despite the prevalence, this is very relevant to us, this patient group with its complex needs is often inadequately managed. I think we can relate to that. And it's time to ensure that the emergency department provides a consistently supportive, cohesive, and integrated approach to managing patients with chronic pain syndromes. I think we can all kind of nod our heads and go, you know, this really resonates with what's happening in our first opinion management. Now, chronic pain in the human sector is way, way more complex. It's being delved into. We're beginning to, break it down into different categories. And this is the International Classification of Diseases, the 11th edition, where something quite profound happened. So this is a human tool, but for the first time, they actually identified, they categorize what's called chronic primary pain. And these are pain conditions where there's not a biological etiology that they can be found. So these are the fibromyalgias, the chronic, complex regional pain syndrome, where the person is describing pain, but when investigated and imaged, there's nothing there. And this is now recognized, whereas it had always been kind of on the back burner. But I just want to highlight how in the human sector, chronic pain has got a lot more attention to it than we have in the vet sector, because just the chronic widespread pain here, just under chronic primary pain, that can then be broken down to all of these conditions. Now, this is quite mind-blowing when we don't do this at all in animals. This is how far it goes with animals at the moment. We have acute pain and chronic pain, and we can divide an acute into nociceptive and inflammatory, and we can divide chronic into neuropathic and functional. This is from the American Association, AHA, can never get it right. Anyway, it doesn't matter. So we are so far behind with regards to our ability to kind of subcategorize this chronic pain and create protocols that are suitable for each of these conditions. We tend to recognize chronic pain as being either nociceptively driven, and we'll come back to that in a bit, neuropathically driven, so impingement of the peripheral or central nervous system. But we are very aware that many conditions are actually a mixed presentation of both nociceptive, and if you want me to go into what that's about, I can in a bit. So we are, as I say, still really lacking. Now, this really demonstrates what is happening in practice. I think a lot of people are apathetic towards OA because they're already struggling. And in an emergency department sector, there's that belief, well, OA, it's not life-threatening. It's not life-threatening. I've got to attend to this. The heart condition is more life-threatening, or the cushions is more threatening. Well, actually, let's be honest, what did I say right at the beginning? If chronic pain isn't well managed, they end up in euthanasia. So it is a life-threatening disease. But we need to realize that our industry is struggling, and we want to try and improve OA management without to the detriment of the vets and the vet teams that are working in this sector. We don't want to make their life harder. So what we're going to do is we're going to look at chronic pain, and we're going to do it from the major stakeholders. So the ultimate stakeholder is the person with the pain, the animal with the pain. We're going to then look at what unmanaged chronic pain can do to the caregiver, and we're going to also look at unmanaged chronic pain, how it influences the team. So first of all, we're going to just talk about pain, and we're going to review very quickly nociception. Now, this is something to be really, really cognizant of, is that pain is not pain until it reaches the brain. So until that signal has been processed into an experience of pain, which is subjective, the process that leads to that is called nociception, okay? So the signaling from the periphery, transmitting up to the spinal cord, modulated at the dorsal horn, then projected up to the higher centers. This is called nociception, all right? And nociception is because of nociceptors, which are high threshold receptors, be them temperature, be them force, be them chemical, that are there to detect potential danger. So these are receptors that pick up on very high temperature, very low temperature, force, inflammatory mediators, because they need to fire and they need to signal quickly that there is danger and the body needs to take note and do something about it. So it's an amazing protective mechanism. Now, in the cases of things like osteoarthritis, so we've got these degenerative changes within the joints. We've got the cartilage breakdown, the joint capsule changes, the synovial fluid changes, the subchondral bone changes. All these changes within the joints being driven by an inflammatory soup. So there's all these inflammatory mediators that are circulating because of these degenerative processes taking place. And these inflammatory mediators will lower these nociceptor thresholds, so they're more likely to fire. So in an inflammatory condition, those danger receptors are more likely to trigger. And danger receptors that were quite silent get recruited. And this is what's called peripheral sensitization, where the inflammatory mediators upregulate the nociceptor signaling potential. Now, so if we've got more signals being generated from the periphery, so we had a trickle of information, and now it's ramping up and it's ramping up and it's ramping up, and we get more and more and more signaling going up to our spinal cord. Here at the dorsal horn, where modulation takes place, i.e. some signals never reach the brain, they're like, no, you're not important. No, you're not important. No, you are important. Modulation is influenced, and because of the barrage of signaling, because it's being driven by this sensitization that's creating more and more signaling, then modulation is also affected, and it is more able to send signals and project them up to the brain. There's less inhibition in this area because it's getting bombarded and it goes, right, I need to really promote the signaling because something bad is happening down there. And this is called central sensitization. And many, many things are happening during central sensitization, which is the amplification of pain signaling. And what we'll do is we'll come back to it later. Don't get caught up in this. You'll have the slides. But it's an extremely complex process which fundamentally leads to improved signaling of the nociceptive system. So therefore, we will end up perceiving more pain. Peripheral and central sensitization. Peripheral sensitization, take note, because it's very inflammatory mediator driven. That's why anti-inflammatories are very, very powerful. And central sensitization, take note, this is where our chronic adjuncts, the gabapentins, the amantadines, this sort of thing comes into play. So it's our two kind of like key areas. Please remember that pain is an experience. Pain is individual, pain is unique, pain is yours. No one else can feel your pain. No one else will ever be party to it. Dogs, cats, gerbils, rabbits, their pain experience is individual to them. We need to actually sway from being fearful of intervening to being proactive. If we believe something will be painful, if we believe that they are in pain, we should attend to it. Because pain, this nociceptive signaling system, if left unmanaged, as you can see, it will upregulate. If we don't control that signaling, we'll get more central sensitization, we'll get improved signaling, we'll get amplification. So actually attacking pain-related conditions early is much better for them in the long run. And we'll expand upon that in a minute. So as I say, modulation at that dorsal horn is extremely complex, many things taking place. And that gives us targets to try and influence. So just to kind of start making you think a little bit differently about OA, consider osteoarthritis, the disease within the joints, as one part of the condition. Are affecting the signaling of pain. They're not actually influencing the disease. So when we construct our plans, we need to go, what am I doing for the disease in the joint? What am I doing for the signaling system? And I'll expand upon that in a minute. So remember what we were talking about, this central sensitization. So if you keep getting signaling, if there's a barrage, an upregulated persistent signaling, and it leads to these changes within the nervous system that promote mechanism called central sensitization, is common to inflammatory conditions, neuropathic, or dysfunctional pain. Leave dysfunctional pain, but it relates to that chronic primary where actually you can't find the cause. Again, in vet medicine, we don't manage this at all. We don't know anything about it. We are so focused on finding the source of pain that I don't think we're even aware to all of the conditions out there that a dog may be in pain, but we can't find the underlying cause. That's called dysfunctional pain or chronic primary pain. Problem with anything is there's always 2 or 3 names for the same thing, and it can get very confusing. So this central sensitization, because of this persistent ongoing signaling, actually really drives some dramatic changes. It increases the synaptic strength of those neurons. It activates subthreshold nociceptive neurons, so the ones that wouldn't have normally fired now start firing. It reduces the threshold of the ones that were firing, so they're more likely to fire. And it basically expands the receptive field and the responsiveness. So that basically means that if we don't control pain and central sensitization takes place, the pain that we experience is going to be greater. So that can be well demonstrated in this, in that we have more information projecting up to the higher centers and less inhibition from the higher centers down to that dorsal horn controlling the messages. So we just get a barrage of signaling causing a greater pain experience. Now, how can we put that pictorially to make it make more sense? This is a typical English road. I don't have this car, it's beautiful, but it's a B road. And you have a trundle of traffic. You just have a trundle of traffic. And that's your quiet nociceptive system when it's not being bombarded with trauma in the periphery. So these signals are just trundling along. But once we start having a source driving the signaling, such as osteoarthritis, and these nociceptors thresholds have dropped and they're more likely to fire, that B road turns into an M road. So we now have significant signaling going up that nerve part, that nervous system. And what people don't realize, because we talk in terms of pain pathways tends to give you the impression that only the nervous system connecting the area of osteoarthritis to the brain will be affected. So it'll only be that nervous system. It won't be all of the nervous system, but it isn't, because the nervous system becomes sensitized in total. Now, I've experienced this recently. As I said, I've been having quite a lot of pain in my my upper back and my shoulders, like crippling discomfort, unable to do things. And I feel that I've become more sensitive to other sources of pain. So if I stub my toe, to me, it's worse. If I get, say, a gnat bite and I'm scratching that, it feels worse. And that's really what is happening here, is that your nervous system, when it's really working well at doing this nociceptive signaling, it's actually becoming hypersensitive to a lot of things. So your whole nervous system, it's not just that pain pathway, it's your whole nervous system is upregulating its sensitivity. So the problem with pain pathways is that it leads to us to believe that there are isolated neuronal pathways. So from just the knee to the brain, from the ankle to the brain, from the hip to brain, and that's not true at all. This central sensitization that takes place because of this increased signaling has a wider field of influence, and it creates systemic inflammation, also neurogenic inflammation. So the nervous system in itself is inflamed. And that means that the whole nociceptive system, the whole body, is more receptive to signaling about pain. It's more efficient. And therefore, it's primed. It's primed to signal about pain. So the modulation in the dorsal horn, the brainstem, there's plasticity in the brain that processes these signals and turn them into the pain experience. All of it is becoming sensitized. So what does that mean to us? And so there's you loving your chronic pain, but everybody else in your practice doesn't seem to be that interested. Well, they should be. Because if we have a dog that's got chronic pain, comes in to have a lump removal, well, they're more likely to have a worse pain experience from that surgical procedure. If that dog that has got chronic OA gets dental problems, that pain from the dental problems is likely to be worse. If they get an ear infection, that pain from that ear infection is likely to be worse. So actually, all of us should be really, really acutely aware of if there is a chronic pain condition, because then we're going to have to really think about our pain management protocols to make sure that they are really, really aligned for the job that they need to do. So central sensitization enhances the function of the nociceptor apparatus. It alters the pain threshold, it lowers it. It has increased intensity of the pain experience. And as we all know, no matter whether it's acute pain or chronic pain, no matter where that pain is coming from, it will have consequences. This is related to all pain, not just OA. If you live for a period of time with pain, it's going to affect you emotionally and psychologically. Anxiety might start causing depression, fear. I've been really anxious that this condition in my shoulder is not going to go away. I've had kinesiophobia, so I've not used my arm as much, and therefore I've lost muscle mass, so it's made it worse. As I say, I don't want it for life. It stopped me going out. It stopped me doing things. And if you live in pain, your coping mechanisms become depleted, be they psychological, emotional, or physical, as said, because I don't want to put myself into a painful situation. I haven't used that arm as much, and therefore I've lost muscle mass. So my physical function is now being affected. So if you've got these psychological reduced coping mechanisms kind of going on, but the pain is getting worse, then you get this horrendous negative spiral. So let's look at this pain experience. So you're thinking, oh my God, I don't really know what that means, but pain is actually a phenomenon. Pain is a cumulative result of many different things. And we're going to break it down. So we've got the sensory information. So that is from our nociceptive system saying there's something not right. And that gives us an impression of where it is. Where is it coming from? Is it my knee? Is it my ankle? Is it my finger? What could it be? How bad is it? So that's your sensory information, trying to quantify and qualify what the problem is so that you can make the best appropriate motor response. You have a physiological response to that, which is out of your control. So whether we like it or not, if our body is in danger or is damaged, we get ready to do something about it. Our body instantly lines itself up for flight, fright, or fight. And your heart rate, blood pressure, pilar erection, pupillary dilation, sweating, all of these autonomic type changes take place. You can't control them. That's part and parcel. But then we have to actually think that pain signal, once it's hit the brain, we go, what does it mean for me? Have I experienced this before? How's that going to affect my future? What do I really think about it? How do I feel about it? Am I already struggling with life and this has just tipped me over the edge? So all of these things come together to create your motor response, your outward behavior. So pain is always going to be unique. It's always going to be individual, and it's never going to be the same, even for that individual. And there are many areas here that we're now going to be able to start thinking, well, can I manipulate that to improve the pain experience? Can I manipulate their cognitive assessment of the situation? That's where things like cognitive behavioral therapy, acceptance and commitment theory, therapy, all of these mind over matter type therapies that are commonplace with chronic pain management in humans tends to work, both on the psychological and the emotional aspects of being in pain. So the pain experience is the sensory data coming in, the associated stress response. How do I feel about it? And what does it mean for me? And I don't want this to happen again. What am I going to learn from it? Now, if we have persistent pain that's upregulated and it's amplified, that means we've got this increased noxious signaling. We're going to have a greater persistent stress response. Persistent stress, we all know, is bad for the body, don't we? How do I feel about it? Well, I'm going to become fearful of it. I'm anxious about it. I'm frustrated by it. How do I feel? You know, I feel isolated by it. I feel incapable. I feel vulnerable. I feel like my world is getting smaller. And I don't want this to happen again. Well, I'm going to learn to avoid things that hurt. I'm going to avoid things that did hurt, even if they don't happen again. So if a dog runs towards me and I step backwards and that hurts, I'm never going to let that dog run towards me again because that hurt. Oh, it didn't hurt next time. I don't care. I remember that it did hurt. So the consequences of being left in chronic pain are diverse and expansive. So we have our physiological, physical, cognitive, and emotional consequences of being left in pain. Physiologically, we've got the stress response. If it influences our gastrointestinal system, our cardiovascular system, our immune system, our tissue healing. If we continue to stay in pain, physiologically, it has a massive impact on our body. Physically, we start trying to offload the area that is painful. So then we can get disuse atrophy. We start overloading other areas, and that can lead to compromised function, reduced mobility. If we're starting to get compromised function because of muscle mass diminishing, muscle mass shortening, we're going to lose our abilities for power, agility, balance. All of these that are part and parcel to a healthy musculoskeletal system are going to be influenced, and we're going to become vulnerable. We're going to be vulnerable to slips, trips, falls. But how do we feel about it? Well, I'm fearful of it. I want to avoid it, and I'm going to take on strategies that mean that I can avoid it. But do you know, it's really tiring thinking about all of this, and I'm not thinking straight. You know, I'm in pain. I can't get my thoughts together. My executive functioning starts to diminish, and that's called fogging. And as I say, living in pain can lead to a massive emotional landslide of, well, this is really isolating me. Is this what I've got to live with forever? What happens if I never get better? So there's lots and lots of consequences to being in pain. And the areas that are beginning to get more interest, people are beginning to pay more attention to, fear, anxiety, I can't see at the bottom here, but functional impairment, etc., and diminishing capabilities. So not only does chronic pain upgrade the roads, those neurological pain signaling roads, and it also influences our emotional and cognitive processing. Chronic pain actually lays the foundations for a hypersensitive nervous system, and it increases physiological, physical, cognitive, and emotional vulnerability. So just sit for a moment. Chronic pain increases physiological, think about your anesthetics. Physical, think about handling, kenneling, think about their comfort, capabilities. But they're also their cognitive and emotional vulnerability. Think about their feelings in our vet practice being handled for a dental, for x-rays, for lumps, for bloods. They're going to feel fearful. They're going to be scared. They're going to be more emotionally vulnerable. So how does that look for us in practice? This dog has chronic pain. It's been brought in for a completely different reason. Maybe it's got scurfy skin, or maybe it's in for a blood sample for a thyroid check. So for the actual patient, handling, hospitalization is going to be really, really possibly more scary, you know, more worrisome. They're not going to behave how they should do. They're going to be aversive, avoidance. But for the team that are managing this patient, everything changes. Oh, go backwards, sorry. Everything changes. How we handle and approach them, how we hospitalize them and care for them. They may already be on multiple medications. How do we add more medications to an already complex picture? How do we make sure that we've got our pain in check for the procedures that we're going to do? Are we controlling them optimally, pre, peri, and post-operatively? And it really affects our ability to plan how that case is going to pan out. And this is obviously going to have a massive impact on the owner as well. If we're not 100% sure how things are going to pan out, their ability to plan, our ability to give them confidence and comfort with prognosis is going to be affected. So what we need to do as a practice, and one of the strategies I've been mulling over for a few years of how we can promote chronic pain to not being an outpatient only consideration. Chronic pain isn't only when it's severe. Chronic pain shouldn't only be attended to when the owner feels it's really, really important. How do we promote this really prevalent welfare concern to have more attention in the practices in which we work? Well, we're going to become OCD about it. And what that means is that we're going to become observant, considered, and we're going to get it done. So observant means that we're going to actually start prior to any animal arriving in clinic, just check back through the notes. Have they got a chronic pain condition? We're going to listen to the owner's narrative. Are there descriptors in what they're telling us to suggest that the animal actually has got a chronic pain condition, be it gastrointestinal, be it musculoskeletal? But we're going to be observing. We're going to really up our game at looking at the way that they walk, how they hang themselves, how they transition, what their reaction rates are. And we're going to look for signs that they actually could be suffering chronic pain. And we're going to start making sure that we don't do spot diagnoses and we do gentle, considered, thorough examinations. And start thinking about pain scoring, like Evie was mentioning, in that will we get to a point where any animal over the age of, say, 4 is starting to have a quick pain score assessment? There's pain screening tools for both cats and dogs. They're short questionnaires, only 6 questions in length. And if the answer is yes to any of the questions, then that means that something needs to be investigated. But considered from our OCD, considered means that we're going to start really thinking about our handling techniques. We're going to look at the environment in which we place them, the kennels, the floors, the X-ray table, the surgical table, getting them in and out of the building. We're going to also think about the routines. And these animals tend to need a bit more time, a little bit more patience. Let's not rush it. Let's not just try and cram them into our ops board. We need to consider if they've got an underlying condition that's going to leave them with a hypervigilant nervous system that's going to influence our pain management plans. It might be that our standard protocol of dexmedetomidine and methadone is insufficient, and we may need to say, well, actually, this dog would do really well to be on a ketamine CRI prior to this procedure, and it can stay on the ketamine CRI through the procedure, and they can actually even recover on it, because I know that whilst they're having an acute incident, be it induced through surgery, etc., that chronic pain hasn't gone away. It's not forgotten. It's beavering away in the background. And we need to think about how we can give our clients advice about these chronic pain conditions being lifelong and needing to be managed. And then this is something that I think we've touched upon through our vent. There's a lot of obstacles to these practice improvements. So we need to really strategically think how we could get it done. And as a practice, come up with a vision, come up with a practice. Everyone agrees that that is the way that we want to work. And underneath this vision and this belief that it's an important new approach, we can create our protocols. So it might be, as I say, pain screening on admission. If there's any concern about chronic pain, for reassessment, bring that into the actual kind of like management plan. Whereas musculoskeletal tends to get excluded as if it doesn't exist. It's not a problem. Make sure everybody's on board and work as a team. And come up with strategies of how to implement it, but then also acknowledge the people that are doing the implementation. I think we forget how the majority of people really respond well to reward. As a person in the team, and I've done more than my fair share, I'd love to be acknowledged for it. So I think practices, if they're interested in expanding their protocols and approaches, need to acknowledge the team players that are really driving them. So I did a little bit of a survey asking the CAM followers how many of them actually had experienced chronic pain. So their dogs had chronic pain, how their dog experienced an acute pain episode after being diagnosed with chronic pain. So this typical situation would be, say, a dog that had cut itself as a pup, but then at the age of 6, diagnosed with elbow disease, fulminant like osteoarthritis, on chronic pain management plans. Then they cut themselves again. Did they see a difference in their dog's pain state? And I didn't know what I was gonna get back from this. But we had a fair few questions. Before your dog displayed signs of arthritis, what potentially painful conditions had they experienced before? Please take the time to reflect on how your dog managed potentially painful conditions before. And 35, I feel they managed potentially painful conditions worse before they got chronic pain. And 23.5, I feel they managed potentially painful conditions better since developing arthritis, which is really interesting because that's goes against science. They shouldn't be able to manage it better if we're just looking at the nervous system. So I took the opportunity to just say, okay, interpretation of better, worse is strongly influenced about how you feel you coped. So how did you cope with your dog after they'd had chronic osteoarthritis and then they had something else happen? Was it you not coping because you're just worn down, or you were actually doing really well because you now knew how to manage pain? And that dramatically changed the figures when people stopped and reflected. And 56% of caregivers then felt, well, actually, take me out of the equation. I feel that they manage potentially painful conditions worse since developing osteoarthritis. Now, obviously, the conversation's been a bit primed, but it's fascinating. So the survey, as I say, is weak on so many levels. However, it does just start to develop interest in that if we don't attend to these chronic pain cases promptly and sufficiently, are we actually ensuring that anything else that ever happens to them is going to be worse? Horrible thought. Some people did say that they did feel that having developed osteoarthritis, it's almost like when they get something else now, it seems that it's much worse. But there's also, as I say, people that have been managing osteoarthritis for a number of years, they actually become better equipped to manage subsequent problems because they've kind of got the fear of being able to manage pain out of their system, not being good enough, not being the best caregiver, not being able to pill, not being able to stick to the dosing frequency. They've been doing that for years now. So they actually, when something else hits them, like, from the left field, they're like, no, actually, I've been doing it for years. I can cope. And it was interesting for me. We've been educating owners now for nearly 10 years, and I found this really fascinating that the people that were filling in this form seemed to really have quite a much better understanding about the pain system. Common sense tells me a pet with chronic pain would tolerate other pain less well. This sound saddened me, actually. This really saddened me. Bob shows very subtle signs of pain now. Wonder why. Why does he show subtle signs? Is it because they're not being attended to? I find I need to observe more carefully as he will be more prone to keeping his pain to himself. And I've found that others don't necessarily pick up on his feelings. That was just a little bit concerning for me because I was thinking, why would the pain be being more hidden, his behavioral responses being more concealed? But then there were other people that really did feel that having chronic pain because of arthritis, subsequent acute episodes, related or unrelated, were managed less well. But what we've also got to take note from this survey, and it really humbled me, is I asked the people that were submitting their thoughts and feelings to this survey, so what conditions do your dogs currently manage? And most of them had multiple conditions that they were managing. And these, this is just one: skin infections, ulcers caused by entropion. How painful is that? Corrective surgery, probably for skin folds, mammary tumor removal, ear infections, gastric bugs, punctures in paw pad. This is just one case. And it really humbled me to think about what caregivers have to put up with. So the struggle is real, and I put this because I struggle just to cope with life. Evie will actually agree with that. You know, just keeping up with daily chores. But, you know, actually thinking about if you have chronic pain, everything from that point is likely to become more difficult. The prognosis is likely to be worse. The experience is likely to be worse. It's pretty awful. So what I'm trying to say is we must consider a wider field of view of what it means to have chronic pain, even in acute settings and presentations. We must consider their sensitized system in an acute setting, be it handling, be it medications, etc. We must consider their functional and physical needs in an acute setting. So they're compromised. They've had consequences of being in pain. Can they cope with the practice environment? We must consider their psychological and emotional well-being in acute settings. That practice can look blinking intimidating. It can be noisy, the lights, the fluorescent flickery lights, the slippery floors, all of it can be very, very stressful. And we must consider polypharmacy and integrative needs. So many of these animals are going to be on multiple medications, and are they being assessed sufficiently? Polypharmacy is a complex beast. So what we need to do, guys, with regards to chronic pain in veterinary practices around the country, around the world, is chronic pain presence needs to make sure that we have proper planning and preparation preventing piss poor performance. So my proposal is that any acute attendance, be it, let's say, ear infections, dental lump removals, neutering, whatever that animal is coming in for, we should be aware if they've got another chronic pain-related condition underlying it, and therefore modifications may need to be made, both in handling, but also in the medications and the strategies that we choose. So I want to grab the opportunity to quickly talk about acute flares, because this is something that people don't know very much about, but most of the times that you see an OA case come into your practice, they're going to be having an acute flare. It's very rare that an owner will come to you and say, do you know what, I'm just being really super cautious and I think he might have slowed down just a little bit, but otherwise he's absolutely fine. They don't do that. They come in and they're like, yeah, he's been limping for 3 days. It kind of comes and goes, but yeah, sometimes it's non-weight bearing. You're like, oh my goodness. That we have to really consider is likely to be an acute flare if there's no other underlying cause found, such as nerve sheath tumor or osteosarcoma, etc. If we don't find another cause, then we can assume that that is an acute flare in their osteoarthritis. And there's no definition of what is an acute flare at the moment. There's many people working around the world coming up with different definitions and different ways to measure what is classified as an acute flare. Some are doing it on like numerical rating scales, some are doing it just on descriptors, some are doing it on functional capability. But unfortunately, the data is not going to assimilate well until all people agree on a universal kind of tool. But these acute flares, why do we have them? You know, what is the purpose of chronic pain, sudden acute deterioration? There's actually a belief that they have a homeostatic role right at the beginning. They're short in duration, not, you know, too scary in amplitude, and they're reasonably infrequent. And at that stage, are they actually resetting the joint environment? You know, having a massive inflammatory flush of that joint environment? Do they serve purpose? And I don't think anybody really knows at the moment. But over time, we know that they tend to get worse in duration, severity, and frequency until they're pretty much the whole time. So what role do they have to play? Are they involved in disease progression due to repetitive trauma, or are they actually a homeostatic reboot trigger mechanism? Or is it actually just a bit of both? But what we do know is these acute flares, from what people have been telling us, is they are often recurrent fluctuations in episodic pain of very different, varying frequency, intensity, and duration. And yeah, totally understand that. Again, data is still limited, but in 2021, they did do a more extensive survey, 744 people, 568 flares in 376 of them over 13 weeks. And what really stood out is that 13 exposures causing flares were identified. So there was 13 type triggers were identified on questioning. So it's 568 flares. When interrogated, well, what could have caused it? 13 possible triggers were found. 8 of them being physical related triggers. So overdoing it, playing too rough, walking too long would be the ones for us in our dog population. But 5 were psychosocial or environmental. And that's where people go, oh, the weather's changed. It's got damp. My joints always flare when it's damp. What's quite interesting is that the influence of damp, cold weather on the pain of OA was actually very weak when doing an odds ratio. So you wonder whether the pain deteriorates in damp, cold weather more because of their mood rather than the damp, cold weather. So is it the damp, cold weather affecting their mood, and their mood then affects their pain? Mean duration of a flare was around about 5 days. But what they describe these acute deteriorations, unpredictable, episodic flare, distressing and disabling and disruptive. So I just wanted to include about acute flares because I feel it's our duty of care to reduce suffering in the animals that we care for. And we know that unmanaged pain leads to escalating pain as well as all of those consequences. And I feel that we've got sufficient data now to translate what we know from acute flares in the human sector to that in the vet sector. So breakthrough pain is another kind of term interchanged with acute flares. They are actually different. Breakthrough pain really talks about pain that becomes greater than the management plan sent to control it. Whereas acute flares can be that they don't have any background pain management in place. But the WSAVA do recognise breakthrough pain as being a condition. And what we've got to do is think about how we can strategise investigating these acute deteriorations. Now, this is where we're at a disadvantage. So vets and vet professionals, our clients don't talk. And what we'll find from the human data about acute flares is the doctor, one of the first questions they'll say is, where is the pain coming from? That's, causing this acute flare. And the owner of the pain will say, well, actually, it's my knee. And my knee's had arthritis for ages. And that's where I really feel that the pain is coming from. We don't have that gift. So it could be that we have other things contributing. So we always need to make sure we do a full clinical examination. We'll come back to that. But I do feel that this acute on chronic, bear in mind the frequency of presentation in practices, all of these OA cases is, oh, he's got worse suddenly. That's acute flares. So if we know it's so prevalent, why aren't we including it in our strategy? Why aren't we sending them home with acute flare plan management strategies? So this is for the people that are saying, how can a practice be more profitable with me being more interested in pain? Where you can immediately say, well, every OA case that's diagnosed needs to have an acute flare plan. And when it happens on a Sunday night that their dog deteriorates, they know that they can give, 500 mg of paracetamol. They need to rest up. They need to kind of keep them on lead. And he's got 5 days of downtime before he's likely to start showing improvement. I think that should now be included in our management plans for these animals, alongside what we're going to do for the disease, alongside what we're going to do for the upregulated nociceptive system, and alongside what we're going to do for the consequences that they've developed because of us not being able to detect their pain. So this is like the new kind of mind map. What we're doing for the disease, what we're doing for this amplified nervous system, what we're doing about all the consequences of being in pain, and how can I best protect them in case he has an acute on chronic episode. But as I say, acute on chronic in dogs, cats, wherever, we do need to make sure that we are opening our minds to it being something else within the joint or associated with the joint or not associated at all, because our animals can't actually talk to us. So we can't be clear of where this acute deterioration is coming from. We do need to check. Nearly there. So with regards to these acute flares, and I talked about those triggers, 13 triggers were identified in 576 acute flares over a 13-week period. So another paper divided these triggers into 3 major categories: incident, idiopathic, or end of dose failure. Now, we can really influence incident and end of dose failure. So incident is they've done something, like Karen Perry was saying in a video, they're often, activity related decompensations. Well, what did they do? Was it appropriate? Was it daft? Is it going to happen again? Do I need to modify it? It might be that they've slipped down the back step, the owner's just got a new sofa and the dog thinks he can jump higher, because it's a higher sofa than the last one. It could be Granny come to stay and they took all the mats up because she slips because she shuffles her feet. Let's try and find what the trigger is so that we can then best avoid it in the future. Idiopathic, much more difficult. But end of dose, again, when we see these acute deteriorations, are we actually taking the time to really ensure that that caregiver is using that medication exactly how it should be done? And if they are, what we then need to do is start thinking about adding after that point. But first off, we need to make sure that the medication that they're on is being used appropriately, and modifications may need to be made. So another study, again, focusing down on this incident, because I think this is something that anybody in the practice can talk about, be you nurse, be you receptionist. If we know a vast majority of those acute flares are due to an incident, say 24, 72 hours beforehand, we can then have those conversations. We're not talking about drugs, we're not diagnosing. You as a nurse can go, right, let's think about it. What did you do? Right, I probably wouldn't do that. Let's do this instead. So of these 67 participants, they reported 54 flares in total over 30 of them. And the duration was extensively different between 2 and 30 days. But what we did find from this study is many of the cases were triggered by a high loading physical activity 48 hours before the acute event. So it really means that we should spend more time talking about these in practice. Identifying potential triggers are important in the management of flare-ups. Point taken. So medical strategies to try and control these acute flares. So these are what we do in the human sector to try and, avoid these acute deteriorations. So one thing they do is they get them onto longer term therapy, and that again applies to us. If we're using non-steroidals as a tickle and a poke, maybe the best thing is actually to get the dog on a daily intervention and give it for a period of time. That could be anywhere from 2 weeks to 12 weeks. We should certainly, like in the medical sector, think about discussing a flare plan and what to do if it happens. And we should also encourage them to avoid those triggers that cause this breakthrough pain. Now, we can translate that into veterinary strategies very easily. We can do caregiver education. We can encourage caregivers to be compliant with the medication by teaching them exactly what to dose, how to dose, when to dose, etc. But we can also teach the owner to be understanding that the disease is dynamic and reactive, and that they need to try and avoid trigger avoidance. They need to have trigger avoidance, sorry. So just something for your use, because we don't want to make your life harder, we want to make it easier, is this acute flare kit, which is now in the member zone, and you all guys, all of you will have access to the member zone. And it's a document, this one's for vets, but there is also one for caregivers. And it basically does all of the hard work for you. So in your OA clinics, you can briefly talk about acute flares, but then you can actually pass them on their CAM acute flare plan so that they're well equipped. And it comes with changed medication charts, changed exercise charts, and it comes with these amazing fridge magnet type things. So you can cut them out, laminate them, stick them to the fridge, so that everybody in that household is aware that their dog's having a flare up and plans have changed. Maybe they're being exercised less, maybe they're being fed differently, but everybody needs to be on board. Now we have all of these available, and Evie's going to introduce you to them later in the nurse clinic training section. But what we really hope is that practices will print these out, laminate them, ring punch them, and use them on kennels to make sure that these dogs that are here with chronic pain do not have that overlooked for the sake of the acute pain condition. So here's your 4-part strategy, guys. You're going to be thinking about, what am I doing for the disease? What am I doing for the amplified nociceptive signaling system? What am I doing for the consequences of current pain? And how am I equipping my owners to give them the acute flare kind of like kit and an acute flare plan? Just before I go, we always want to mention new resources. We've got this one out called the Young Dog Joint Care Course, and the aim of this is to try and help people not get into a pickle. We want people with young dogs to start paying attention to their dog's physical health so that they can identify the signs early and do more about it. If you get a chance, please try and scan this because you will be added to the member zone. If everybody's in agreement that they want to join the member zone, it might be easier if Evie just takes all your email addresses and send them to Blanco and put them straight in. Right, so that's the first one done. Woo! How many of you have thought about chronic pain in that way? Different way of thinking, isn't it?
Yeah.
And I think for me, that's a culmination of frustration of chronic pain not getting the attention it needs in practice. And I was thinking of what people's attitudes in practice already are. And then generally in practice, there's a lot of kudos about doing, you know, the pre-meds and the surgeries, and all the acute conditions take precedence. But those acute conditions are affected by the chronic pain. So actually, you're not doing as good a job as you could do if you choose to continue to ignore it. So it's one of my strategies to try and give you guys confidence to promote chronic pain management in practice. And a very simple thing that you could do is in your pre-med booklet. Everyone has a prep book, don't they, where you get your dosing strategies, your charts, you know, laminated sheets. Why don't you stick a sticker on it and put, has chronic pain been assessed? And see what the reaction is. And then when people go, what are you on? You can say, well, actually, yeah, I've been doing a lot of work on this, and our acute pain management plan is going to be heavily affected if the animal is already in chronic pain. So us, by doing a clinical examination and taking note of underlying chronic pain, it will change the way that we potentially do our pre-meds, our perioperative care, our post-operative care. Because guys, all we want to do is make sure that this dog goes home more comfortable than it arrived. You know, that's what we do. That's our job. So that is a potential angle of attack. And on that note, we're teaming up with the amazing James Hunt to offer practices a pain review. So he does the acute pain side. He'll come in and look at your pre-med protocols, your perioperative protocols, and he gives advice, and he also does shadowing. So he does this for some practices where you have a surgical list board. He'll come in for the day and he'll be circulating. You'll be like, what pre-med? Why did you choose this? What else could we have done? What do you want to do in this situation? Because he's a referral anaesthetist. So we're going to combine up, and he's going to be bringing acute pain management into practice, and then he's teaming up with me to do the chronic pain thereafter. So a practice could actually have the whole of their pain management practices reviewed in total. So that's another angle of attack to promote chronic pain management in practice.
Exciting.
I know, busy. Have people got questions? Did I go too fast, too far? Do
There was a
not
question from Charlotte that came in.
Yeah, so let me show, see if I can grab it quickly. I'm going to show you what that looks like. I think it's in this one. Right, let me share. So when you have central sensitization take place, and this nervous system is now beginning to amplify, become more efficient at signaling, it also can get confused, and it can misinterpret what were normally non-noxious signals as being potentially harmful. And that's what happened to my friend. So touch, temperature change started to be misinterpreted by the brain as pain. So her just having a piece of cloth running across her face would feel like someone with a blowtorch. And that is because the inhibition, there's like this prevention of crosstalk in the where we modulate pain. and that breaks down. So touch, temperature change can then end up being rechanneled to being interpreted as pain. And let me just show you what that looks like. It's called allodynia. So there is hyperalgesia, which is when noxious signals, so they are damaging, dangerous signals, they're interpreted worse than they were. So that's what we're describing for surgery. If that animal's got chronic pain, that surgery, they're going to be hyperalgesic. So they're going to interpret those noxious as worse. But allodynia is when non-noxious is being interpreted as noxious. And I'll just show you a video here. So hopefully you see Dottie. Go away. Stop it. So you can all see, same location as Gwen's hand is coming back to the caudal lumbar. You start seeing these behavioral responses. There's anxiety there. The ears are back. The yawning of the calming signal. There's the avoidance, the sidestepping. There's the skin crawl, and it's always in the same location. Now, all she's doing is touching, but that is being interpreted as painful. A big driver of allodynia, transient allodynia, is sunburn. If you think about it, if you burn your skin, then actually just touching the skin is super damn painful, isn't it? This is Jack. Subtle, isn't it? They don't talk to us. We need to be very, very observant. And in the current kind of clinics that we work in, being given the opportunity to do such a light examination where that animal is able to express itself and give you those feedback of, no, please don't, that hurts. Think about the busy prep room. Think of kennels. Think of the slippery floors in the waiting room. They just don't have the opportunity. So again, the merits of doing a chronic pain clinic is you can have time, you can have space, you can have comfort. They can actually relax, chill down. A mat can be on the floor. You can do a lot of narrative with the owner. The animal's relaxing, so then you can get a better clinical exam rather than this rush that we have. Cool. Any questions? We're a quiet bunch. The last ones were really gobby.
Well, weren't they?
They were really gobby. Like, we couldn't get rid of them at break times. We're like, right, need to go to the toilet. Give me a chance. What now, Evie? Are we gonna?
Well, we're actually on time for the first time ever. I know.
It's never happened.
Shall we take like a 10-minute tea break and then go from there?
Yep, that's good for me.
Yeah.
Let's get a coffee.
Yeah, perfect.
And then,
so
what are we doing afterwards? Have you got the agenda up to you?
I do indeed. So we have case reflection and game changers, and then it's my home to group problem solving.
Okay, so if we were to have till 11:15,
yep,
that means that we miss the case reflection and we still keep on time for game changes, don't we?
Yeah.
Cool. Okay. We will be back at 11:15. Sorry, I've got to run up to the house to get my coffee to get back down. But Evie, you'll be able to come back in a few minutes if anybody's got any questions, won't you?
Yeah, for sure. Yeah, I just need to go for a wee. Let me go for a wee and then I'll be back.
Wonders. I'm going to press pause. Remind me to start it again.
Yeah.
So this is pretty classic. You know, these are pretty classic stairs in a house. And they're often not talked about or attended to. And you know, many houses, dogs are allowed to freely move around the home. But this is the sort of thing that does actually happen. This was a conversation. This is a truthful conversation that I had a lady. I'm going to set the scene. That was like her staircase. She had a Westie, probably about 14, 15 years old. I was doing a house visit. She was there with her turned up collar, like a little round neck, blue, woolly. She had a good hair, you know, all tidy, pearl earrings. And I saw the stairs and I said, I can see you struggling with the stairs. Have you considered carrying him up so that he doesn't injure himself? And she said, yeah, I know, he really struggles. He's even fallen down the stairs a few times now, but I'm really worried about what people would say if I carried him. And I was like, okay. I really wouldn't worry about that. I don't think you need to worry about what people may think. To be honest, they won't even see. Oh, okay, then I'll do that. It was that simple. It was so insanely simple to just have the conversation. And that dog for months will have been trying to navigate these steep stairs up and down, risking injury, the fear, the anxiety, etc. All she needed to do was carry him, but she just didn't feel that she had permission to do it. And that's why I think we need to be a lot more descriptive about these household changes and less relying on people's logic. So we're going to talk about adaptation to the home environment, owner empowerment, and about owner education. This is our expectation pyramid. We use it as like an owner education aid so that they know what the journey that they're about to go on is. First of all, we identify underlying clinical concerns. We push to get a correct diagnosis. We manage their expectations that this is a lifelong, non-curative condition. We teach them that actually the vet is integral because they're the only ones that are allowed to prescribe and diagnose. You know, we're your friend. We're not the official. Pain control is central to everything that we do, and pain control comes in many different formats. Indirect pain control can be offered by preventing further injuries and also by weight control. Complementary therapies, diets and supplements all fit into the plan, but they're not the sole plan. And that's a big problem is a lot of people will think that they can just do one aspect of a multimodal management plan and expect it to work. But something that people forget is the rebuild. So the rebuild is there for us to say, rebuild the dog physically. So quite often they're late stage in presentations, so they are debilitated, they have functional compromise. But there's also rebuilding that new relationship that owner is going to have with their dog. So instead of throwing the ball, they're going to just carry the ball. Instead of playing frisbee, they're going to put the frisbee away and they're going to do hide and seek. So doing 12-mile hikes at the weekend, they're going to reduce it down to 4. You know, if we don't tell them about their changed relationship, they'll follow the path of least resistance, which is to go back what they were doing before. So we're going to talk about preventing further injury and how integral into the plan it is, not just physically, but also emotionally and psychologically. It features in our volume of influence pyramid, which is like our motivation pyramid. The major caregiver that often gets neglected is the owner. And we don't spend very much time teaching them about their role and how important their role is. And if it wasn't for them, we wouldn't get anywhere. So this is identifying what's in their control, identification, monitor, weight control, lifestyle, exercise. These are all within the owner control. Actually, what I do as a vet is right up there, right at the top. So by showing them that the volume of influence lays with them, I try to empower them to get to be part of the management plan. And I kind of acknowledge them and playing a key role. And without them, we wouldn't get anywhere. To make sure that they stick to their guns, they do what's asked. So the environment became a great interest to me when I set up my mobile clinic. I never planned to become an occupational therapist for dogs, but I have become because I did a mobile clinic going to people's homes for a number of years. And I just saw firsthand how many houses have major obstacles that the owners just don't identify. This is Rossi, had a right foot lameness. I went to their house, having had long consultations with them, talking about all of these management practices. Dog was not getting any better. I popped into their house just by chance, and they had a dog flap with a 2-foot drop onto a concrete patio, and then another 2-foot drop onto the grass. And the owner worked away from home all day. So the dog had no choice but to use that dog flap to go and toilet. Even though this dog was being lead walked, etc., we hadn't made progress. As soon as we started looking at those things that were really going to challenge that dog's joints, that then started making progress. This is Rolo. Rolo's a 14-and-a-half-year-old border collie. He was probably one of the most debilitated dogs I've ever seen. He had a carpal hyperextension bilaterally, complete collapse. He needed a pancarpal half-thoracensis, but also he was collapsed through both hocks as well. He was obese at about 9 out of 9. So it was a recipe for absolute disaster. I just didn't know how he had got that bad, and he was still going for vet visits. It was kind of like, how do we get into a position of no return? Anyway, he used to sit in the hallway, and they said, oh, it's because the carpet's warm. And I was like, no, it's because the carpet's got grip. Your kitchen floor is like an ice rink. And if you're walking on your fur, because carpal hyperextension meant that he was very, very walking on his antebrachiums, and he was also plantigrade in the back. As soon as we put rubber matting down, the dog came back into the kitchen, and they're like, now that's the dog's entrance and exit. That's where the dog goes to the toilet. So I had to navigate this ice rink every time. This is Monty. Monty was a 9-year-old short-haired pointer, and he was about to have an elbow replacement. They'd tried everything, but no one had ever been to their home. So even though he was on strict rest and he was lead walked, and he'd been lead walked for like 3 months for 10 minutes, 3 times a day, no one had been to their house. And as I knocked on the door, I heard him fly down 2 flights of stairs. And at the bottom of the flight of stairs, he hit tiles. There was a wall right in front of the bottom of the steps. He had to turn whilst hitting tiles with his whole body weight and gravity driving him. And as soon as I pointed it out, the lady was like, I can't believe I've been that stupid. I didn't even think. And I was like, yeah, it's that obvious. But it's happening all around the country. Right. So just watch that one again. Right. So he'd fallen down the stairs twice. That's why they asked for a house visit. He'd actually hit the deck on these concrete slabs twice. He starts off fast and then he slows down. He can't actually flex through his stifles because he's got end-stage stifle osteoarthritis because of cruciate disease. So he was having to swing his legs around. He started off with propulsion from the back legs, but as soon as that was diminished, he was trying to recruit his forequarters to drag him up. He needed a harness. He needed a support harness. He needed somebody to go up the steps with him. They weren't in the position to move house. This is a house in Brighton, and people do move houses. But by them making sure that the tiles was not slippery, a support harness with a handle, and guiding him up the stairs like a child on a stabilizer bike, and then bringing him back down, they minimized the risk of him falling and doing harm again. Acute lumbosacral stenosis, and well, pain medication wasn't working. This is a varnished wooden floor. These are black marble steps, 2 of them, into a black marble floored kitchen. The back door dropped down by about 1/2 foot onto concrete. Then you had to go up 3 steep concrete steps to get to the grass. Her bed over there was just one of those plastic bin beds, and it had loads and loads of toys in it. So they loved her. And that's how they thought that love was expressed, when she was saying, I'd rather go out the front door. Can we just go out the front door because there's no steps, and keep it, buy me a rug for Christmas, and bring my water bowl, my food bowl down onto where I'm comfortable. So everything that she needed was up in the kitchen, but she also had separation anxiety. So she followed the owner around the home all day, every day. and the owner worked from home. So that owner was back and forth, back and forth. So she was doing that activity that you just saw 30 to 50 times a day. That's not going to help at all. This is Millie Lutz. When I first saw her, I couldn't touch her. And I had driven, 40 minutes to go and do this house visit. And I was absolutely petrified that I just wasted a 40-minute drive. I'd lost, obviously, my consult fee. But I was like, do you know what, actually? Okay, so I can't touch her. I'm going to spend this hour and a half with the client doing education, looking at the environment, talking about her weight, talking about all these different lifestyle changes. And it was amazing because during that conversation, they let it slip that she didn't like pigeons. And what she really didn't like is she didn't like pigeons on the lawn. And what she would do is she'd run from one side of the house and slam into the glass doors at high speed to spook the pigeons off the lawn. And I was like, well, that's going to be contributing to the pain state, I think. Why don't we frost up the glass? So we bought that sticky back frosty stuff so you can't see pigeons on the lawn. And we put rugs down and we put some baby gates up. And within 2 weeks, I could go back and do a full body massage. So she, that is environmental modification at its roots. What did I not realize? I think sometimes something is so logical, it's too logical, and people just can't see the wood for the trees. It's, you know, you wouldn't want to be doing that to yourself. But I think because dogs don't tend to cry out with chronic pain, I think because they get on and cope, people assume that it hasn't hurt. Also, vets think like this. So our textbooks literally talk to you about all the different sources of, pain, the inflammatory mediators, the collapsed joint space. We don't think about the consequences of OA. We don't think about the physical changes that take place. And that's not just joint pain, that's reduced joint function, that's reduced balance, that's reduced power, that's reduced strength. Whereas physiotherapists are taught like that. So the arc of the flight of the foot is going to change. The distribution of load on the foot will change, leading them to be less balanced. They're going to have impaired reaction rates. They're going to have that poor balance. They're going to have less ability to adapt to change, to rebalance themselves. So physiotherapists are equipped with much greater understanding of how the disease affects the patient physically. And therefore, I believe that enables them to look at the environment and go, well, physically, they're not capable of doing that anymore, and we need to make adjustments. So let's just review what happens with osteoarthritis. We know that there's a degeneration of the normal structures within the joint. This pain causes reduced joint and limb use. That leads to that limb having a reduction, degeneration of the surrounding soft tissue structures. If they're not used, they will atrophy. So you don't have that same soft tissue dynamic stability around the joint because those tissues are becoming less functional. There's also that offloading, and it causes pain elsewhere in the body. So if you're painful in your right hip, you're going to throw your weight forward and you're going to take more on your shoulders into your neck, etc. And over time, that can lead to problems themselves. And then you get this central sensitization. So the nervous system becoming way more aware of the pain signaling and amplifying it. So what we're going to kind of focus on is what happens with osteoarthritis, so that you too can now logically look at environments and lifestyles and just go, that's just not suitable. So as I say, pain with the joint is painful, especially when used. The joint changes, so it becomes thickened joint capsule, poor joint fluid, restrictive bone gets deposited around the joints. So the joint function changes. And then the dog posturally shifts, so they put the weight elsewhere. So their posture changes to allow that weight shift patterning. And that leads to compensatory changes, leading to overuse, injuries, and further pain. The areas that are being used less frequently, to less degree, they atrophy. So we get reduced function and weakness. And we get that persistent pain, central sensitization. I've got mouth ulcers at the moment, so that's why I'm bit my mouth the other day. So postural and functional shifts, right? Let's talk about this. If you've got pain, localized nociception, you will have an uncontrolled reflexive reduction in motion. You can't stop yourself protecting yourself. Even if you're the hardest man in the world, you're still going to have a slight reaction, because that's how our system's been developed. Danger or damage, we have reflexes that take place to protect that area. So at the moment, as I say, the shoulder problem, there's certain motions that I can't do. I can do this. I can't do that. My shoulder says no. And I'm having to really think about how to do it. So we have this reflexive reduction in motion and load bearing. And that's through localized muscles activating and splinting the area so that it doesn't move in a certain manner. And that then leads to us automatically having these postural shifts and pushing loads elsewhere on our body and reducing loads in these areas that are splinting. Because we're therefore changing our load bearing, and in a dog on the forelimbs, because we're changing the load bearing, we're going to change our postural alignment to allow that to happen. You know, you're going to swing slightly to the left, slightly forward. That's going to change the curvature of the spine, and it's going to affect all the soft tissue structures that work in and around it. And this is going to lead to overworked muscles and underworked muscles. And that can lead to what we call an imbalance in length and strength. So instead of them working as a nice dynamic pair, they don't work so well together anymore. And that can then lead to further joint instabilities. The overworked muscles shorten, they are more prone to fatigue and dysfunction and become painful themselves. And the underworked muscles disuse atrophy. So they fade, they become weak, they become less reactive. So let's talk about muscles, these ones that are being influenced by the osteoarthritis. You get this disuse inhibition. So either reflex or disuse. And basically those things that can drive this disuse and reflex inhibition is either sensory stimulation, such as pain. So that causes that inhibition of muscle contraction in some areas. But you also, the sensory stimulation can be a fusion. So if the joint has got swelling in it, that can also lead to this reflex inhibition and disuse. The muscle fiber types, type 1, type 2, are predominant muscle fiber types. And type 1 are the postural stabilizers. So they're slow twitch fibers. They've got to be able to work long and strong, whereas type 2 are fast and dynamic. Now, type 1 muscle fiber types are more readily affected by disuse atrophy. So our postural stabilized muscles are the first ones that start to fatigue and atrophy. In these muscle groups, the extensor muscle groups are more likely to atrophy quicker than the flexor. And those extensor muscle groups are also postural stabilizers. So disuse atrophy affects posture first. And posture muscles are needed there for stability, for these movements, for these activities. So basically, with this disuse atrophy, we get a lack of strength, a lack of endurance, and overall just a lack of soft tissue function. Please remember, the reason that we want to try and identify these cases early and get them on an appropriate management plan is muscle takes double the amount of time of immobilization to recover. So it would be much better for it to just not happen. And we've also got to consider that these dogs will have comorbidities, associated issues that could delay that recovery even more. So age-related disease, etc. Remember about central sensitization, we won't spend too much time, but there's a number of things happening at once that creates this central sensitized state, which means a hypersensitive nervous system. Weight shifting is easily demonstrated in this, so normally we have 60 and 40, so 60 in the front and 40% in the back. So it'd be 30-30, 20-20. But if we've got pain localized to, say, the left hip, and that dog is now offloading, we'll be throwing more weight forward, maybe 80, and we'll be offloading hind limbs in total to 20, so it'd be 15 on the right and 5 on the left. And the body copes quite well initially because we've got amazing like resilience in our bodies. We've got compensatory kind of capacity. But over time, that creates problems in itself. And we start having shortened, non-functional, painful muscles in the forequarters, down the back, as well as around the hips. So now we get these dogs that don't look overtly lame. They're just totally lame. And these are the sort of pictures that we will see. These are the classic dogs that are coming into our clinic. We've got significant muscle mass loss there. We can see the femur, you know, so we've lost quads, we've lost hamstrings, we've lost gluteals, we've got this S shape where the dorsal pelvic tilting, where the hypaxial muscles, so like the iliopsoas attaching to the top of the femur, that's all beginning to shorten. We're beginning to protect this area here. Our stride length is shortening, etc. And you get this kind of S shape where you've got the rump is becoming more curved, and then the tail kind of has to over flick to go into its standard position. We've got cranial location of these hind limbs. We've got the forelimbs are set back a little bit because this dog's thrown its weight forward, so it's bringing its center of gravity back. But it could also be that it's got some elbow discomfort. It's trying to keep his elbows as straight as possible. But I should suspect it's throwing its weight forward. We've got muscle mass loss here over the shoulder blades. So you can just see the scapular spine there. Dog doesn't look happy. And then we've got muscle mass development. So this dog has got huge triceps here, developed a mane, quite wide and slightly supinating out through the front limbs. And this is more than likely because they're offloading from their hind limb, and therefore the forequarters is having to overwork. Muscle is developing, and that's therefore changing the lay of the skin over the muscles that starts creating these turbulent coat patterns. So the myofascial changes below dictate the lay of the skin above, and it dictates the hair follicle kind of arrangements. So you start getting these weird coat patterns.
I also had a dog that it had really tight myofascia and its coat actually changed colour.
Yeah, that's another one. So if you've got a lot of myofascial changes, myofascial adhesions, the fascia should be like cling film, really free and easy, happy cling film, slides all over itself. And it's a communicating system, a bit like the cardiovascular system, a bit like the endocrine system. Many chemicals go along these fascial lines, but it also is a communication system through mechanotransduction. So touch, force, movement travels down these fascial lines. And that fascia impregnates everything in our body. It gets even into like the kidneys, it gets into the bone, everything has fascia integrating into it. But fascia is a very fickle beast, and fascia gets upset really quite easily. And fascia, when it's upset, gets sticky, and it contracts and it shortens and it scars and it attaches. So you can find all of us will have fascial issues. I have a very bad back. But the skin should slide over the underlying musculature because of these fascial compartments. So between the dermis, the subcutis, etc., we've got fascial layers and different density. And over time, these fascial layers start contracting, changing. And that will then adhere, they'll start clumping. And what Evie's talking about is that more than likely the circulation to the hair follicles has been affected by adhesions, affecting the microcirculation, the lymphatic drainage, the nerve supply, etc. So it's probably not having the chance to epilate. So was it kind of a clumpy coloured coat? Colour change?
Yeah, it was an Australian Shepherd, and she was black, like all over her back black, and it went like almost like grey brown.
Yeah, so that's like old coat. So the whole hair cycling is being affected.
Yeah.
And I got to dissect a dog once that had that over its hind limbs. And as I was pulling the skin off the thorax, where the coat was shiny and it laid in the right direction, the skin just lifted off. But as soon as I got to that back leg where I had that clumpy coat pattern, I could not pull the skin off. Could not pull the skin off. Now, you will never know whether dogs feel what I'm about to make you do, but just pinch your skin and lift it. So pinch your skin and lift it. It's not very nice, is it? Now, don't just lift it. Now hold it and move your arm around your skin being trapped. It's not very nice. Now, we don't know because we can't ask dogs, but you wonder, you know, when they start developing these quite significant adhesions like that, movement must become really quite awful. Right. So something to remember, if you have osteoarthritis, you will always have pain elsewhere. There will always be compensation. There will always be other changes. And that's where the world of complementary therapies, lifestyle modification, exercise modification really comes into its own. So changes to the soft tissue surrounding the joint leads to proprioceptive disturbance. Here we go. They cannot cope as well with the environments that we place them in. They have not got the speed and reaction rates and competent reaction rates to adjust to that slippery floor, to manage that step, to stand over that threshold. Their skills to react to loss of balance are starting to diminish, and that's what I'm going to explain now. So go back to revision times, the sensory motor system. So the sensory motor system means all of the sensations that come into our body that lead to a motor output. So the whole shebang. And our somatosensory system, which gives us information about the environment from the external body, so somatosensory, that combined with our vision, our balance, is able for us to make the safe and necessary kind of motor activities. That's how we don't keep falling over, tripping over, stumbling. A motor response is basically a result of continually supplied feedback, response to the stimuli. So our balance, our vision, our hearing. And that's why when you close your eyes and you stand on one leg, you don't realize how much you rely on your vision to make all these pictures of where you are in space and time come together. But we have not only a feedback, but we also have a feed forward system. And this is because our bodies are always so close to threat. You know, we can do ourselves harm so easily, so blinking easily. Actually, having just a feedback system means that we've been exposed to the stimuli and therefore given it the opportunity to do harm. But if we have a feed forward system, we can anticipate potential stimuli and have still a protective response. So let me explain this. If I was to kick you in the knee, that force is going to trigger your mechanoreceptors. They're going to send a nerve signal that's going to go up to the CNS, but it's going to be more of a reflex arc. There's going to be an efferent signal that comes back down. It's going to activate muscles and it's going to splint that joint and it's going to stabilize it. So you'll immediately splint your knee to protect it. I'm going to give you a few minutes and then I go to do it again, but you splint before my knee and my foot makes contact. That's your feed forward. So any potential disturbance, we have a reflex muscular kind of response to prevent instability, loss of balance, and danger, basically. Now let's just talk about joint stability, because we know joint stability is crucial for joint health. And joint stability allows appropriate joint function. If we don't have good joint stability, we don't have appropriate joint range of motion. We could end up having the range of the motion of the joint going beyond what it's capable of, which can lead to damage. So we want good joint stability. And joint stability is dependent on not only the static measures, such as the joint shape. So we know that that bone slips in that bone and they're a nice snug fit, but also the ligaments and the capsule that surrounds that joint. They also create this passive joint stability due to geometry and structure. Whereas dynamic joint stability is reliant on the muscles that surround that joint working in harmony with each other, in perfect harmony to create the appropriate movement. But if those muscles are not working in harmony with each other, then we're going to end up having inappropriate movement. And muscles, obviously, it's not just about their function, it's also about their endurance and their strength of function that we have to consider. Now, all of that information from the somatosensory system has got to get up to our brains for us to be able to kind of make the right motor responses. And we have different categories of receptors within our somatosensory system, within our muscles, tendons, ligaments, skin, etc. And you can divide them into exteroreceptive, interoreceptive, and proprioceptive. And the messages, the signals that they are picking up upon to send on is based on force related, so mechanoreception, temperature related, or danger related. So we have these different receptors that transmit different kinds of information. We have an amazing array of receptors that are all kind of specific for what they're good at detecting, be it vibration, be it force, be it certain temperature. So this is where all the information collates. So our somatosensory sensations can be divided into tactility, and we have the ability to pick up difference between vibration and tickle and touch and pressure. We have temperature. That should say nociception, not pain. But I leave it pain because it gives me an opportunity to remind people that we don't talk about pain until it hits the brain. Conscious proprioception is also transmitted, and that's the understanding of movement and what you're moving against. So proprioceptors, part of this external sensory system that we're absolutely dependent on so that we have the appropriate motor response. Proprioceptors that transmit information about balance in space and time, they can be divided into different kind of senses: joint position sense, kinesthetic sense, and resistance sense. So they have the ability to say what is that positioning in relation to just static movement? What's their position in relation to moving body parts? And what are we moving against? We've got all these different specialized mechanoreceptors that can offer information about proprioception. And these proprioceptors reside in our soft tissues. These soft tissues which are either becoming compromised through overwork or underuse. But we know that proprioception is absolutely essential for our neuromuscular control, safe neuromuscular control. So let's just go back to our cases. This is muscle mass loss, adapted posture. This is muscle mass gain. So the soft tissues that have these proprioceptors in are changing. They're modifying. So I think we can assume that the proprioceptors themselves are changing, are modifying. So the signals about proprioception are likely to be skewed. So proprioceptive capabilities are reduced with muscle mass loss or muscle dysfunction. So that means we lose the ability to know how we're moving or what our position is and what we're working against. And in the absence of awareness, we're going to have effects against our dynamic and static joint stability. And we're then going to be very prone to trips, slips, and falls because of lack of foot traction and placement, inappropriate placement. So if we've got an absence of this joint position sense, we're going to have that reduced dynamic joint stability. We basically are going to end up with a complete lack of function, which means a lack of strength, a lack of agility, a lack of endurance. And we're going to have a lack of ability to cope physically. And now there is talk about the fact that proprioception loss can actually lead to OA. Because if we don't have the ability to use our joints within their comfortable range of motion, and we lack proprioception, so we're pushing them beyond their comfortable range of motion, and that then is going to lead to potentially degenerative changes because of inappropriate use. But this lack of dysfunction leads to injuries and damage. That creates more pain, that's more lack of function, that's more damage, and it's a negative cycle. Now, this is well demonstrated in this lovely old deer. You have a quick look at this video. So hopefully you could see there that there was the real, like, drunken gait. There was that loss of appropriate placement, the lack of balance. Now put that dog on a laminate floor. Put that dog on a laminate floor with steps. We're going to start to see struggling. And just imagine now you're on your hands and knees and your pecs are working really hard to keep your hands underneath your shoulders. But I've now changed your hands to woolly mittens. And you're really using your pecs to keep your feet from sliding out from you. So these muscles are going to end up being overworked. They're working stupidly hard. And then you do slip. And whilst they're contracting, they're forced into an eccentric movement, which is going to cause muscle damage. That's going to cause pain. It's going to cause inflammation. So we need to think about what is happening in this home environment, because a patient that falls regularly becomes one that requires a home euthanasia. And as I said, I think we really neglect how much we rely on aids when we get older. You know, mobility aids is part and parcel of life, but we offer nothing. I don't know of one practice that sells appropriate harnesses, thinks about any kind of adaptive flooring. I see practices still that use ball chuckers on their sales. I'll just sit there going, are you mental? But there's another area that you could really expand your practice turnover. So with all this in mind, about 2017, I realized I was giving a lot of lifestyle advice with absolutely no scientific backing. So I thought I'd go a little bit further and completely ignore all the cynics. And we found a tool that's used, it's well recognized in occupational therapy, and we adapted it. So I got a team of volunteers. Cam only had about 1,000 followers at this point. And there was 2 people from New Zealand and 1 person from the UK. I think there's somebody from somewhere else. And we adapted this tool. They did loads of research to try and find the most appropriate tool. Then we adapted it through surveys in our community. And we came up with a tool, a resource that you guys can print off and download and can be used forevermore. But joint protection in the human sector is widely recognized as influencing disease and disease management. And joint protection can include anything from assistive devices to modifying their activities to modifying the home environments. Joint protection is big picture thinking, and we don't do that, you know, and we really, really should. So there is evidence to support these joint protective approaches. We don't have anything in the canine sector, so we have to translate. And I think we're allowed to use evidence-based logic in this situation. But joint protection for us may look like this. Ignore the weight of the dog. So the ramp's good grip, nicely attached, seems pretty sturdy, nice and wide. Harness, so she could guide him up because he'd be unstable otherwise. So harness maybe with a handle. Bedding in the van, I'd probably go for a mattress personally, because these rugs can end up becoming all scrunched up and become more uncomfortable and a trip hazard. But that's joint protection. This is joint protection. So that is a help them up harness being used. And I think you can see the dog is super, super happy. Now, you might think to yourself, oh, but what's the point? It's just a moment in time. Those neurochemicals from that pleasurable event are going to last that dog for the rest of the day. You know, that is constructive pain relief right there. But the dog's doing it safely. So the Home Safe tool is 17 questions, and it's being composed into a easy to print off PDF. So you can print this out and you can have it in your OA clinic bags. But if you don't want to print it out, you can access it as a digital tool, and that is within the member zone. So if you want to use it yourself, you can print it off the member zone because you're a member. But if you want to use it digitally, I'm afraid you need to encourage your caregivers to join the member zone. Cam is looking at doing discount packages on member zone. So a practice could pay for like 100 sign-ups at a significantly reduced rate. That's what we'd like to do. We'd really like to give practices the opportunity to use the member zone to support their work. So get in touch if you're interested. So what does game changing look like? Well, we need to start thinking about the stairs in the house, and these are still stairs. They're just called steps. So when you talk about stairs, say stairs and steps. What can you do? Well, you can minimize access, you can support them having access, you can make sure that they're safe. Flooring, flooring, flooring. It just doesn't change. We still love our slippery flooring as a nation. Some countries are more reliant on it because of dust and dirt, but the UK they're proper into our laminates and our wooden flooring now. So you need to come up with strategies, and you will have pushback. And I had one guy who said, "I absolutely love my dog." I said, "Oh, I think we need to put some rugs down." He went, "Oh, just spent £3,000 on the parquet flooring." And I was like, yeah, the flooring will be there when your dog's dead. I didn't say it that badly, but you do have to be prepared for when you get some pushback. It might be that you park it and return to it, park it and return to it. Sometimes it takes me, 3 or 4 occasions before an owner actually really does take on board the advice that I've been given. Raised sleeping arrangements. I used to try and keep the dogs more like floor-based, but I realized that many dogs, they've been on that sofa for 10 years. That is their safe zone. That's their comfortable relaxation zone. So we need to think about modifying access. Bedding, can't stress the importance of bedding. And it's not just from the positions that they lay in so that they're comfortable, but also that we want them to get good quality sleep. And if they're in uncomfortable beds and they're not able to find the right support, and they therefore don't sleep, it's going to be harder to manage their pain from what we're learning in the human sector. Doesn't need to be a lot of money. You can easily make adapted versions. Don't forget the dog flaps. Again, very, very important in trying to prevent harm. And this is one of my cases. So this is Max Saunders. Now, I swear to God, with Max Saunders, all I did was rejiggle some of the pain medications, adapt the environment, and we introduced massage. And within 4 weeks, we were back to this. So you can get some extremely amazing results by just doing simple modifications in the home, looking at what they're already on, bringing in some basic, therapeutic interventions, game changing. 1 minute. I think she's gone. So modification of lifestyle is essential to optimal management of canine osteoarthritis, and our owners are willing. So this lady put a lift in her house because this was her last memory of her late husband, a lovely, lovely Rottweiler. This person put a chair lift in. They just took the chair off of it. And this person rebuilt their ramp. So owners are willing. They need inspiration. They need to actually have the importance kind of like educated. They need to, as you say, ideas, empowerment, reward. But these holistic approaches for self-management using aids and devices is really a strong player in human management of their own chronic pain. So you can see here non-pharmaceutical treatments for OA, thermotherapy, so that's heat, electrotherapy, so that's TENS, aids and devices, and manual therapy. So home and lifestyle and exercise are often overlooked and not very well educated upon. But vets are thinking to themselves, I've just not got time to do this. And that's one of the reasons that we created the tool. That's why we've got the member zone. That's why we've got the social media. We're there trying to say, look, you don't have to, send your client over to us and we'll help fill in the gaps, or use our resources, or train up your nurses to deliver the appropriate content. But I'm really, really strong believer that, environmental adaptation is as powerful as a non-steroidal. I really, really, I feel this firsthand, anecdotal, but many years experience. Another tool that we've got available in the member zone is the lifestyle tool. And this disc spins around, so you can click on different elements of the dog's life, and it gives you potential hazards and advice of how to best manage them. We've got all the booklets, and one of them, the very first one I ever wrote, was Household Hazards, Living with a Dog with Arthritis. Now we're going to move on to exercise, but just before that, I want to remind you that clients are doing as much as they can to listen to you in a consultation, but the truth is 40 to 80% of what we say will be forgotten immediately. 50% of what we say is also going to be remembered incorrectly. So you need to really think about the resources that you provide, maybe eke out how much information you give and when. Now, this is a very thought-provoking slide. We as a industry are always looking for the next best thing, the next best drug, the next best intervention. But when you look at the World Health Organization's 2003 kind of impact statements, improving human compliance to the medicines that we already have is likely to have a greater impact than any improvement in medical treatments. Now, I totally feel that we've already got an excellent toolbox, and I just wish that we had the skills to use it more appropriately. So owner education and then them concording with the treatment plan, them sticking to the treatment plan is likely to have a greater impact than any improvement in medical treatment. So bear that in mind. So this is another diagram from CAM. This is the overview of the treatments and who takes which responsibility for which treatment. So the blue triangles are veterinary controlled, veterinary supported interventions, and the green pie charts are very much about what the caregiver is doing. So it's really good tool as well to tell the caregivers that what you do is bigger than what I can do. This diagram shows that you overwhelm by blue triangles. So for the owner, they're looking really at observing and tailoring because they're making the decisions, they're changing the plan, they're coming to see you when they need attention. They've got to put these lifestyle changes in, be them environmental modifications or exercise. And then, as I say, they need to think about rebuilding a new relationship that meets the abilities of that dog. And that brings us on to exercise. Little and often is a phrase that's used hundreds of times a day in vet practices around the UK. What does it actually mean? And I've had a number of chats with owners and they're like, I don't really know what that means, but yeah, I'll just try and reduce what I'm doing and I'll maybe double it. I'll do it more often. So we were thinking, how can we actually give more information? How can we have a structure that actually helps owners with more information? And we came up with a PRR. That's proactive, reactive, and reflective. And the reason being is that we want people to exercise consciously. We want them to be looking at what their dog wants to do that day, is capable of doing, does do, and how they respond to it. So proactive, we have to admit that a dog with late diagnosis compared to a dog with early diagnosis are different beasts. So there's no way in the world we can create an exercise advice plan that's generic for all. But when you're thinking about a proactive, you have to start saying to the owners, well, you need to think about the time of the day you're going to walk, how often you're going to walk, the duration you're going to walk, the terrain you're going to walk on, the surfaces on that terrain, the activities that you do on the walk, how do you get to your walk, and the surrounding temperatures. You can add them constructive advice about changing the pace, doing transitions, sits, stands, lays, finding obstacles for them to step over with ease, not making it really complex. Balancing exercises, they could be walking on slightly uneven ground for a period of time just to really challenge their proprioceptive skills, etc. So it doesn't need to just be that plod around the block. You can spice it up, you can change it. Things to consider avoiding needs to be talked about, the repetitive forces, the high impact forces, the long walks far from home, and then fatigue sets in. So you need to be more of an advisor about, the avoidance necessities. Things that could be added that of like pleasure and happiness are like the shorter walks with a safari, with hide and seek, different challenges to keep you and your dog engaged and rebuild that rapport. Challenges can be added that do tax them physically, but if you're not sure whether it's appropriate, then avoid. But in physiotherapy and rehabilitation, beginning to add these challenges can really, really kind of ramp up the re-education of the system. So, it's not uncommon for physiotherapists to suggest doing stair walking in dogs that are debilitated, but they've obsessed whether they're capable, whether they're likely to do harm, and how many they should do. Whereas stairs wouldn't be appropriate for me for a dog that I didn't know how severe their pain was and how they're capable and what the stairs are like, if that makes any sense. So yes, you can add challenges, but you need to have a greater understanding of the like soft tissue biomechanics, the home environment, the caregiver. Reactive means put your phone away and actually look at your dog. And I'm the world's worst at the moment. I'm trying to do all my emails whilst I'm walking, etc. But looking at your dog for signs of fatigue, leg tremors, lagging, toe dragging, anything like that. And that's when the walk should have ended. So you need to reflectively change the length of walk the next day. So reactively, I've identified, he's really beginning to struggle. I need to get back to the car. Oh, that was 17 minutes in. Right, tomorrow I'm going to make sure my walk's only 20 minutes in total. And then you might choose to look at them in the evening and say, actually, that was still too much. I need to reduce it down again. So actions taken with regards to this reactive approach of being observant of your dog whilst walking is to come up with like a portfolio of possibilities. It might be that you just go back to the car. It might be that you're able, the weather's suitable, that you could stop, let them recover, and then you can carry on a little bit further. But action needs to be taken. And then, as I say, reflective. How long, how far, what were the conditions? How did it all pan out? Was it suitable? Are they left in a more vulnerable state than they started? Write it down, start getting a diary. So this is my dog Past. This is Holly.
Yes.
And that is Tess, the bull manic. And I'm just doing this because most people that know me know that I've got a bit of a problem with us lobbing balls all the time. And people say, well, they wouldn't do it if it hurts. And I'm like,
No,
well,
they don't.
no, they would.
No way, man.
Because Tess, a few months after these videos were taken, collapsed with cervical disc disease. And she'd had cervical disc disease, according to the surgeon, for a long time. It was her body had managed to kind of like manage it, but you can see she's in pain. So she's got nerve root signature there. That's that lameness. She is in pain, but she still wants that ball being thrown. She still is obsessed to have that ball thrown.
That's literally like my, oh, I was
What?
going to say that's exactly the same as my granddad the other day. So my granddad's got really bad OA. He's got muscle wastage on hind limbs, I was going to say, and bum. And he walks like his top half is pointing forwards. Yet he's still, we kept saying, stop, granddad, stop, granddad. We went to my brother's graduation. He was walking round and round Cardiff. And it really made me aware then that if someone really wants to do something, they will still do it because they want to still get that pleasure from it. And in the evening, he was done, like so uncomfortable and sore. He couldn't get comfortable, but he still kept going.
Yeah. We all do. My dad's the same. All of us are. But what we're trying to do, and let's think of what is our ambition with these dogs in our care, to give them the longest comfortable life possible. Clients will always say to you, I'll do anything, I just don't want them to be in pain. So they've brought their dog in, it's been hit by a car, and they will say, do whatever you need to do, I just don't want him to be in pain. Yeah, the same should be translated to chronic pain, but I don't think that conversation is had. So what our duty is to try and keep them as comfortable as possible for as long as possible for them to have a good quality of life. And if it means that we change some of these activities because we know it's really going to impact disease progression, I think it's a conversation to be had. And we got into trouble quite a lot with our whole ball throwing. I can promise you if I put a social media post on tomorrow, it'll kick off. We now have anti-ball throwing groups on Facebook. So they're anti the fact that we're anti, and they're going, please get a life. So yes, keep them moving, get them up and moving regularly, keep them moving in a safe environment. So this is my lovely Holly. She's wearing a harness with a handle. She's got a really pleasurable activity. She's on a really grippy floor. And she's up and she's down. She's got a really good dog bed in the background, lots of activity games, etc. And then this is another toy. So again, the rugs are down. This is just a cardboard box, screwed up newspaper, treats put in there. And she gets to root around and she's weight shifting, she's balancing, etc. Right. Any questions? So it's an area that I don't think that many people talk about. I think it's an area that's really neglected. It's an area that there's no boundaries. There's no prescription rules. There's no diagnostic rules. This is where you shine. This is where you get to be their best friend. There, you offer them practical, empowering information. Generally, caregivers, they like being able to do something. It needs to be affordable and it needs to offer benefit, immediate benefit. So I know my experiences when I've managed to get the owner to put down a couple of rugs, they start to see it helps, and then they start putting more and more rugs down, don't they? And then they start getting on a little bit of a bandwagon. And that's why we came up with the anti-slip tape, because I wanted to give them the tools to start the ball rolling. And what I found is that if I encourage them to put the anti-slip tape in a couple of key areas, they then would go, well, if I'm doing that, I might as well do this. Well, if I'm doing that, I might as well do that as well. And it's silly things like many dining room tables will have a rug under the dining room table. No one uses it. Let's take it from the dining room table and let's use it somewhere useful. People, another thing you'll counter all the time is symmetry. People don't like if it's not symmetric. So if you have a coffee table on a rug, but then there's a big slippery laminate between the sofa and the coffee table and the rug. If you say to the owner, well, why don't we just pull the rug closer to the sofa and we push the coffee table to the far end of the rug, they're like, symmetry, can't deal with it. But there's so many things in the house that can be really adjusted so quickly with really strong beneficial effects.
I think this is the point as well where you make a good bond with the owner because they feel like you're not
Trying to
making them
sell them
buy. Yeah, you're not forcing them into spending loads of money. They've already got the stuff at home. It's simple things that they can put into place and make a massive difference.
Yeah. Right, questions. I think I'm still nearly on time, aren't I?
Yeah.
Unbelievable.
You
Are there
already.
no questions? Come on.
Yeah, got one. From Helen, is there anything other than runners, carpets you would recommend giving the expense of these? Yes. Got
What?
lots of things.
Oh, then go for it.
I brought mine in with me, these things.
Oh, yes.
These are really good. It's like gym matting. They're like foam pads and you just like jigsaw them together.
Mhm.
They come in a massive pack from Amazon for like 20 quid.
So the expense fund thing is really interesting because that is people's kind of like reaction. So we're going to just talk about this in a few different areas. First of all, as said, they probably have got things in the house, things in the attic. Other family members have got a rug that they've put in the garage. I've come back to my parents with my 2 dogs, and in my bedroom, my old child bedroom, there was no rugs. So my dogs sleep on the bed with me. I immediately said to my mum, have we got a rug anywhere so I can put it on the floor because they're on and off the bed? There's nothing wrong with them, but I don't want them slipping. And my mum was like, yes, it's a rug in the attic. So I am up in the attic. So people do often have things laying around, but there's this aesthetic need. People want something aesthetically appealing. So sometimes I'll say to them, look, temporarily, let's just accept that it's not going to look beautiful. But as we see the benefit of it, then we can find something more appropriate. So you might need to counter their objection because they're thinking, oh, I've got an eggshell blue hallway and I really need to find a mat that's in keeping. You're like, just let's see the benefit first. So preempt that. The other thing is carpet shops often have offcuts. So if you've got somebody that really is low income, then they can get offcuts from carpet shop. There's a company called Splendid Pets that does rubber-backed rugs that you normally see in shops, you know, the rubber-backed foot wipey things that you come into a shop. They have them cheap. They're really useful and off eBay.
Charity shops.
Charity shops, yeah.
Lots of options.
Because yoga mats are really good, but I will be honest, the $9.99 ones, they don't last. They get claw prints in them. So they end up becoming quite tatty quite quickly.
Also, you'll be surprised, an owner that doesn't want to spend a lot of money in the vet will then spend £1,000 on rugs to match their house.
It's insane.
Yeah.
There are people that have recarpeted their houses.
Yeah. It's the people that you don't. I have one lady who she's just paid for her attic to be redone because she's working from home. She started seeing me and I said the dog can't do stairs because he's really unstable, and he tried with a harness and he didn't like the harness and things like that. So I was like, he really needs to stay downstairs. He's got separation anxiety. So she's just gone out and she's hiring an office space that is like no steps.
Amazing.
And she doesn't want to spend any money at the vet. So yeah.
Yeah, and I think that just captures the fact that owners feel that they can do this. When it comes to drugs and it comes to other things, it's disempowering. They have their control taken away from them. They don't know what's in the tablets. Their knowledge control's taken away from them. They don't know what dose they've been told. So their control's taken away. But this is where you give them the control back. And that dog's their best mate. This is their chance to do something good, you know, that emotional state. And we all have it. Like, so my dad's just had a stroke, and so I'm at home because that, and you can just see people going, I just want to do something to be helpful, please. And you can see people who, you know, putting up a handrail, doing this, doing the other. They're like, oh, I've done something good. And I think there's that emotion comes out in the caregiver. They feel that they've finally had purpose.
We've also got a question from Claire. What about raising food and water bowls? How do you judge how high is high enough?
Yeah, so this is, again, there's nothing in the literature to tell you exactly where. So the rule of thumb tends to be around about elbow high, but the real key is being proactive, reactive, and reflective again. So you create your station, and what I'd do is I'd start off just doing a pile of magazines, because then you can choose the height by removing the magazines until you find the height that's really comfortable for that dog. And then you can find the appropriate alternative if they don't want to carry on with the magazines. But you're looking, I'd pitch it around about elbow height. But what you want to be able to see is they do want to lean from their shoulder blades slightly forward. So I was messing with Luna the other day, and I put her food bowl just a little bit higher. And you could see that because her neck was straight, she then really had to arch from the occipital atlanto joint, you know, from here, she had to really crane her neck round. Whereas if I had it a little bit lower, she could actually do the bend throughout her cervical spine rather than trying to anchor point there. So it's about bringing it up where they're stable. So with the owner, does the dog look stable on all four limbs so that they're comfortable whilst they're eating, that their body is passively stabilizing itself so they can eat? They're not having to think that they're unstable. So that needs a mat as well. And then you want to see them being able to move their mouth in that bowl around the bowl. But as soon as they do that, they can't do that. Do you see what I mean? So it's slight slope to the neck so that they can then navigate around their bowl with that atlo-occipital joint there. So elbow height are around there. With regards to bloat, so the jury's still really out whether raised feeding can lead to bloat. I don't feel that the evidence is conclusive, because there's one study that says no, smaller in number, then there's another larger study that said potentially yes. So what I do is I say to people, well, everything in life is benefit risk, you know? And for me, that dog eating on the floor twice a day is really struggling because it's having to get to the floor because his elbows are not bending. It widens through, and that really hurts. Widens through his shoulders, has to turn out his paws slightly, and he has to kind of lean forward. You know those Christmas games where suddenly somebody brings out like the cornflake packet game where you have to start trying to do the splits to get the cornflake packet off the floor. Do you know? Am I talking?
No, I do
Not-
know that.
Yeah, what's the other one? Limbo. What's the limbo? No, what's it one where you
Limbo.
want to- is it limbo?
Bend back and then
Yeah.
go onto the pole.
And how awful, because we don't bend like that. It's the most horrible feeling, isn't it? You're like, oh, I'm gonna do that to you twice a day. Oh, thanks. That's great. Eating's the only pleasure I have, but now you've put it in a place that it's going to hurt for me to get there. So when I talk to my owners, I'm very much, look, let's be pragmatic about this. The water bowl is safe to be raised, so we can raise the water bowl. The feeding bowl, shall we not raise super high and we make it a puzzle feeder, so we slow down the rate of the meeting or something along those lines?
Can I just ask something about the bowls? Is this appropriate for all dogs with OA? Like, if, for instance, if there was a dog with hind limb OA, are we assuming that because of the compensatory habits that you've discussed, that there will be pain around here as well, or yeah?
So when you think about it, like whoever, we're going to go beyond. Evie's used to this, but whoever decided to feed dogs in bowls on the floor, where did that come from? I think it came from convenience. I think it comes from convenience to us. Would all dogs, no matter with or without OA, prefer to actually not have to spend time with their head right down the floor? Probably. No, actually, when you think about it, would they also like a raised bowl? But yes, what we basically do is a suggestion and say to people, your dog's activities of daily living are what keeps them happy, keeps them, being the dog that you've got. That's what provides them purpose and quality of life. But if these activities of daily living become really challenging, then you're really affecting their quality of life. So these minor adjustments, put them in place and see, watch them, observe. Everything in OA, everything in anything doesn't come with a promise. You could be treating Cushing's, you could be treating cancer, you could be treating OA, and your treatment intervention should work. I've clinically reasoned it to work, but it doesn't work. So the same with this, you could put the bowl on, a pile of magazines and the dog just hates it, just does not want to. So it is a real big trial and response. And that's why I quite like the idea of saying, look, before you throw a load of money at this, let's just check that it's the right thing for your dog. Any more questions? What we're trying to do throughout the day is, because we've got lots of topics to cover, is to also link them into CAM resources already written, easy to immediately use. Because what I tend to find from CPD is you go and you listen. Like, say I go to a congress and I've gone to 8 different lectures and I've made notes that I never read again. I don't know why I write them, but you make these notes and you come back into practice and you feel like you suddenly chokehold. You're like, I don't know how to take what I learned into practice. You just told me to, I don't know how to do that. So all of what we're doing, there are CAM resources that you don't need to write, you just print them off, or you at least know where they are so you can signpost people. What's next on the list, Eve?
Next on the list is identifying chronic pain early, or the build. The build next.
Oh, it's the build. Okay,
Build.
so they have to talk. How long have we got? 10 minutes for the build?
Well, it's scheduled in now to the competition. It's my home 2 group solving, problem solving, till 12:30, which is now. Then we got the build, but we don't start identifying chronic pain early until 1 o'clock.
Okay, so we've got basically 25 minutes and we can do what anybody would like. So option 1, the build, is to now start talking about all the problems that you're having, the obstacles, and start trying to come up with some solutions by sharing what each of us have done to circumvent them. Or we could look at some people's houses. This is what we were going to be doing with the It's My Home Too. I can share with you the It's My Home Too tool so you can have a look for it. And then you have an opportunity to look at the room that you're in, the house that you're in, and start going, okay, oh yes, I see. Or we can start identifying early and get to lunch quicker. Totally your call.
Everyone's shy today.
I'm going to get Claire to decide. Just typing. Yes, her microphone's not working, is it? I'd like to look at houses. Okay, right. So what I'm going to do, I'm going to share the It's My Home Too tool with you. Let me just get it up. Right. We do this. I share. So hopefully you guys can see the website. So within this website, you have Member Zone up here. Just so you know, there is everything that you could ever want to know about arthritis to some degree.
Yeah.
And if the topic isn't in great depth here, there's going to be a Facebook Live about it. There's going to be a resource about it. So if you go into managing arthritis, for example, and we go down to what can be done, we then have the intervention pyramid. So owners can actually, home environment adaptations. I need to get rid of you guys so I can see. That one's, I need to get that checked out. That's not playing very well. But basically, there is the website version where you can send them here. Trip hazards, sleeping area, access to furniture, etc., etc. Or in the member zone, again, we go down to downloads library. And in here is all the downloads that you could wish for. And we're adding at least one big one every quarter. A new one, we've just done a claw care handout of why keeping their feet maintained is really important. This is a really cool tool. This is our prescription pad. So that vets, knowing that they've got quite a lot to cover in a consult, can actually just fill in this prescription pad. And what's beautiful about it is 2 sheets of paper. There's this, what brings your dog happiness? So if they are really in palliative care and they're on polypharmacy, they're really limited, you know, their independent mobility, let's start talking about what other things keep them emotionally healthy. So that's a tool that's it's been about 6 months, I think we've had that. But in here, dog enrichment a pack as well. So these are games and activities that they can do that require less independent mobility. Puppy guidance. So if you've got a young dog and you're doing puppy clinics, you want to start talking about them being able to protect their dog's joints from a young age. But you want this one, home assessment tool. So home assessment checklist, you can print it out, but it is 11 pages. And it asks, are there slippery floors? If yes, consider. Stairs, yes, consider. Thresholds, yes, consider. So basically there's 17 questions like this. If they tick yes, then they need to consider adaptions. So that is available for you. Stop share. And then there's the household hazard booklet as well. I can share that one with you. That's actually a real goodie. Here we go. Let me go back into here. So member login. And if you go down to CAM booklets, there's all of these different booklets now. You go to this one. Oh, we have to download it. So 32 pages. So your practice probably doesn't want to print them out. Doorways and thresholds can be really challenging. Dog flaps. And then I offer some simple solutions. Gates, anti-slip tape, support harnesses, ramps, stairs. And these are all photos either that I've taken or our caregivers have submitted. That's my lovely Holly. So this booklet is available as well. What we would love is if practices would buy bulk loads of these booklets, that's what they would develop for. And what we were hoping is that practices would go like, I'll have 100 of them, 100 of them, and 100 of them. And that means that you could make 100 kits, couldn't you? So you have your practice bag, you have the It's My Home 2 printed off, you have the household hazard and the OA Bible, and you have an anti-slip tape. And your OA clinic is 45, 50 pounds because you're going to spend half an hour with them, but they get a takeaway. They get things to actually put into practice at home. That's the plan behind it all. Claire, what else would you like to know about houses? If you're willing, if you've got a camera phone, we can do your house. Oh, Evie, we could do yours.
No, we can't. Mine's not in a good state at the moment.
I'm hiding the kid in the bedroom from the kids. Okay, so I'm going to do an imaginary house. We're gonna I'm going to talk through one of my mobile clinic kind of like protocols, strategies. So get out of my car, and I would tend to park actually either on the road near the house or I'd be in their driveway. But as soon as I got out of my car, I'd be looking. I'd be looking at what car they drive, access points for the car. I'd be looking at the driveway. I'd be looking at the front garden. I'd be looking at the front steps. And as soon as I arrived, my opening statement was, promise you, I'm not casing the joint to rob you. I'm just looking at obstacles in the environment because part of my service is to make sure that I support your dog in your environment. I've just kind of walked past. I can see that you got this 4x4. It's quite high, that boot. Is he jumping in, jumping out? Are you lifting him? Do you have a ramp? How is he accessing it, that vehicle? That opened that conversation. I'd still probably be on the front steps. I'd be like, so these front steps are actually quite challenging if you're mobility restricted. Can you see how much I've had to step up? And do you see that, you know, your dog's 14, so his vision's going to be impacted a little bit. And this grey stone of the step is exactly the same as the grey stone. So I'm not sure that he'd be able to figure that out. And I'd then say, can you see here, we've got like this PVC door frame, this white plastic frame, the threshold that you step over, that's quite wide. And I bet you what he's doing is he's not able anymore to step over it because that's quite a large stride length. Does he occasionally pitch his foot on it? Yeah. Does he slip? Yeah. Right. So this is where you can get some anti-slip tape. So this is this clear, colorless. You can stick it on the white plastic. It comes off, you know, when you don't want it there anymore, but it just gives them traction because they haven't got the capability to step over anymore. So what we've got to do is think of how we can make it safer. We don't want him having his legs slipping away from him. So that's how I'd probably start my clinic. Then I'd go in and I would still be Miss Snoopy. I'd be in the hallway and I'd be like, oh, have you got any rugs? Or no, I'd be something, I'd say like, how have you found him on the floor? Do you find that he's beginning to slip, or do you hear the clickety click click of nails? And they quite often be like, yeah, we hear the clickety click of nails. Haven't really seen him slip. And I'd say something along the lines of, should we just see him come in? Let's see what happens. And I can guarantee you about 50% of the time, the dog would run in to greet me and its back leg would swing out, and she'd be like, oh, like, yeah. And then I would always say things like, don't be offended. I've been doing this for years. This is what I'm trained to do. You're not trained to see these things. But now that we've noticed it, we've got to try and think about what we can do to remedy it. And then I'd go through the house and I'd say, don't think I'm being too nosy, but just let me know where your dog spends most of their time. Can we go out into the back garden? Oh, it's quite a big step down, isn't there? Does he do this on his own? Is there any lights? Does he do it out in the dark? And then I'd lead on from there. There's definitely scope for OA clinics to become mobile again. And what we're doing at the moment, we're experimenting. Everything, everything to do with arthritis in the vet industry is so go slow. It's painful. Because I set up CAM, as I say, back in like 2015, and it's only now that we're really getting traction. It's been 8 years, 9 years of just plug. But we've set up a tele-guidance service. So me, Evie, Dr. James Hunt, Dr. Katie Smithers. Because when you think about what you deliver in an OA consult, most of it's verbal advice. There's actually less animal handling than you can think of, you know, unless you're bringing laser into it or PMF or acupuncture. These reassessments, quite often, you look at the dog, maybe a quick palpation, and then it's discussion, isn't it? So why can't that be done as telehealth? And then you can actually achieve a lot more by reviewing videos together. So if the owner's already taken the video, you can then look at them, slow them down, talk about the video together. You can still look in their house. So they're generally on an iPad or an iPhone, aren't they? And you can take, you know, have a work around the house. You can see where they exercise, and you can do a lot that way. So that's what we're up to at the moment.
Hannah?
Yeah.
These home modifications, are these for not later stage, like very debilitated, but are they for when there is quite clear arthritis? How ahead of it, you know, when you're talking when they're 7, 8 and seeing very small behavior changes, how are you going to convince, is it even, do you need to convince them to make these adaptations when the animal in their mind isn't showing signs?
Okay, so it goes back to a similar thing with the bowl. So there's daydream Hannah and there's reality Hannah. So daydream Hannah, dogs were never designed to live in our world, not in our houses, not on our slippery floors. They weren't designed to do that, you know. It goes back to the bowl. Whoever said that they should eat out of a bowl on the floor? So a lot of these things that we expect them to do daily, even when healthy, are they necessarily appropriate? And I'll illustrate this. My friend Rupert, who's richer than stink, he's got a massive house and he's got like a big head staircase that comes into this big open section. It's this mahogany floor, whatever. And he's got Ruby, the lovely Springer Spaniel that he's had since she was about 3 months old. And she flies across the floor like a bowling ball, you know, on one of the bowling rings, you know, they she drifts as a dog around that house, and she slams into cupboards, she stumbles into the sofa because she has no grip whatsoever, and she's a Cocker Spaniel crazy. I've tried talking to him about the fact that that house flooring is not suitable for her personality, her breed, and would he consider putting rugs down because she's going to hurt herself? And it's no, just no. So daydream and reality are two very different things. I think if daydream land was around, I think we'd still be on carpets for dogs because it offers them the ability to have traction. And I think we would encourage activities in the house that aren't so ridiculous. You know, do you Do you remember in COVID, people were getting dogs to jump over toilet roll walls? Do you remember that? And they do it in the hallway, and you see these dogs come flying over these toilet rolls and slip. Yeah, I would be like, what is wrong with us? But in reality, it's very, very caregiver dependent. And you have to really use your human skills, your communication skills to read body language, verbal language, know when to push, when to back off and wait. So for example, when I used to do my house visits, I would say to them, I need to get you to sign up for 3. They'll be a week apart. We'll do 3 in a row. And I knew that that was because it gave me 3 opportunities to do my massage, but it was also 3 opportunities to get them to make the house changes. So week 1, I'd point them out. I'd go back week 2, nothing had happened. I'd go back week 3 and you'd just start to see a few of the changes. But you have to really, you've got to trust your gut on how you push certain areas and back off. It's like driving a car, the accelerator, go a bit, nah, put the brakes on. Go a bit, nah, put the brakes on. And then you need to make notes of where you've got in your conversation. So something that's really bad about OA is we write shit clinical notes about it, don't we? The notes on the computer are embarrassing. It'd be like it's got OA. Where? How bad? What's he having? What plans have you got in place? But if you've got a client where you're just drip feeding, it's worth making a note of where you're winning and where you're not winning so that you can come back to it and approach it again. So with the house changes, it really is a go slow. It really is. How do you do it, Evie? Do you find that they're receptive, or do you do it as a real test and see?
It's really dependent on client to client, and also I think practice to practice as well. Like my clients, the way that they're receptive about things is going to be different to what your clients might be, Hannah. Like they're whatever part of the world you're in, I think it's different. What I tend to do is just don't go in with everything all at once.
Yeah.
Just give them 3 or 4 things to change. Because if you go, right, well, you need to put rugs down, you need to change your door thresholds, you need to change the steps out to the garden, the gravel coming in to your house, things like that. They're like, what the hell? Like, I haven't come in, like, I don't want to change my whole house. Whereas if you just start with a few little things that you think are like the major points. So jumping on and off the sofa, putting a carpet down, that's a massive point because the dog sleeps on the sofa. Let's put the dog spends most of its time in the hallway and the kitchen, so let's make sure that the floor in there is completely okay, and let's raise the food bowls. That's the first session. That's all we need to do. And then next session we might check in, make sure that that's been done, and then create goals for the next time. Because I think it's the same with when you're doing them exercise plans and things like that. If you give them too much, they back away because it's too much.
Yeah, definitely. And do remember that all of those tools that I've just showed you, the printouts, are there because the branding, the strength of branding, that somebody else has said it, the big company has said it's important. Rely on that. So it's in your pack and you say, look, there's a lot of things that we can do to support the comfort of your dog, as well as potentially slow the progression of this disease. Don't forget progression. If they are slipping, tripping and falling, they're going to progress the disease, be it the joint or the surrounding soft tissue. So if you say there's lots of stuff that can be done to make them feel more comfortable, feel more safe and secure in their own environment, but also potentially slow the progression of the disease. However, I don't want to overwhelm you. There's a really good resource in the kit that I've just given you, 17 questions. Look at those questions. There's also stuff on the website. So sometimes it is easier to deflect through a strong brand professional appearance that they don't feel is trying to sell them something.
Got a couple of questions. I guess we could do the same. Ask the client to provide us with a video tour of their house. I've had to provide one recently for a rescue centre home check. Yeah, I do that a lot of times with my clients is get them to bring in lots of videos. And that's normally what our first consult together goes through, is all the videos that they've collected of the dog moving around the house and the house itself. So yeah, that's a really good idea, Claire. Do you get your exercise plans from your physio? So I'm really lucky in the fact that I have a physio who comes into my practice. So we basically run it that the physio rents a room a bit like a hairdresser rents a chair. So we work closely alongside the physio and do and work out exercise plans for the patients that we're seeing. If you don't have that and you don't work alongside a physio, there are a lot of exercise courses that you can do to further your knowledge in that. But yeah, I wouldn't be prescribing any exercises until you've had further learning in that area.
Yeah, I'm just going to expand on that. The PRR is because I would suggest 95% of the client population will not want to do that. They will not want to have a targeted exercise plan. There are certain dog owners that really engage with it, and they will do it to the button. The majority have lives. They've got other people at home. They've got kids. They've got their granny living with them. They've got work. What we can do is help them do their exercise more safely. So I would say most dog owners in the world, no, actually that's a total lie. Many dog owners in the UK believe it's appropriate to walk their dog twice a day. Some are unlucky and it's once a day. Some may be lucky and have it 3 times a day. But I think the national average would be take the dog out twice a day because they pee and poo, that sort of thing. So that's what we're working with. So I would start off with the PRR and think about what you're going to do with your dog. Just make sure that it's suitable for your dog. Watch your dog whilst they're exercising. Be comfortable to rein it in. Be comfortable to bring the walk to a close and come home. And then just see how they coped with it. Now that's a really easy conversation to have. And if they engage with that and they get a bit of a buzz about it and they talk back to you about it, then you can go into targeted exercises. But most humans, this is fact because I had to do a project about this. Something about, I think it's like 50% of people don't stick to physiotherapy plans for themselves. They only stick to it in a very, very short term. I'm a case in point. I should be doing shoulder exercises. Have I done it today? No, I haven't had time. Am I going to find time to do targeted exercises in my dog, especially if I don't see the degree of discomfort they're in? I've got pain and I'm not doing it. I haven't got my dog's pain. So am I likely to do an array of targeted exercises? So do not beat yourself up if you're not getting your clients' dogs onto targeted exercise plans. It's just hard work. It's really hard work. If they are interested, as Evie says, there's some really good courses out there now. But I think one of the brilliant things which would bring income to the practice, and we'll explain about this hairdresser concept. So we work in a vet in Tamar Vet's in Cornwall. And my boss was expecting me to be able to do a chronic pain consult and offer all of this advice. And I just didn't have time. My love is doing massage. I don't have time to do that at work. So I said to him, I know it's a missing part of the plan. We're not achieving it. Why don't we get an external therapist in where they can concentrate on that aspect? No loss to the practice, none at all. Actually, a bit of a gain to the practice because that room's empty a lot of the time. That part of the practice, that room, you're going to get a commission. So every time that room is used by that physiotherapist, they're going to pay you a portion of their fee. So I think it's 15 or 20%. 20%, Evie? Tanya pay? Yeah. So say she charges out at £60 a session, the practice will end up getting 12 quid for a room that wasn't being used. Many physiotherapists are quite happy to work in the evenings or that quiet time in the afternoon. Yes, the practices are getting busy, but quite often practices will have quiet times where the rooms are empty and you can bring money into the practice. The clients that go into a kind of physiotherapy within the 4 walls become extremely loyal. They become very loyal. And then there's more opportunity to sell food. There's more opportunity to sell drugs. So Tanya would often pop her head out the door and go, he's more painful today. Can we up his meds? What can we do? And that gave me an opportunity to upsell. So I changed the drug plan. So the practice is still benefiting all the time. Get regular weigh-ins as well. So the physio will be doing the weigh-in. That's food opportunities. So if the dog's not losing weight and the vet's tried and the physio's been inspiring them and they still are not losing weight, do you know what? We're not shifting this dog's weight. I think we're going to have to accept that we're going to go onto a prescription diet to get this weight coming off, and then we can go back to its normal diet if we hit target weight. Having a physiotherapist in-house opens many financial avenues.
They also become like a stepping stone between the client, the vet, and you, because they're not a vet and they're not. I don't know what it is in clients' heads, but as soon as you say you work in a vet's, it's like, oh, you're going to take all my money from me. Although they're still paying for the physio, they tend to listen to them more and create more of a bond with them. And then it makes it easier for us as professionals to work alongside them.
Yeah, it's a really good addition. What courses? So if you really have not great musculoskeletal knowledge, I wouldn't jump straight into an exercise course. I would actually think about doing a rehabby type course first. And you can get different ones. Vetquinol was doing a course for nurses. I don't know if it was successful or whether they've shelved it, but there are some more simple ones like Key Steps Online, CPD Solutions. I know my friend Emily Ashdown did a online modular physiotherapy course, and they're not there to make you a physiotherapist, but they're there to give you a much greater understanding about, you know, soft tissue work. And then from there, you'll be more capable of being able to, you know, design an exercise plan. But there are courses solely focused on exercise. I've got one that I'm on that I actually haven't looked at for 2 years now. I've paid £1,800 and I still haven't got around to doing it. But yeah, so Northeast Seminars, they do the CSSC one, which is an exercise course, but that course, as I say, is like 1,800 quid. So do consider that as well. How are we doing? More questions? Got a hand up from Lana. Oh, maybe it was an accident. No, sorry, I didn't mean to do that. It's all right, don't worry about it. Okay, so we do early identification and go into a lunch break, yeah?
Yeah.
Okay, sure. Let me find the presentation first. Okay. Identifying pain. Cool.
Yeah.
So we just have a little brief tangent about cats. I do love cats as much as I love dogs. But it's taken, I'd say, 8 years to get people interested about dog OA. I can't imagine it's going to be any easier doing cats. But cats, how they present pain is even more subtle than dogs. And that's because we tend to interact with our dogs more. We walk our dogs more. They come with us places more. Cats do their own thing. They're independent beasts. And quite often their signs of discomfort will be lumped into them just sleeping more. But changes in their capabilities, changes in their ability to jump up, changes in the ability that they wait, how they do things, changed interaction, changed moods, a lot related to change. Now, all of us know that a cat would not normally ascend the stairs like that, but an owner would think that that was almost normal. It's his home, he's comfortable in his own home, he's just taking his time to do the stairs. We know that a cat would be way more fluid, they clear 3 steps at a time. So physical appearance is often how we can pick up on signs, you know, so the lack of grooming, the way that they choose to sit. This cat's obviously sat extending its neck quite significantly for comfort reasons. It's not grooming itself. This cat may have not been able to jump the fence like it used to, so it's ending up having to climb the fence and it's breaking nails, etc., not cleaning itself. But quite often it's in the owner narrative of, I can't pick him up anymore, he's got grumpy, or all of these sort of things. So cats, because we don't walk them, because we don't have them as our constant companion, it is a lot harder. So as I say, we've been through this before. The cartilage degeneration exceeds repair, inflammation, exposure of the subchondral bone, loss of the concussional capacity of the subchondral bone, periarticular bone deposition, joint capsule thickens, and changes in that supportive, functional surrounding soft tissue. I've seen this one before. We know it's a process. We know that it's not a disease that remains within the joint. It actually, the consequences of osteoarthritis is what we see. And we've seen this about the weight shifting away from the source. So we start to get these capability and physical changes. We've talked about proprioception and how with poor proprioception, we lose our ability to balance and to judge and to react. And proprioception is hugely important because lack of proprioception could actually drive OA and progression. You've seen the changes in physical appearance, so the loss of muscle mass because of lack of use. And we've got this S-shaped tail where the dorsal pelvic tilting. We've lost muscle mass over the hamstrings and the quadriceps. We've got the caudally located forelimbs, so they're being drawn back across the thoracic cavity. The elbows are more extended, the shoulders more extended. Got the muscle mass development. It's got these developed triceps here. We've got this wider placement of the forelimbs. If I was to give you a sack of potatoes to hold, you're not going to put your feet together to hold them. You're going to spread your foundation so that you've got more balance, more stability by having a wider base stance. So you start to see the physical changes and the choice of posture to allow functional movement changes as well, and that main development. Adapted posture. So at the moment, I'm shuffling around in the chair because my back's hurting. So I'm trying to find a posture that I'm comfortable to stay in. So posture is a really big indicator that there's something being accommodated. And it might be a chosen posture, or it might be a posture that's developed over time because of structural change. So for example, this could be a chosen posture, but actually, if I'm really honest, my shoulders roll forward anyway, because I've had a bad posture for a long time. So that is my physical posture. If my shoulders really hurt, you might even see me do this. But adapted posture is really, really overlooked. This dog, again, has got that dorsal pelvic tilting. Oh, go back. Got the tails tucked under because our coccygeal, kind of like a sacral coccygeal alignment, is more ventrally positioned. So the tail is coming down. We've got these hind limbs. We're hyperextended through the stifle and through the hock, and these limbs are tucked underneath. These forelimbs are being brought back again, so we're extending through the shoulder and the elbow. But is it because we're actually offloading this back end and the weight is now being carried, still effectively almost doing a handstand? The forequarters are working harder, and we can see that because we've got tissue changes, and that collar is now tight. You wouldn't put a collar on this tight. This looks abnormally tight. And the dog looks unhappy, you know, that facial expression of life's difficult. Changing in capabilities. So why would a dog stop as it's crossing the road to pee in the road? You know, most dogs, yeah, even young dogs, would want to get somewhere quieter to have a pee, or somewhere of interest, something that smelled good. It has this dog actually been uncomfortable, hasn't wanted to squat because it's going to be uncomfortable. And ended up getting to a point where it's holding its urine for so long, has to just go there. So changes in the way and when Also the postures that they take to perform these activities like pooing and peeing. So you've got the poo-poo train, where they carry on walking as they're pooing because they don't actually want to hold a static squat. It's easier to keep moving. You might find that the arch of their back seems more uncomfortable. You might find that they throw their weight way more forward. So they look really like they're teetering on their forelimbs, balancing on their forelimbs, because actually squatting through the hind limb is quite hard and they can't take any weight. You know, it's a compromised position in the hind limbs, being a flex like this. They don't want to actually ask that part of the body to take any of the body weight, so they throw their weight more forward. Walking in a regular, uncoordinated way. So this dog just looks like it's really abnormal gait pattern. You've got wide over here on the right. You've got offloading here on the left hind, and collar is sitting right up here because the lower neck has got, you know, it's expanded because of soft tissue related changes, probably from compensation. We've got some hyperextension through these carpal joints. We've got that roaching of the lower back. So you've got flat, then it roaches. So we have that sacrococcygeal downward facing tail. So this picture actually speaks 1,000 words, but this dog might not be overtly lame. And this one, so yes, we are just capturing a moment in time, but you could question, you know, that tail is counterbalancing this dog just about to get a bit of a wobble on. He's crisscrossing the hind limbs. Why would he do that? He looks like he's going in a straight line. So has he actually got a little bit of ataxia here? So he's not got good placement. And he places this foot thinking it's the right place, but actually he's gone too far over the midline, and his tail's now trying to counter that lack of balance. He was beginning to sway over to the left, so the tail's coming right to counter that. We've got the panting. So this is something that people really overlook. But when we did a survey recently of what were the first kind of signs in a young dog showing musculoskeletal pain, panting featured quite frequently. And people always link it to cardiovascular or respiratory issues. But I've seen many dogs that pant because of pain. I had a dog that I was treating online based in Lisbon. And the thing that really haunted the owner was the dog panted all night, all night, all night, just sat and panted. And it turned out this dog had a spinal abscess. So, you know, we're talking about significant neuropathic pain. So this dog might have literally just started their walk and already started to pant. But cardiovascular and respiratory, fine. It's just their way of managing. And we've got this flip. Is it because this dog's been throwing weight forward? So we've now got development around the forequarters and around the neck. That's restricting the range of motion of that proximal forelimb. So it's not able to glide over the thoracic wall as easily because it's held there in place by soft tissues. And these soft tissues are now shortened and contracted and hypertrophied. So instead of that limb being lifted off the ground as a whole limb movement from the scapula, shoulder, elbow, carpus, because the scapula and the shoulder are restricted, are we having to make more exaggerated movements in the lower limb to get that ground clearance? This dog, you know, is sitting, but it looks like his back legs are a deflated tire. You know, there's no muscle mass there. So the soft tissue apposition between the quads, hamstrings sitting on the gastroc, they've deflated, they've concertinaed down. So it looks like he's got poor muscle mass in the back end. And that's supported by him having massive muscle mass development in the forequarters, in that his neck into his shoulders is just like a tree trunk now, you know, and that collar is slowly migrating up his neck because this neck area is just getting wider. And this one looks like he's run into a wall because, again, he's tucked up from behind. So he's really not wanting to do much movement through the lower back. He's keeping it all splintered in place. He's overdeveloped through the forequarters with that muscle development, that mane, that collar is uber tight, isn't it? You know, but we could also read more into this, in that this might have been a dog that used to be at the end of that lead, pulling forwards, might have always led the charge, but now he's quite happy to totter at the side on a loose lead. But again, that roached back, muscle development. Again, another one where we've got grimace. So canine grimace scale probably won't occur. It might do, but it probably won't, because there's too much dimorphic kind of, what would it be, polymorphic facial features in the dog because of our dolichocephalic, I think that's the long nose word, and then we've got our brachycephalic. We got such variety in dog facial features. Being able to validate a grimace scale might be quite hard, but grimace scales are in feline, they're in mice, rats, rabbits. So I think we're allowed to assess a dog's facial expressions as potentially suggesting signs of discomfort. And this dog is, life's shit. They're throwing the weight forward into those forequarters. We've got that mane developing with those coat pattern changes. But then we've got to think about the behavioural changes. So if you come near me, that hurts, or it could hurt. So I'm just going to keep myself to myself. When you brush past me in the kitchen, that knocks me off my balance. So I'm just going to stay in my bed. The changes in their willingness, I think, needs to be interpreted. You know, this dog is saying, I don't want to do that because it could hurt. Changes in sleeping position. You know, this might be a dog that now has taken on quite an abnormal sleeping position, bringing his back legs underneath his forelimbs because he's trying to relieve his lower back. And this is a comfortable place for him to get to sleep. None of us can sleep, can fall into sleep if we're in a stress position that's causing discomfort. So how they choose to lay can be very indicative as well of there being a potential problem. Again, seeming uninterested and distant. I think many dogs, this is a big, bold statement, ready for it. I think many dogs that we diagnose with canine cognitive dysfunction probably have a chronic pain component as well. They're associated with aging, both conditions. And I wonder how many times, if we were to say to an owner before we start putting them on cognitive influencing medications, how effective any of them are, we're not sure. Why don't we actually just get them onto a pain protocol to start off with, because that can be very cognitive lifting. A consequence of chronic pain is that cognitive fogging. And changes in behavior and personality. So a dog that used to be uber tolerant of everybody is now starting to become intolerant. Or a dog that used to be really quite independent has now become needy. I think looking at a change in their personality, who they are, is also another big indicator. I get ratty, I get impatient, I get intolerant. I'm not the Hannah that I would like to be, and I think it's a very logical kind of understanding. So this is Sarah. I'm going to let her do some talking.
Hello, my name is Sarah Heath. I'm an RCVS and European veterinary specialist in behavioural medicine, and I run a busy referral practice in behavioural medicine in the northwest of England. We see a wide range of behavioural presentations in our patients, and one thing that we consider on a daily basis is the possibility of chronic pain being a contributing factor in those behavioural changes. Canine arthritis management has been working hard to increase understanding and awareness of canine arthritis, which is indeed a common and also a debilitating disease. The chronic pain that's associated with this condition has wide-ranging effects on the behaviour of the animals concerned. Whilst these behaviours may not reach the stage where they result in referral to a service such as ours, we do need to remember that in general practice, asking specific questions about behaviour can help us in the early detection of this disease. Indeed, it's important to remember that diagnosis of chronic pain is virtually impossible in the context of a general practice veterinary consultation. Neither the time available nor the context make it possible to get to the bottom of these conditions. Therefore, it's important to ask questions about the animal's behaviour outside of the veterinary context. Animals who are in chronic pain may show subtle signs, such as a reluctance to walk on such certain floor surfaces, such as wooden floors, which don't give a sensation of safety as the animal moves across them. We may also see changes such as the dog being reluctant to get into or out of the car when they're going on a walk or when they're going to another destination. If the animal is allowed onto the furniture in the house, owners may have noticed a slight reluctance to jump up or indeed to jump down. So it's important for us to widen the range of questions that we ask, and not to think that pain will only be associated with extreme changes in behaviour, or indeed only involved in changes of behaviour of a repulsive or a confrontational nature. Animals suffering from chronic pain are in a state of fear-anxiety. Indeed, the pain emotional system is a relation of the fear-anxiety emotional system and is triggered by a need to protect yourself from harm. In case of pain, it's protecting you from physical harm and is associated with either actual or potential tissue damage. This means that when dogs are suffering from pain, they may show any of the 4 possible behavioural responses to a negative emotional state. Indeed, they may show repulsion. They may show signs such as growling or grumbling, or they may have escalated to the point where they have bitten somebody. But we also need to remember that animals in pain may show avoidance behaviours or appeasement or even inhibition. In the veterinary consultation, we often find that animals go into an inhibited behavioural response. This means that they may sit very still on your consulting room table or on the floor and pose no challenge to you in terms of carrying out your physical examination. But the lack of any kind of repelling action, growling or snarling, is not a sign that there is no pain. So, in order to increase our early diagnosis of arthritis, I would really urge you to think not only in terms of manipulation in order to detect chronic pain, but also in terms of observing your patients in the consulting room, looking for signs of inhibition or appeasement or avoidance, but also widening out your questioning to include questions to owners about the animal's behaviour at home. Hannah and her team at Canine Arthritis Management provide a series of workshops for veterinary surgeons in general practice. I would strongly urge you to engage with one of those workshops, find out more about this very common disease and about the practical aspects of chronic pain management. I would also urge you to consider behavioural medicine and the contribution that that makes to our understanding of chronic pain.
Little legend is Sarah. It really does open your eyes, doesn't it? The fact that Sarah Heath, fellow of the Royal Vet College, lectures around the world, is saying that chronic pain really isn't well managed in the consult setting. It doesn't give us the tools and the accessibility to be able to interpret chronic pain well. Now, this is a tool that I created for myself years and years ago because I, probably like you, was beginning to see a lot more cases and indicators of chronic pain, but I couldn't converse it. I could not communicate it to my team and my clients. And I was shy. I was scared about doing it. I was scared of rocking the boat. I didn't want to uncover something that was insignificant, or I also didn't want to have those conversations because who wants to tell somebody that their pet's in pain? So I created this so that when I was listening and seeing these cases, if I saw behavior change, didn't greet them at the door anymore, didn't want to walk as far, if I saw postural change, arched back, offloading, start to see physical changes, I'd collect my confidence to start the conversation. You know, if I got full house, you know, I'm having the conversation. I've got 3, I'm having the conversation. Now, if I have 1, I'll have a conversation, you know. So if I start to see changes in any sector, I feel confident to say, do you know what, you said something earlier, it's just really caught my attention. I think I'd like to kind of have a quick look into that. But at the beginning, I too was kind of underconfident about broaching the topics. So as you can see, pain, chronic musculoskeletal pain, can present in a very wide array of clinical presentations. And when you look at it like that, we have a problem, Houston. There is a lot out there that we're not attending to. So we now need to start thinking about how we can actually step away from waiting for the owner to come in with a lame dog and start actually more preventative medicine, more prophylactic, like you know, noticing things early and feeling confident to have conversations. And what's going to be really hard, and I'm just going to tangent slightly, is when I started, the easiest cases were the ones that were really obviously debilitated. And the reason that they were easy, not because they were easy, it was easy to convince the caregiver. They were on board. They had been pushed into a corner where they had to accept that things had to change. The ones that are really hard to manage are the early ones, because at that point, cognitive dissonance works. The owner doesn't really believe there's a problem. They don't really want to change the way that they exercise the dog. They don't really want to change anything. But actually, the pain state in that dog is going to be easier to control. So they've got these kind of like contradictions. They're like paradigms, aren't they? Early is harder because of owner, but easier to treat. Late is harder to treat, but easier because of owner. Right. That's that section done. Questions? Are we giving you too much? Are you kind of like feeling a little bit like, woof?
Hi, sorry. Are there any sort of questions that we could ask owners who are maybe very resistant to accepting that their young dog has OA? Like I know my dad, for example, he was saying that he's got a Jack Russell, and she had the Jack Russell hop for years and years and years. And I was saying to him, Dad, there's really something not right here. Like she's running weirdly, she's walking weirdly. Over the years, she became really quite aggressive. There was lots of behavioural changes. And he just wouldn't listen to me whatsoever. He just wouldn't accept that there was something wrong, because maybe he was Facebook educated, Google educated, I'm not sure. And then when he finally did sort of listen to me, it turns out she had double hip dysplasia, and she had done obviously since birth. And I find that it's quite difficult sometimes to get the client to accept. So is there any kind of like prompt or anything that we could say or use to try and really get them thinking about it? Because you can send them away with homework or booklets and stuff, but if they're not willing to accept, then it's probably just going to get chucked on the kitchen side.
Yeah, there's so much. First of all, be at peace that advising family members about anything is impossible.
True.
No, just don't. I don't even. My dog's just got a new Labrador puppy. He's about 5 months old. He is so lax everywhere. He is wobbling through the waistline. He's floppy through his carpal joints. He's just a floppy goofball. And however wrong or right this is, I have to wait for them to ask, because I've been there 100 times with them where they don't listen. And families are really, really difficult. Friends are really difficult to advise. I try and steer clear, to be honest. It's much easier if the people don't know you, being able to advise them. There's a couple of screening tools, which we probably will look at later. There's a canine screening tool and a feline screening tool, and they're basically 6 questions. And if you answer yes to any of them, that indicates that there's a potential underlying problem. And because it's done by NC State, which is a very well-respected university and it's branded, it gives people it's not her subjective opinion, it's a universal opinion. And these tools can be very powerful on like a psychological level, because as you say, people just think it's you. And you're like, no, look, I've got an army behind me that agrees that there's something not right. There's so many different angles. We're actually thinking about writing a course about talking about pain, because it's the biggest area of problems and there isn't a course about it. And I'd like to try and get some like psychologists and some behavior change specialists to help us write a course about what terms are you supposed to use. Again, there's a real gut instinct. I have been known on a frequent basis, when an owner's pushing back, I go, just pause. Am I in pain? And you can see them go, what? And I'm like, am I in pain? And they're like, I don't know. Yeah, I'm in pain. I have pain, but I've got a mortgage and I've got a car and I've got a job. So I'm here and I'm working and I'm getting on with life because I have to. It doesn't mean that I haven't got pain. So the fact that your dog is still walking with you and doing all these things doesn't negate the possibility of them being and having pain. So you can go in quite hard, you can go in quite strong, but you have to really choose who you do that with. Sometimes it has to come from somebody else. Me and Evie would team up and I would throw her cases. So we had this system when we worked together where she had her message board and I had mine. And if I was having difficulty, I'd just push the client over to her for Evie to give them a ring or make sure they did a checkup or do a weight check-in. And it can become better from another person as well. What else can you add, Evie? Because there's so much here. This is like a day in itself, really.
Yeah, I think, like you said, you have to. It's also a really emotional time for an owner, and especially if they aren't realizing that their dog is in pain, and you're like, oh, there is pain. They can. It's a feeling of guilt, and they can get quite defensive because they're like, well, I'm the best dog owner in the world, and I do know. I've had dogs for 30 years, and I do know when they're in pain, and I can pick things up. They can take it as a insult sometimes that they haven't picked it up. So I kind of always swing it round and say, look, I'm rubbish at picking up things in my own dog, and I didn't realise until Hannah actually looked at her that there was something going on. So it doesn't matter what profession you're in or what education you've got, you sometimes don't pick things up. Instead of saying,
you have to say you see your dog every day.
Yeah.
So changes that are taking place, you're not going to pick up on them because they're so gradual.
I think also not using the word pain in the first instance, because that can be quite a scary word. So I normally use, well, there's a certain element of discomfort there, or we've got some muscle wastage and things like so. And then I explain why those things can happen. So it's not being like boom pain, like that's quite a, oh God, like I don't want my, that's the word they always come out with, as, oh, I don't want my dog to be in pain. So that can really upset them.
The word discomfort can be more socially accepting. Sore, or I believe he's in discomfort, and people don't seem to get so kind of reactive to that.
Yeah,
it is really difficult, and there's loads of different strategies. It might be that you choose to jump to this. This is what I do all the time. I would rather be wrong than right, and then they will be like, what do you mean by that? I'm like, I'd rather we looked into this and I was wrong, and then we've got a clear bill of health, than be right and we've not done anything about it. In 2 years' time, we're in a worse position. And they're like, because it shows that you're a bit humble. It shows that you're human. It shows that we haven't definitely diagnosed something yet. We're going to look into it. It brings back this, are we on a shared decision-making journey? Are we doing this together? Because I'm happy to, and I'm really okay if I'm wrong. I don't mind, but I'd rather look into it. So there's phrases that you can use as well.
I think also praising the owner. So I normally say, oh, there is a certain element of discomfort there, and then you can tell they're like, oh, a bit worried about that. So I say, well, that's fine. We can make a plan moving forward now, and it's really good that you've come in now, and we're able to address the situation and go from here. So you're putting it back in their court and saying, well done, you are a good dog owner. You've brought your dog in, and we've identified it.
Yeah,
that's great. Thank you so much.
There's a really, and Sally, there is, it's I've been doing it for what? Been a vet now for 22 years. And it's, you just have to have your wits about you. You have to be looking at them. You have to be looking at their choice of clothing, bags, dogs, what they drove in, who they are, who they brought with them, how they speak to you. And you're like, okay, I'm going to use my gut instinct of how I'm going to, and you're not going to win them all. You're not going to win them all. But if you don't win, you write it in the notes and say, concerned about pain. This is the region I'm suspecting. At present, owners not engaging on this topic. Please review at next consult.
Okay. I like that line. That's a good line.
But yeah, it is really difficult. We actually quickly mentioned the staging system that we created. So it's called the 5x5x5. 5 stages, 5 grades, and 5 scores. And because I was finding that as a vet, if you detect something, the owner doesn't engage with it, it then gets forgotten about, goes into the ether, nothing happens about it. Or basically communication between vets sometimes does not have the best interest of that animal at heart. Things get forgotten, they get neglected. So the stages are identification. Stage 1 is identification, 2, diagnosis, 3, initial management plan, 4, maintenance management plan, 5, palliative care. So there's 5 stages of the OA journey. Why is that helpful? Because if you wrote in your notes, stage 1, still at stage 1, still at stage 1, then that vet is going to go, we've been talking to you about the clinical signs for a long time and you really are not getting on board. And it just gives you so much information about where you're at with that client who's in control of that case. You can say things like, oh, right, so you want to go from stage 1 to stage 3. And they'll be like, well, what's stage 2? Like, well, that's diagnosis. We haven't actually really got a diagnosis yet. What's that mean? Well, we have to do imaging. Oh, so there's a plan. And you're like, yeah, there's a plan. I didn't know there was a plan. Okay, we'll do the plan. It's a bit like people like to follow a recipe. And if you suggest that there is a recipe and there's a structured recipe, and then if you're in stage 4 and you start knowing that the time is coming, you go, right, let's all talk about this. We're heading from stage 4 to stage 5. And do you understand what that means? And they'll be like, well, what's stage 5? We're heading towards end of life care. And, you know, it's a polite way of saying, you know, we're running out of options. Grading 1 to 5 is different grades of OA, but that's a combination of like pain and radiographic changes. And it isn't formalized, it's more of a practice decision. And why is that helpful? It can be helpful in what you choose to offer and also prognosis. So if you've got like end stage OA and the joint doesn't move, putting things into the joint, is that going to really work? You know, so that can be helpful, but it's still very, very open to interpretation. And then SCORE is equivalent to the Colorado acute pain scale, where they do 0 to 4 for acute pain. This is 1 to 5 or 0 to 5. Chronic pain, again, it's very subjective, it's not validated, but across the board, all UK practices do not quantify pain. They do not. If they do a CVPI, which most don't, and me and Evie really struggled to do them. They're really hard to bring into a practice setting. We had them at front desk. Evie would give them out when people arrived. I'd try and get them to use them in consult. I'd get them to take them home and say, can you do one before every visit? They just don't want to engage with these tools because they're dull, they're 2D, they seem like homework. So if you can't do that, what is the thing that you could do? You could use your experience, your clinical professional experience, and say, my impression of this dog, whilst he was in my care, he's 1 out of 5. He's sore, but he's not bad at all. You know, we're doing okay. If you were like, he's actually bloody damn painful, he's 4 out of 5. You know, he is super bloody sore. And it just means that you can say to your owner, like, he's 4 out of 5 in pain. We need to do something about it. And it also means to your colleagues that when you're not there, you're away and they come back, they were previously 4 out of 5 in pain. How are they now? Are we actually... So there's a lot we can do more, but there's so much more we can do with OA, but we're just not there yet, really. We need to get people to wish to engage with these. Claire, you've got an amazing question. I know we can use the home adaptation structure exercise to slow down the progression, prevent further injury. Changes which have developed over months here. How do we correct those? So you're absolutely right. If you've got a problem, you want to first of all make sure you're not making it worse. And that's where home adaptations, appropriate exercise, etc. come in. So do no harm. Try and make it, you know, don't progress it. But then how do we actually get them posturing properly to bring back their capabilities to then start using their muscle mass to redevelop? That, unfortunately, is going to be a combination of pain relief, so that they choose postures that are comfortable, that are appropriate postures. So we need to make sure that their pain state is well controlled. But really, to rewind the clock and rebuild really does need professional input. I think if you take the pain away, I think you will see an improved posture that will bring back some tissue function, but I'm just using myself as an example, you know, over the years, have I got anywhere with straightening my back out and pushing my shoulders? No. Should I actually see a physio that gives me targeted exercises that I do every day? Yes. Do I do it? No. So I think the idea of actually rebuilding and getting back is very caregiver dependent. And if it is, a caregiver's really able to understand that that's going to give them the longest comfortable security, then that's getting a physio involved. Do you agree, Evie?
Yeah, definitely. Yeah.
I think at the moment, with the way that we manage chronic musculoskeletal disease in the vast majority of our population of dog owners, our ambition should be to prevent it getting worse. I hate to say it. We are not anywhere near clients that are ready to reverse time by putting hours in. And that's what it needs. You know, it's not a case, even if things like neuromuscular electrical stimulation was effective, which it can be, even if it was, owners are not going to sit there with a electronic device attached to their dog and sit there for half an hour 4 times a day to redevelop muscle mass. And nothing's as good as functional exercise. So, and being able to do the right exercises to rebuild requires a good eye and a lot of experience, and that's where physio comes in. But I would imagine if we surveyed all the UK physios and said, what percentage of your client base actually return to function? And I bet you they will say sporting dogs, where there's something to lose by not getting physical form back. Yes, high percentage. They've come in with the intention to return to a previous functional high-end state. But then I would imagine that in their caregiver-owned population, they're just firefighting, they're damage limiting. That's a very morose acceptance, isn't it? But it's better than what's happening, where dogs are progressing quicker and suffering more. Our role, if our first step on this mission is to raise awareness, earlier identification, and take on activities that don't make things worse, I think is a bloody big step in the right direction.
Definitely.
No, I'm not saying that physio is the only therapy that really does rebuild, not at all. The difference is physios have a much broader understanding about musculoskeletal health, and it's not just about, and hydrotherapists will hate me saying this, but you can put them in a swimming pool, put them in the tank, but is that going to give them acute fine motor movements? No, it's not. Is that going to get their balance and their agility and reaction skills back? No, it's not. You know, that's going to be good for gait patterning and it's going to be good for muscular development, but it's not going to fine tune them to being back to a reactive athlete. So physiotherapists, depending on their qualifications, have a very broad knowledge. And if they are a good physio, they work with a hydrotherapist and they'll work with a massage therapist, but they're almost like the overseer of return to function. They'll be like, so pain's under control. I've been using my class 3B laser. I've been doing some massage and some myofascial release techniques. I feel that you're now at a point where I want you to go off and do hydro for 4 weeks, and then I'm going to see you again. That's how it should really work. They shouldn't be seen as separated skills. They should actually work as a team. But unfortunately, the nature of business quite often means people don't work like that. People keep their cases. So that's where you come in. This is where you develop your community around you. And having a folder in reception where you have the local hydrotherapy and you've been to see them, you've phoned them, you've got to know them, you're now mates. And then you've got your physiotherapists. And then you actually end up implementing a network and they start trusting each other and utilizing each other's services. But it's almost like you become this catalyst. And what I'm noticing is that there's a fight for cases. So Tanya's busy because she's got in with a vet and a vet that believes her. So her caseload is full. But if you don't have that rapport with the local vets and the vets aren't identifying these cases, then people are scrummaging for cases, and therefore they don't case share.
Yeah.
Hannah, can I ask, or Evie, is there, what regulatory body, if that's the right word, should like, where do we find physios to signpost to that aren't just people that say they're physios?
So the easiest one would be RAMP at the moment. So RAMP, Register of Animal Musculoskeletal Therapists, no, physiotherapists.
Physiotherapists, yeah.
Yeah, and they're working more closely with the Royal College of Veterinary Surgeons to bring physiotherapists under the umbrella of the rules and regulations of the RCVS. But regulatory bodies would be RAMP and would be the Animal Health Practitioner Register,
APHR.
APHR. That. And these are regulatory bodies, and that basically means that to be a member of that regulatory body, you have to do a certain amount of CPD and prove competence. You are going to be insured appropriately with public liability. You have a body where if somebody's got a complaint about you, they can make a complaint to that body. So they're the two major ones, aren't they?
Yeah, or obviously ACPAT.
Do not ACPAT come under RAMP?
No,
Oh, do they not?
no, they're the ACPAT or ACPAT.
I thought that they'd still have to be under one of the regulatory. Then there's ACPAT. And ACPAT are human trained physiotherapists that have transferred.
So, and each of those, I've just put RAMP on there as an example, but you can go in and you can type in the area that you're in and it will tell you where your local therapists are. It's a bit like the RCVS nurse register and vet register.
And the animal health practitioner, does that also include acupuncturists and massage therapists, laser therapists as well?
So acupuncture in the UK can only be done by vets. So yeah. And I'm not, so there is the British Veterinary Acupuncture Society, but then there are many vets that do acupuncture that aren't registered.
Yeah.
Massage therapists would fall under AHPR, wouldn't they?
Yes.
Yeah.
I think that's where hydrotherapists are as well.
Yeah.
Yeah.
But then there's other ones like IRVAPT as well. But I
Well,
do
there's
start
so
to.
many different ones, and also I think make your clients aware if you are, because some insurance companies only cover certain regulatory bodies, and they don't at the moment cover AHPR.
So IRVAPT, I think, is only CPD though, isn't it? I don't. God,
I don't know.
It gets confusing. What is a regulatory body and what is more of a membership and CPD provision? But start in those places.
Yeah. Cool.
Right, what's
Should
planning?
we stop for lunch now?
Mhm.
And then reconvene afterwards, and we will then be doing setting up an OA clinic plus resources available.
Amazing. So you're in charge of that, aren't you?
That's me. So if we start back at about 2:15.
That's cool.
Yeah.
Cool. I'm going to pause. What? When did she change? It's a new person. A new voice.
It's being recorded.
Yeah, this is normally a guy.
No, it's not.
Is it not?
No.
Okay. Okay. Yeah, good.
Perfect. Do you want to put it on presentation bit?
I have got it on presentation.
Oh,
Have I not?
it's coming. Oh, is it loading?
What about now?
Yeah. Do you want to put, can it go
that
on
good?
full screen like yours were?
Okay. Stop being silly, Zoom. So, nurse training. Oh, I know why. Okay, I'm going to step out and step back in
right.
because it's changed me from browser. 2 seconds.
Yeah. Right, I'm going to close my door before you start barking. Out the way. Out the way. Perfect.
Zoom's being annoying. Yes, you're good to go. I'll go back. There you go.
Perfect. So we're now going to spend some time talking about how to set up your OA clinics within practice. If you've got any questions, please just ask them along the way. So life is really busy in practice, as we all know, and clinics, as Hannah mentioned earlier, normally get shoved out the way by things that walk through the door. So a GDV will probably walk in, or a C-section, and you're on call, and then clinics get chucked out the way, and you don't have time to set these up and things like that. So that is why CAM has created the nurse flip chart and other resources to help you take that first step and make it easier for you. Slide. So we're going to go through each module of the flip chart and how I normally talk through to the clients and things not to forget. We'd also like to say a massive thank you to our sponsors, Limp Bells, with their Mobility Matters. With their Mobility Matters kits. They have amazing resources, as Hannah mentioned earlier, and they will also help you massively in your setup of clinics. Like we keep harping on, having a company behind you helps make the owners aware that you are talking sense, and this is something that really matters. So, step 1 in your perfect OA pain clinic toolbox. So these are things that I have within my room and things that I could not do my clinics without. So the nurse flip chart, which we're going to go through, and that can be found in the member zone and as a free download, which you guys can print off and have as many as you want in practice. Kennel cards, which again, I think Hannah showed you in the IVAPM lecture. They are really good ways to take your pain clinic throughout the whole practice and try and get the whole team on board. The CAM cards, so these are really useful. They're little business cards which basically have all the details of CAM on there, the website, everything. So you can just staple that over to invoices or prescription reminders or your OA booklet. So they're going to an actual source of information that actually makes sense rather than just going and asking Dr. Google about arthritis. I also have a lot of monitoring tools, one of them being the CAM Good Day, Bad Day monitoring tool. So I don't know if any of you are aware of these, but they are basically a 30-day calendar, which your owners can use. It's nice and easy, it's nice and bright and colourful. They don't look like homework like other objective monitoring tools, and the owner can use them in a way whichever they find most appropriate. I also use a lot, it's my Home 2 tool, which is the home adaptations tool that we talked through earlier in Game Changers. Yoga mats, I use these a lot, and also therapy mats, things like that, just so that the area that I'm actually consulting in doesn't have a slippery surface and the animal can feel calm. I also have yoga mats in the waiting room. We have them throughout the practice, so they're in the kennel rooms, they're in the prep room. so that there's always a nice non-slip surface for these patients. So if they are being admitted, it doesn't just finish as soon as they go away from the owner. I have lots of licky mats and kongs and snuffle mats and things like that. I use these all the time. These are really good ways to just calm the patient and reduce their anxiety. In our chronic pain patients, they normally have they're normally quite stressed when they come in, because they're either in some element of pain, or they've had a stressful journey in, or another dog has come near them in the waiting room and things like that. So this is just a nice relaxing way to calm them when they come into me. Tape measure, I use these a lot for my weight clinics and things like that, and that plays a massive part of your pain clinic as well. And also make sure that when these clinics are booked in, that I have a good amount of time with these patients. So my clinics tend to last about 45 minutes, and this allows me to take questions from the owner, and also spend time just letting the dog get used to the room and making them feel relaxed, and then carrying out the consult. Oh yeah, thank you. So during Vet Nurse Awareness Month, it was a year ago now, we created the Nurse Flip Chart. So it's an amazing resource which is downloadable for free within the member zone. And this is going to be your Bible to create your clinics. It's basically a 11-stage flip chart, which basically has a side that the owners can look at and a side that you, the nurse, can look at. It allows you, if you're feeling a bit nervous and a bit like, oh God, I'm not really to grips with these consults yet, it allows you to have prompts so that you feel like you haven't forgotten anything. But it also provides nice visual aids for the owners so that they can be reminded of things and the information is going in different ways, rather than you just waffling on at them. As we really do need to remember that only 20 to 40% of what you say goes in, so we back that up with the visuals. So setting up your consult room for the clinic. So like we said earlier, the yoga mat is priceless. They aren't a lot of money. Like Hannah said, you do get the claw prints in them, but what I tend to do is buy the yoga mats and then cut them in half, so you get 2 for 1. And they work really well. I always have my clinics on the floor. Putting a dog on a table can be really stressful for them. It's a really unnatural position for them to be in. So we want to reduce that as much as possible. So all my clinics are done on the floor, no matter what size the dog is. I have a nice orthopedic cushion therapy mat which goes down, and then there's yoga mats around the outside, so they can choose where they want to go. They feel more at ease. They're easier to fully examine because they're not trying to scramble off the table. Once they've relaxed and they've got a licky mat or a Kong, they're just chilled, and they'll let you do a lot. It also lets the clients know that you care. You're actually sat on the floor with the patient, you're engaging with them and the patient. It's more relaxed because you've not got that barrier and you're not stood behind a table. You kind of have that more friends vibe, rather than I'm a professional and you're here for my advice. And it also shows that you're considering your handling, which, if you're setting by example by making sure that there's not any slippery floors and you're being careful and you're not bundling them up on the table, the owner's going to think, okay, well, they're not doing that for a reason, so maybe I should be doing that at home.
Oops, sorry.
That's right.
That one. There you go. You done that one? Happy with that?
Yeah. So we then need to think about the CAMS 4 E's, which are engage, educate, enable, and empower. So by doing that, slide, we move into step 2. So we need to engage with the client, and it starts as soon as the client and the patient arrive at the practice. So the first impressions that the client makes is when they walk into the waiting room. So like I was talking about to Charlotte earlier, making sure that on your notice board you have strong positive messages. So the notice boards at my practice, we change them bi-monthly, but we always have one that's half of a board that's surrounded by OA and things like that. We still change it because it makes the clients want to look at the board if it's something different, especially if they're coming in regularly. But with the CAM poster pack which we use, I think there's about 6 posters in the pack, if I'm correct. So you can change those around regularly. And I found that those posters actually were brilliant conversation starters and makes the client think and comes into the room being like, actually, I looked at that poster and my dog does do that. So I think there could be some pain going on. So by starting them thinking in the waiting room, it makes your life a lot easier and the vet's life a lot easier when they enter the consult room. Also in the waiting room, we have CAM OA Bibles. So these are brilliant. These are booklets basically on caring for an OA patient, everything you need to know as a client. So these are really useful take-home things. If you wanted to, this is something that you could factor into the price of your consult as well. They're really easy and nice to read, and pictures and things like that. So that's also a really good, useful product to have. We have the CAM anti-slip tape. Again, this is recommended a lot during the consults. They can be used on door thresholds. You show the client how you use them within practice, things like that. And also the CAM bandanas. This is something that owners love. So I don't know if anyone's seen them, but they come in dark blue and yellow, and they just say, be careful, I'm arthritic, or some.
Be nice, I'm arthritic.
Be nice, that's it. Be nice, I'm arthritic. And they have the CAM logo on it. The whole thing behind this is obviously to make people aware. It's a bit like the anxious dog. Is it the Yellow Dog company that have the anxious dog lead? So it's a visual statement that people see in the park and they're like, oh, what's that? And so one, it protects the patient if they're out walking them, if they're coming into the practice, things like that. But it's also a massive talking point, and something that the arthritic dog's being walked by the owner. Someone's like, oh, my dog actually is like that. And the conversation goes from there. So again, that is a massive helping point for you. It's a helping point for the patient and the owner. The owner starts to feel part of a community because there's other people coming up to them with arthritic dogs in the same position, and they're not feeling so isolated when they're taking the dog out on a walk. Also in the waiting room, we have raised water bowls of different heights. So this allows, again, it's a visual representation that the practice cares and that we're practicing what we preach. It's all very well us saying to owners, you need to raise their food and water bowls, and then they go out and ours is just a bowl on the floor, and it's not ideal. So varying raised water bowls in the practice is a really good idea. And also a yoga mat basket, which the owners can take out and use whilst they're waiting in reception. Again, a massive talking point. When me and Hannah are at Tamar, one client would come in and put the yoga mat down that had been seeing Hannah for ages. You'd then get another client come in that hadn't seen Hannah or the dog doesn't have any underlying pain. They're like, oh, why have you got a yoga mat out for your dog? And so they explain, and then they roll a mat out, and then you've got a whole room full of yoga mats and dogs. So it's just different ways that can start raising awareness to other owners, as well as the ones that are already converted as such. Ensuring that your reception team greets the clients. They could offer what has changed from my dog questionnaire, so questionnaires that can be filled out within the waiting room ahead of the consult, so that the owner can bring that into the consult room and the vet or the nurse has got something to read off. Clinical metrology instruments, so that's your objective monitoring tools. So like I said earlier, the good day, bad day diary, but you've also got the canine brief pain inventory, LOAD, which is the Liverpool Osteoarthritis in Dogs, Helsinki, you've got loads of different ones. My advice for those is to have a look through all of them and see what's going to work best for you. Which one do you find most useful, to then choose which is going to be most appropriate for your caregivers and their patients. And also making sure that your receptionists know why there's yoga mats and making sure that they're offering them. Again, it's a good talking point to start off their journey through the practice. So again, when we're talking about engaging is when your consultation begins. So when you go out to the waiting room, making sure that you're making good eye contact, that you're introducing yourself by facing them and shake their hands so that they feel comfortable and know who you are. This is also an opportunity to start watching the dog and see how they rise and walk towards you. Did they get up easily? Did the owner use the yoga mat? Have they slipped out? Are they slow? Are they limping? Things like that. If it's appropriate, greet the dog. But again, you need to try and work out if that dog is going to want you to go down and start fussing it, or if it's a case of let's take them through, let them settle in the room, and then go from there. I also make sure that I make a massive...
Oh, sorry. Apologies.
No,
I thought you...
I also make sure that I make a massive deal of putting them onto the weighing scales every single time. This is to make sure that we have up-to-dates on each occasion. It also highlights to the owner how important weight management is in the management of OA. So yeah, that's really important. I saw it on Instagram the other day, which a lot of people, I sometimes struggle with patients, is you have the step going onto the scales, but there are weighing scales now which are literally just which literally lie flat on the floor. I don't know if anyone's seen them, but they look pretty cool and I quite like to get one. But that's normally the thing, is you need to be aware that this is a strange object and you're getting them to step up, and if they are in pain, then that could be why they don't want to do it. Slide. So your space, your time, your consultation. So you need to understand and accommodate your owner's mood. Like we've said along the whole time, if they are at the beginning of the diagnosis, this is life-changing for the patient. We went to a lecture one time which the speaker said no one buys a dog not to take them for a walk, and I think that's something that's really important to remember. Owners think as soon as you say, oh, your dog's got OA, that's it, they can never walk them again in their life. It's obviously not the case, but they become quite emotional about the situation. They might have bought the dog to do agility with, they might have bought the dog to do long hike walks along the coastal path, and now they're not going to be able to do that. So it can be quite emotional for the owner. So just make sure that you understand what they're going through and how you're going to accommodate that patient and the owner. They also could be quite apprehensive whether they're doing the right thing. Like I said earlier, they can feel guilt because they haven't picked up on this soon enough. If you've got an owner that's a bit further down in their journey of OA, it might be that they're just getting overwhelmed by everything and they feel like they're not doing enough. There's so much going on. And they can also be feeling anticipatory grief and things like that. So it's a really good idea just to gauge the client and what you're dealing with. Also making sure that they're aware of all the options that are available for their patient and for what's going on. So I always invite them to talk about their dog and their house and everything. So I know I ask them open engaging questions, which allows them to open up to you. You sound really nosy, but they tell you that people love talking about their pets. And if you ask, right, tell me about your pet, what was their mood like, their behavior, what was their capabilities recently, where do they sleep, how much exercise can they tolerate, things like that. Owners open up to you, and that's where you can start building that relationship with them. So you then
sorry, this is freaking Zoom. Apologies. There you go. Back again.
Yeah, there.
Okay.
All right. So we also make sure that any decisions that are made is shared between yourself and the owner, as this makes them feel more involved within the situation. Especially when you look at the volume of influence pyramid, owners are a massive part of OA management. So we need to make sure that they're not just in the background and we're just like, oh, well, whatever, I don't care that you don't understand what's going on. They need to feel really involved from the beginning to make sure that they're engaged and going to carry this all out. Slide. So that's when you move on to educate your client, and this is where your flip chart comes into play. So there's a bullet point list of prompts on the back of your consultation so you don't forget anything. After you've done a few consults, you then get used to it and you get your own flow and you get the way that you're going to approach the questions and things like that. But the flip chart basically is a logical flow through the multimodal management, and you don't need to know everything. It's all written down there so you don't have to remember everything. What we need to remember is to keep it simple and brief. I do waffle a lot. So every time I do a consult, I'm like, right, stop waffling, stop, don't panic. But what we need to think of is how everyone's brains work now. So we all sit and we scroll through reels on Instagram, and they're about 45 seconds. And if they're any longer than that, we're bored and we're flicking through. So that's what we need to think of when we're carrying out these consults with the owners, is that they're only going to engage with you for the length of a reel. So just make it short and sharp and don't lose their attention at the first hurdle. I also make sure that throughout I do something called I give them a chunk of information and then I check that they understand. I don't go, do you understand me? Because that can be quite like, okay, whatever. So I just ask them rhetorical questions like, how do you feel about the options we've run through now? Do you understand? Does that all make sense? Or is there any questions that you might have? So by doing this, they don't feel stupid, and you can run through it again if they need to. You can also gauge how much the client understands and issues that you might have moving forward. So this is an example of what it looks like on the nurse's side. So the first step of the flip chart is what is arthritis and why is it painful? So this is basically what it will look like on your side to give you an idea, and this will help make the owner understand what the dog's going through, because a lot of the time they don't even really understand what arthritis is. It's something that's it's a word that's chucked around quite freely within our language, so it's good for them to fully understand what is going on. So what is arthritis? So we need to focus on how common it is, and our intention is to reduce the anxiety of the owner and reduce the guilt for them not noticing sooner. Mention how many breeds are predisposed. It is so. A lot of owners think at this point, oh my God, is it something I've done wrong? Is it because I fed them Weetabix? Is it because I didn't brush their teeth enough? So this just helps them understand that, yes, it is really common and so many breeds have it, that don't panic. You're not the only one in the world. It's something we can work through together. So we then explain what arthritis is. So it starts in the joint. The painful joint then needs some compensatory changes in weight bearing and function, and this leads to behaviour. This can then lead to behaviour changes, posture changes, capability changes, and over time physical changes. So again, there's a really good CAN resource which you can then work through with the owners. And it basically has a bubble with behaviour changes, posture changes, capability changes, and physical changes. And then there's lines either side that you and the owner can work through together and write a list so that they can then see that, oh yeah, he is a bit hunched in his back, or yeah, he isn't able to go up the stairs as easy as he used to. So then you can start building a puzzle and they can see it visually rather than looking at their dog and being like, well, there's nothing wrong with him, he's just getting old. They can then start to see down on paper, and it's something that they can take home and speak to family members as well, because that's something else that comes into play, is that one owner will come into the consult room and listen to all of this and understand it all, but then they'll go home and they'll be like, oh, don't be, and the husband's at home and telling them, oh, don't be so stupid, it's not, he's not in pain, he hasn't got arthritis, blah, blah, blah. Just getting old. But by taking filled out charts that you've carried out together within the consult, it really highlights it and helps get that across. And also mention the amplification of pain messaging.
Slide, doing it.
So yeah, this is the diagram that I was talking about. So this is an example of what it looks on the owner's side. So it's just nice and simple, nice, pretty picture for them to look at. Slide. So we then move on the flip chart to signs of OA. So we talk, this is where we get out the suspicion of chronic pain document, and we go through the behaviour changes, the postural changes, capability and gait, and physical changes. We can jot down the observations together so they can take them all home. And also on the flip chart, there's a lot of hints of things that the owners might say and how you can answer them. So I thought it was just getting old. Things like that, there's ways of which you can answer them nice and easily. So then we move on to the difference between acute and chronic pain. It's really important that the owner is able to understand the acute and chronic pain, so that when they have acute flares and things like that, they are aware that, yes, arthritis consists of chronic pain, but acute, it waxes and wanes, and during those points you can get acute flares. So explaining what pain is. So a brief understanding of pain will encourage the understanding that pain can be complex, and it also makes them understand that you might start them on one medication, but that might not be the right medication for them to be on. It's not a one size fits all. A really nice anecdote, I think it is. I think that's the right word to use. That I heard when I was speaking to Drew Tootle was pain isn't black and white, it's all shades of grey. So you need to I use that quite a lot in consults, and it makes it understandable to the owners that it is complex, and it's something that is going to have to be worked through over time rather than just a quick fix. It also makes them understand why the signs that they might be seeing might be quite subtle. They understand the multimodal approach and understand why we might need to do observations and further monitorings moving forward. So when you're explaining the differences between the acute and chronic pain, it explains to the owner why they don't yelp. So that's a lot of the time what the owners say is, oh, well, he's not on pain because he doesn't yelp, he doesn't hold his paw up all the time. It helps them understand that a bit more. It supports their diagnosis of OA. It confirms it's a long-term disease and not a quick fix. And it suggests why a multimodal approach is better than a simple pill. So like Todd is telling us there, time spent now will be time saved later. And I think that's really important to remember, is that as soon as those clients come into that room, we need to manage their expectations. It isn't going to be a quick fix. It isn't a case of they've had a bitch spay and 10 days later they're signed off as fit and healthy. It's a long-term thing that needs to be managed, and they need to be made aware of that at the first point. So then, have you gone backwards, Hannah?
No. Explain what pain is. What are the signs of arthritis?
No, there we go. Ignore that bit.
Weird.
That is weird. I don't know what's happened. So we then move on to section 4, which is the volume of influence pyramid. I really love this image, and this is something that we have in our waiting room, and is something that hammers at home to the owner about how important they are in the multimodal management. So actually, vets, yes, we do play an important role, but in the overall management plan, it's the owner that has the most control, and this helps to highlight it to them. So it helps to also make sure that they feel a massive part of the care plan. Owners in a lot of chronic diseases feel like they don't fully understand it, and it takes them a while to grow confidence with it. So this pyramid just helps from the first hurdle be a visual representation of how important they are. So they can carry out basic observational skills at home. They can also offer weight control at home. Lifestyle adaptations is all they're doing. So that's really important. It's not a pathway. You don't have to follow this step by step, but it helps as a visual for the owner to tick things off and to positively influence them moving forward. So we then move on to owner identification of pain. So this slide is where we start to talk about observational monitoring tools and things like that. Within the flip chart as well, we have QR codes which take them straight to the CALM website and to where these resources are, so the owner can literally scan that and then print it off when they get home. And this talks about the importance and what they should be looking at when they are carrying out these monitorings. So identifying signs of pain is just the beginning. So we need to make sure they understand that, and that monitoring the condition throughout is what we need to carry on doing. We need to big up our owners to make sure they feel confident in doing this. And if we are using other monitoring tools, talking through them and making sure they understand how to fill them out within the practice. So big them up. No one knows your dog better than you. Nothing comes with a promise. We need to check what we are doing is working. OA is a progressive disease. Their needs will change, and we need to be ahead of them. Arthritis waxes and wanes, and so does what we can do for them. So this helps the owner understand from the beginning the importance of monitoring. I also talk about at this stage taking videos, but also looking back at old videos that they've taken of their dog, so that they then can flip back and forth. So they might have a video of their dog going for a walk 4 years ago compared to now, and there's a massive difference, and then it all highlights it. And you then say, well, if you'd taken a video every day, we could then see if any changes happened, especially when it comes to acute flares and things like that. So the validated monitoring tools that are available, like I said earlier, are the LOAD, which is your Liverpool Osteoarthritis in Dogs, your Helsinki, Cane Brief Pain Inventory, and the Good Day, Bad Day Diary, but that one isn't validated at the moment. But there's loads of ones out there. Like I said, choose one that suits you and your practice. Like Hannah was saying, they can come across as quite dull, and they can come across as homework. So make sure you use them wisely and to who you hand them out to. It might be that you say, look, let's just take some videos or pictures and things like that, or just tick and cross on your calendar at home, so they feel like that they aren't having to do homework. One thing that one of my owners is doing at the moment is just writing a diary of every day and things that change and exactly what's happened, so that when she comes in, we know that when she does a certain walk, that might not be the best for the dog, and we make sure that the next week she doesn't, and then there's improvement and things like that, so we can have a good understanding of what's going on at home as well as in the practice. So we then move on to weight management. Again, this is quite a emotive subject for some owners. Like we said earlier, when we're talking to an owner and saying their patient is in pain, they can become quite offended. Again, in this situation, if you say, oh, your dog's really fat, they can get really offended. So just using emotive language and making sure that you're being supportive of the owner and come across in a way that you're not judging them and things like that. So ideally, a patient that is predisposed to joint disease or has arthritis, we should aim for a body condition score of 4 to 5 out of 9. So making sure that we're keeping them on the leaner end of usual. As well as excess weight putting more pressure on joints, it also increases inflammation and pain.
Evie, just
Yeah.
at this point, somebody wanted to know more about like the weight aspect. Is it worth actually running through, just pausing and running through what we tend to do?
Yeah, but it's on the next slide.
Perfect. All right.
I think it is.
No.
Click again and just check. And again.
It's not a huge amount. There's enough. And we can top it up, can't we?
Yeah, completely. So did you want to jump in and do your bit about calculations?
So just about how to do a really simple weight clinic. The things that I found that are really, really important, guys, is that you need to give them a target weight. They need to know what they're aiming towards. And the thing that we've heard from clients again and again is when people say, oh, your dog needs to lose weight, it doesn't give them any direction, ambition, timeline, etc. So take the time to get a piece of paper, work out the dog body condition score, which Evie's going to teach you in a bit. Work out from that body condition score, very simple maths, what their target body weight is. So if they're 6 out of 9, that means they're 10% overweight. So you work out 10% of their body weight and subtract it. But give them something to target, and it's always going to look intimidating. So say you've got a Labrador that's 35 kilos and you feel that it's 7 out of 9. So you believe it's carrying 20% too much weight. So it's 120% of what its body weight should be. And then you do the maths quickly and you're like, oh my God, he's actually supposed to be what, 28, 29 kilos? Oh my God, if I suggest that, they're gonna laugh at me. That does happen. And it's happened to me where when you've done the calculations, it just looks like obscene.
Yeah.
But quite often, when you hit, say, 31 and 30, you realize they do still have a little bit more to give. But what I would always remember to do is say, that looks like an extreme weight loss plan. I'm going to support you throughout the journey. If we hit 31 and they look perfect, we'll stop there. But this calculation is pretty accurate, and it will give us a target, and it gives us a timeline. But I assure you, if we hit a target body weight before the calculated weight, that's where we'll maintain. So just remember that tip. But the next thing that you really need to do is, as I say, create this timeline, manage their expectations. And I use the simplest method ever, which is 1% weight loss per week. So in my head, they're 35 kilos. That means that I'm aiming for 350 grams weight loss per week. So when I see them again in 2 weeks, it's 700 grams weight loss. And I will say, right, so I'm going to see you in 2 weeks. Our target, if you choose to accept it, a bit like Mission Impossible, our target, if you choose to accept it, is 700 grams weight loss in the next 2 weeks. And then I'll make a joke, kind of going, and do you know what? If we continue to fail to hit that, I'm taking over. And they're like, oh, and I'm like, no, I'm in it. I will be taking over, and I will be encouraging you to go onto a diet of my choice so that we can actually really shift this weight, because it is a health concern. So by doing that, you've given them the long-term ambition, the short-term ambition, and then you can also calculate how long it's going to take. So if you know they've got like 20% of their body weight to lose and you're going about 1% per week, you can say, look, if we really tackle this, we're still looking at a 5-month project before we hit that target body weight. Another thing to also mention is that around about, I think 50% actually ever hit target weight, and 50% then bounce back once they have done. So there's a really high failure rate, and it's really worth mentioning that at the beginning. It's almost like it's like a challenge. You know, I'm going to be honest with you, many people do not hit target body weight. It's always really upsetting for us because, you know, we know that there's the potential there, but people fall by the wayside. They can't see that the weight is a health concern. And even more upsetting is the occasions when we've done all the hard work, and then once reaching target weight, the owner sits back and it starts piling on the pounds again. So all these things are really worth mentioning. Right, back to you, Evie, sorry.
No, that's fine. Also, the calculation that we use, and it's really simple and easy to convert, that Hannah was talking about, converting the body condition score to how much overweight they are, and how much weight they need to lose. It's all in the nurse flip chart. It doesn't show it on here, but it's on the nurse's side. So I also at the beginning was a little bit unsure about, I'm not very good at maths, it's not my strong point. So I used to I'd say to the owner, look, I'll email it all through to you. I'd show them the calculations and what I'd done on the email. And again, like we said, because they're not remembering everything that you're telling them in consult, and you're telling them so much other information, following up with an email is quite a nice idea. I also teach the owners to body condition score in their first clinic so that they can carry this out at home and they understand it. So the Royal Canin scale, well, it's the Wasava scale that we use, but Royal Canin do out of 9 as well, and they do lots of free. You can just ask them for body condition scorecards. So I always circle what they are in red, and then green is what they need to be. And it also gives them pointers as to what to look out for when they are measuring the body condition score. So that's really useful. So yeah, I think that's basically everything run through with weight management. Can you flip to the next? Yeah, I think so.
I guess another thing to add is don't be shy to mention the other health benefits of optimal body weight. So they did a study and looked at actually mood in dogs that were able to hit target weight, and their demeanor improved, their quality of life, their impression of life, their attitude to life improved. And so if you would say, look, we're not just pushing to get this target weight because of the osteoarthritis. There's so many other reasons. And one that I really love doing, because it's really scary, is when I turn around and go, and do you know what? When you have to unexpectedly operate on a dog that's overweight, it's not pretty. The anesthetic's harder. And also, if I'm guddling around trying to find your dog's pancreas, it ain't easy to find. And you can see them just going, but it is worth just having these little ditties that you have floating around in your head that you can just assess what the client is doing. And you can just drop things in, because these little impressions will stay with them. They're little haunting, little pokes, haunting pokes, we're going to call them. But it is true, we don't want these overweight dogs on an operating table. We don't, we don't want these overweight dogs having heat stroke. There's so many reasons. And something that I didn't know until I went to a really good, there's a really great lecture by a lady called Hetty. Can't say her second name because she's Dutch, I think. Anyway, she was talking about the biomechanics of too much weight. They actually gait assessed dogs that are overweight, and the range of motion that their joints are put through exceeds normal. The other thing is they also realize that the lipid, it's not just that it's a source of inflammatory mediators, it actually permeates through into tendon structure, muscle, ligament structure. And that lipid infiltration can actually weaken those structures. So there's so many reasons that weight is important. And another haunting ditty, it's the thing that you're really in control of, mate. That dog doesn't go to the cupboard. That does not get out the measuring bowl. It doesn't pour its own food. I hold you wholly responsible. Okay, save that special occasions, only special occasions. But it is true. Weight is completely in our hands. We are responsible for our animals' weights.
I think also so I had a Rottweiler, she was 72 kilograms at our first consultation. I think when I worked out the calculations, I think she was meant to be about 35 kilograms. So she was grossly overweight. And when I said how much she needs to lose, the owners were really daunted by that. And they were like, well, we'll never be able to do that. So instead of just having this massive weight loss, we basically put it into chunks. So I said, okay, so let's start off, we'll set our goal, let's get her to 65. So let's just lose the 5 kilograms. And that came off super quick. So the owners were like, they reached a goal. So it gave them a lot more motivation to then carry on. So it's keeping the owners motivated. Also at work, I've got a leaderboard. I have, so we have Slimmer of the Month. We put a picture of the dog up who's lost the most weight in that month. And the owner gets to write a little story about what they've done and tricks and things like that they found out along the way. They love it. They get a certificate. The dogs get a little bag of the weight management treats, and yeah, it's fab. So it's all good. I have got a couple of questions. So Anna says, what do you suggest to clients how to achieve this reduced amount of food by how much? So Anna, what you need to do is it'll make more sense when you have the nurse flip chart in front of you. So once you've calculated, oh, hang on, Hannah's gone, but we can still carry on. I'll answer the questions. So once you've calculated the dog's body condition score and what their ideal weight will be, you then need to work out their RER, so their calorie input per day of what they need for their ideal weight. So what I've done then is I've gone through all the most common foods that owners feed and worked out the they normally will tell you how many kilocalories are in 100 grams. You just work out how many grams that dog will need per day for their ideal weight. It's all on the nurse flip chart how to do that. I also do have a handout which I can email to you as well if you'd find that useful, because yeah, I am rubbish at maths, and it's if I can do it, anyone could do it. And like I said, you don't have to do it with the client in the room, because again, that puts pressure on you. Email it to them. They prefer it. They've got it all in front of them. They have no excuse. And to answer your question, Claire, do you automatically recommend prescription diets or try weight loss on their current food first? So like Hannah said, I always recommend that they stay on their usual diet first, work out the kilocalories of what that patient needs for their ideal weight, not the weight they are then, their ideal weight. See how they get on with that. If the owner's not getting on board and the dog isn't losing any, you should see weight loss even by keeping them on that food, because they're feeding them a lot less. It's normally a lot less than what the recommended, on the back of the bag, they have like the weight of the patient and how much you should feed them each day. It's normally less than that. And the owner will be like, oh my God, but I'm like, trust me, it will work. If it isn't working for any reason, then I talk about prescription diets. For some owners, it's better, you kind of gauge the owner straight away. Some owners that I know aren't going to do it, I say let's put them on a prescription diet straight away, because you can then create a management plan with that, and because they're paying a lot more for the money, they're going to probably stick to it. So kind of gauge the client you've got, but I tend to start with their normal diet first. Is Hannah back?
I am here.
Oh, lovely. Can you flick? Yeah, lovely. Does anyone else have any questions about weight management whilst we're on that? Nope. Perfect. Another good point is what you could do. I made for my practice is basically looks like a little Slimming World diary, but for the dog. So the owner comes in, you can put the date of when they came in, the weight they were that day, their body condition score of the day, and also take metamorphic measurements, so measurements of their neck, their chest and their waist. So once you start getting closer to target, yes, you might not be having these massive weight losses as what they've had before, but you might be seeing movements in the measurements. So that's why I take the measurements, because again, it keeps the owners motivated if they are seeing a little bit of improvement. So we then move on to the adaptations to the home environment, and this is where the It's My Home 2 tool comes into its own, and this will be a really good add to your clinic. So like I said before, like the Good Day, Bad Day diary, we have the QR code on here so the owner can scan that and get the digital version on their phone. So when we're talking about home adaptations, we need to be addressing common household hazards and explain to the owners how much of a game changer this can be. So think back to the lecture Hannah did earlier about game changers and how much that can change the benefit the patient. So the dog is there 80 to 90% of its day. So if it's on slippery floors all the time, if it's climbing up and down the stairs, if it's following the owner around the house like the videos earlier, they're going to keep injuring themselves, and it doesn't matter if they're spending £100 a month on medication. That isn't going to make any difference if they're still going to keep injuring themselves. So that's normally a good way to put it across to the owners. And it's, like I said earlier, it's a good bonding point because they feel like they're kind of getting something for free. It's quite nice and easy to make these changes around their house. And they because they feel more involved and like, oh yeah, this is really something I can do, like straight away when I get home, they get quite excited about this, and it's something that they can improve and help their pet. You might think surely this is common sense when you're talking through it, when you're saying let's put a rug down, right, let's put a baby gate across the stairs, or let's raise the food bowls, things like that. But honestly, people have no clue. They don't think about these things. And also when they're in this emotional state of, oh my God, everything's changing, everything just goes out the window. So start basic and make sure you run through every aspect. Like Claire said earlier, you could, if you knew this pain clinic was booked in at the beginning of the week, you could give the owner a ring and just say, could you just take a video around your house just so I can have a look and see what adaptations we can make? And that could be something you run through at this stage of the clinic as well. But if not, let them take the It's My Home 2 tool home, and let them go through that all together, so they can think about that when they get home. Go.
Is that good? No, this
Yeah.
one?
Yeah, you can go. So we then need to think about our veterinary practice flooring. So like I said, when they're in the room with you, we need to be practicing what we preach. So making sure that the consult room, there's nice non-slip flooring all over the floor, that you're not putting them on the table, that the waiting room, there's yoga mats or non-slip rugs. They're available for the patient, that you're using them throughout the practice, so that it highlights to the owner how important this is. Next one.
This one.
Yeah, so we're then going to, so when I was thinking about things that we can use that are inexpensive for both us at the vets, because we all know that our bosses don't like chucking money out on things that they think are useless, and also for owners at home. So we don't need to be spending hundreds of pounds on anything, and it's quite a nice way to show either your boss or the owners that actually I didn't spend a lot of money on this and it's made a massive difference. So like we've been talking about the yoga mats, door runners are actually really good, especially when you've got bigger dogs, and also if you're taking blood samples or putting catheters in, the door mats are quite nice for us as well, because it's something soft for your knees to go on it. It can fit a lot of people on it, but they make a massive difference. And the patients, when they're off the mat and on a mat, is just, yeah, once you start using them, you'll then be like, oh my God, why did we never do this? Because it does make a massive difference. I also put them in front of kennels, so that if they're having to step out of the kennel onto a slippery floor, then they're not nervous about that. Sometimes if you get dogs that pull back and are resistant, it's because they're nervous about coming out onto that slippery floor, especially if there's a step down. The foam jigsaw matting, which I showed you earlier, I think mine was like gym matting on Amazon or something like that. I've also used that in my consult room quite a lot. It's nice and comfortable for them, and also, yeah, stops that non-slippy floor, and you can make it into shapes to fit the room. Also, go into your local carpet shop. The one down the road from me is amazing. They've always got a massive tub full of offcuts, but I'd always make sure that you put non-slip tape underneath that, because else that will slide on the slippery floor and there's no point. Okie dokie. So we also have an amazing endorsed product, which is Floors for Paws flooring. So these guys have done so much amazing, they've done loads of studies and work towards flooring that is suitable for for dogs. So it's non-slip, but it's also comfortable and durable, and actually it looks amazing. It looks really nice. It's really lovely flooring. So they also have a domestic range. So if your owners were thinking about changing the flooring in their house for their patients, this is a company to recommend to them. But they also have a commercial range as well for veterinary practices. I'm not telling you all to go in on Monday and tell your boss to change every single piece of flooring in the practice. But if it's something that you were setting up a new practice, or it's something that you wanted to do, then these guys are definitely the people to talk to. They also have a product called Paw Safe Mat, which is basically a durable upgrade to the yoga mat. The bottom bit is non-slip, so it doesn't slip away from the patient, and it's non-slip on top, so they're comfortable and they don't slip on the floor. And it's also cushioned, so it's a lot thicker than a yoga mat, so there's a nice comfort layer, a grip surface underneath, and it's fab for your knees as well. Next one. So also Mo at Floors for Paws has offered an amazing 10% discount if you did want to order any of these products. And her email address is, Hannah, if you could just flip back a slide.
Yeah. And it's Mo's he.
Oh, sorry, Mo. Back.
It's there, isn't it? Mo at Floors for Paws.
There we go. Yeah, so it's mo@floorsforpaws.com. You just need to quote Cam and you will receive a 10% discount, which I think is fab. So if you wanted to order any of the mats, then that is your place to go. Next one. So we then talk about understanding exercise requirements. So like Hannah was talking about earlier, this is where you bring in PRR, and also talk about little things that the owner could change straight away. It also might be where you consider incorporating targeted exercises to improve balance and strength and things like that as well. Next one.
There seems to be a lag. I'm pressing click and it seems to be
weird.
changing.
No,
Yeah.
that's all right. That's okay. So again, this is an emotive topic. Owners can feel that it's the end of the road. They're not able to do the things that they wanted to do with their dogs before. They always get really sad when you say you can't throw the ball for them anymore because they love the ball. But come up with plans that are going to work. One, that the owner can still have a lovely time with their dog, but also things that are going to make it easier for their dog. So as well as thinking about being proactive, reactive, and reflective when you're taking them out for a walk, I also talk about things now like mental stimulation. So the way you're feeding them. So it might be a rainy day, so you're not going to take them for their normal walk, or it's not suitable because the ground might be quite slippery. But you could take them out in the garden, and instead of putting their food in the bowl, you could scatter feed them, or you could bring a mat in and put the snuffle mat down and let them have a snuffle mat, things like that. And making sure that when you're creating these exercise plans with the owners, that you think about the dog as an individual. You're not just thinking, oh, this dog with OA, so it gets the OA exercise package. So a 3-year-old Labrador who's just been diagnosed with elbow dysplasia is going to be completely different to your 16-year-old Cocker Spaniel who's just come in and can hardly move. So making sure that you're adapting to both the dog and the owner and what they're currently doing. And it's also really important to make sure that the owner understands that it's not the end of the road, it's just a change in direction. And I think that quote is something that I use all the time. And it's something that really resonates with the owners, and it's something then that they're like, okay, it's not so bad. We are like, this is going to work. We can still take them on exercises. It's just slightly different. We can't throw the ball. We can't feed him all his treats all the time, but we get more years with him, and that's fine. So we then move on to diet and supplements. This is a massive minefield for owners. They are bombarded with this in every direction they look at. They turn on the TV, there's an advert. They look on Facebook, there's an advert, Instagram advert. So this is where you need to make sure that they are understanding that there could be misleading claims. Owners tend to be quite like they clutch at straws, especially if you're talking about end stage and things like that. They just want to do anything to help this dog. So if someone's on Facebook telling them that there's this miracle supplement that they can now give them and it's going to change their dog's life, they'll go out and buy it and spend hundreds of pounds on it. So just make them aware that there could be misleading claims and also false marketing, and also that unfortunately there is no cure for arthritis.
And what we have got a section about supplements where we're going to give you more of an overview, which we can come to after this, because I know it was something that wanted to be discussed.
Yeah. So when we're talking about supplements, they are often very often mistaken for pain relief. So it's important that the owner understands that no, it's not. This isn't pain relief. He is now on pain relief. That was to support the joint health and things like that. So make sure they understand exactly what is going on. It says accessible outside the vets, and so it is seen as cheaper, but often it's not cheaper. I had one lady the other month who said to me that she was going to have to stop coming to the clinics because she was struggling with costs and things like that. And I said, yeah, that's absolutely, like, completely understand. But I asked if we could just sit down and work out how much she's spending and what she's spending it on and things like that. And she was spending £450 every 2 months on different supplements. So we worked out that maybe that's not the best avenue to be spending her money down, and worked out a better plan, and now we're able to work what's better. So it's not saying don't ever use supplements, but just be wary what you're spending your money on, and that it's not going to cure it, and it might not be needed in this case. Clients don't have the knowledge that these are unregulated, so they're allowed to do all this mental marketing and pushing that. There's no efficacy studies on this, there's no safety studies, there's no reporting of adverse events, there's poor evidence behind supplements. They can be utilised inappropriately, so that it may not be necessary for this patient in particular. They have slow onset of action, also prone to caregiver placebo. So that's something that they also should be aware about, and talk about using your objective monitoring if they are going to use it, and see if it is helping. So it's a lot more expensive, and promises don't make a better product, basically. So just make them aware of all of these different things. Talk to them about, is that a good use of their money in this case? Could it be better spent in a different way to help support their dog? So also when you're talking about diets and supplements, because it's something that owners are bombarded with all the time, you can come across that it's a bit of a sales pitch if you're trying to push things like your joint health foods and things like that. So just make sure that you make it aware to them that you're not trying to do a sales pitch, you're just helping them, guide them in the right direction. I'd like to make you aware about the difference between a supplement and medication, things like that, because as soon as they think you're doing a sales pitch, they're going to back off. So you just want to make it aware to them that you're just there to support them. You just want to make them aware of the minefield of what is going on out there. We move on to complementary and physical therapies. So I always talk through to the owners what therapies are available for the patient, what is available in practice, and give them a list of therapists outside of the practice, so that I know that they're going to go to a therapist that is regulated, but also that we have a rapport with as a practice. So we make sure that we have that continuity of care between both the vet, the nurse, and the therapist in question. So when you're speaking about this, you can then again highlight the multimodal approach and saying that by using the multiple interventions at the same time, that is the best way we're going to see a really good effect of all of this. Explain that reducing the pain of OA is phase 1. We then want to restore the function and capability, and that has decreased over time, requires phase 2. So we want to improve the muscle function, regain the range of motion in the joints, improve strength, stamina, power and agility, and regain the ability to safely negotiate activities of daily living and enjoy exercises. So yeah, this is a really good point. We're going to run through a bit later on about all the complementary therapies and what benefit they have for each cases. Owners tend to, what I found, it might be different than anyone else's, but with the clients that I have, they tend to know about hydrotherapy and that's about it. So by going through all the different ones, it opens up a wide variety and what might work for their dog. Yeah, that's okay. Go for it.
Okay.
Yeah.
Done.
And then last but not least, we go on to anti-inflammatories and other medications. So this is where I go through with the owner what the importance of why the patient has been started on medication. Dependent on what medication it is given, I then talk about why it was that particular medication that has been started. I make sure they understand how to give it, if they're dosing it correctly. Any side effects that they might see, so you're being open and honest with the client from the beginning, so they're not worried about anything, and answer any questions. A lot of owners come in and they're worried about Metacam or Loxicon and all the different names that it comes under, or any pain. A lot of them are worried about any pain relief because they're like, oh, it killed my friend's dog 11 years ago, and I'm so worried about it. So what I tend to do is sorry. Sam just really distracted me. So what I tend to do is I say, if you are worried, then that's absolutely fine. A lot of people are worried, so they feel like they're not being stupid. And I just ask them, I give them the options that if they could come in regularly or every 6 months, say for blood tests and urine samples, things like that, so that if there was any changes in kidney or liver parameters or a change in the urine, anything like that, we would get on top of it quickly, and that could be something that was managed. I also make sure that they understand that this may not be a medication that they need to be on forever. So our younger patients, so for example, we've got a 6-month-old Cocker Spaniel who has just been diagnosed with hip dysplasia, and she's just been prescribed Metacam. We've told her that it might not be that she needs to be on this every day for the rest of her life. It might be that we just need to get the pain under control now. She's going to see an orthopedic surgeon about having a hip replacement and things like that. So it might be that will change. She'll need more at one point, she'll need less at another point. So making sure that they know it's not just going to be this one medication, it might not be any, and go from there. Next one.
Which ones?
Next one.
Next one.
So there's a really nice quote from Chris Zink. Oh.
What one? Sorry, I am moving them. They're just really sticking.
No, that's okay. Just go back to the one before.
I have done. I did it about 3 seconds ago.
And again, go back again. Okie dokie. Perfect. Leave it. Hold. So a quote from Dr. Chris Zink was, when we see pain, it's likely that the dog is 7 out of 10 in pain. So that's really important. So that's when the owner is able to realise that, yes, there might be something going on, or we pick it up, things like that. So it's really important that we do that we are medicating these patients and controlling their pain, because else it can lead to behaviour changes. It can lead to the loss of the owner-dog bond, and unwanted behaviours. So by adding in the pain relief and managing it, it makes a massive difference. And yeah.
Slide.
Yeah. I think we've gone through most of these. So the 8 points not to forget to talk to the owner about. So understand that they don't come with a promise. So we might start them on one medication. It might not be the right one for the dog. So we might have to change it onto another one, or we might need to add something in. And that's when we need to observe and monitor. The dog's response to the medication is individual. So yes, their neighbour's dog might have had a catastrophic event and spread diarrhea over the whole village, but it might not happen for their dog, and it might be exactly the medication that that patient needs. It's not uncommon for a dog to be on multiple medications at the same time, and if that is the case, then maybe talk to the owner and work together to make a timetable throughout the day so they don't get confused, things like that. Telling them about the routine blood and urine screens, so we can monitor adaptations to other health problems that might be going on, and making sure that the medications we're giving are safe to do so in that case. By doing this at the beginning, it also allows the owner to expect to come. So if they ring up in 6 months' time and say, "Oh, can I have a repeat prescription?" You say, "Oh no, you've got to have blood tests and a urine test for that." They're expecting it rather than it being a surprise. I'd also tell them about the guidelines of your practice. So when you do prescription checks and things like that, so say you're doing Librela, and 1 month you see the vet, 1 month you see the nurse, and things like that, just so that everything is clear and the owner understands when they're booking in or ringing the practice. Making sure that they're following the dosing guidelines and discussing any changes of the plan with the vet as required. Adjustments to the plans are, if needed, spaced by weeks, as medication can take time to take effect. If you have concerns, discuss with the vet or the team. And medications prescribed may not be for life, as if other aspects of the multimodal plan are maximised. So, like I said, it might be a young dog that's been diagnosed with hip dysplasia and it's currently experiencing a flare, or it could be a severely overweight dog that suddenly loses all the weight and it's a lot more comfortable, so we can take a medication away. So again, showing why monitoring is so important. So the OA kit to take home. So a lot of information for the owner to take home, and your role is to do the CAM 4Es. So educate, engage, enable, and empower. Massive take home would be create a kit for them to take home. Like Hannah said, they love a freebie, and if you work out the costings and things like that and include a free kit, they love it, and that is something that they can go home and show the family and show their friend down the road, things like that. So in my consult kit, they get a free CAM OA booklet. So how this is set out is basically a vaccination booklet, but for the management of OA. This can be used by the owner, the vet, the nurse, and a therapist. So it basically is it runs through what's been discussed, what the plan is moving forward, how the patient's getting on, objective monitoring and things like that. Owners really like this because they can take it home, read it, they can then get that the whole team is working as one, rather than it being bits. So I saw the vet and then I saw the nurse and they weren't talking, they didn't know what they were talking about. So that's a really nice booklet to have. They also get the CAM bandana, a CAM business card, leaflets of complementary therapies in my local area, the objective monitoring tools that we're going to be using, information on medication that the vet has prescribed. So I've made little laminated cards of each medication that we use in the management of OA in my practice. So what it does and why they've been prescribed it. On the back, it just has the dosage instructions for that individual patient and how to give it. We're just at the moment coming up with a handout to give owners where it gives them different ways of how to give medication if the dog's fussy with it and things like that. So that different things like that just to help them. A weight loss chart, so their little Slimming Well book and a body condition score, and also an appointment card with a scheduled telephone call or consultation coming up next. So I always make sure that that's booked in before they leave the practice to ensure we keep the ball rolling with this. If it's something they can't do then, I schedule it in to give them a ring and just catch up and just say, oh, I haven't seen you in a while, just want to see how Fluffy's getting on with his weight loss or how he's getting on with the home adaptations. It just helps to remind them of how important this is and that they're not just a lost cause and we saw them once and now we've forgotten who it is. So again, we've also got Lint Bell's Mobility Matters appointment cards, and they've also got the Mobility Matters booklets. They're all really useful in helping to set up your clinics as well. So please give your local reps a ring and they can send that all over to you. So yeah, they've got a really good guide about how to set up your clinics as well. So that will definitely help. So a conclusion of this lecture is to educate our owners. They really not... What did you say? I don't know, she's gone.
No,
so
carry on.
So educate our owners. They aren't just being stupid, they just genuinely need to understand what's going on. I know it can be frustrating at times, but just start from the basics and work up. Take your time, these consults cannot be rushed. So make sure it's booked in at a quiet point during the day, or make sure that you have a whole day booked off for clinics to allow that you've got a good amount of time to go through it, as it is a really emotional time for the owner. Make sure that you structure your consult. So please do use our flip charts and the Lint Bell's Mobility Matters guides and things like that. But everyone's clients are different. Your clients are going to be completely different to my clients. So you might find a way that, oh, actually, this works a lot better for my clients, and that's fab. It's there as a guide and just to help you get set up, and you will soon get to know what's going to work for your clients and how it works for you moving forwards. I really enjoy these consults because they're so rewarding. Seeing that owner bond when they're getting used to their new exercise regimes, and the dog's feeling a lot better on the medication and they're more confident coming into the practice. It's so rewarding. So please do enjoy them.
Oh, righty ho. I think the slides, they just stick. They just I've pressed them and then you're talking about 5 seconds later, so I don't know what that's about, but Zoom's being glitchy today. There's a question about, do we automatically recommend prescription diets? Again,
I've already answered that one.
You've done that? Okay, you happy with that?
Yeah.
So
Unless you want to do it.
No. I was just going to say that again, I have to really judge the client. You know,
Mm.
at the moment, we've got the CMA going on. People are really, really convinced that vets are there just trying to make money out of everybody. And I think it's a really interesting time with regards to you using your body language skills. You look at the owner, you look at their conversation, you look at their history, and then you make that decision. I mentioned that quite often I'll say something along the lines of, hey, so if we don't hit that target weight, you know, I'm going to take control. So if after 2 or 3 weigh-ins, we're really not shifting weights, I've already preempted, I've already told them that if we're not hitting target, then I take control. And that might mean that I do a prescription diet. Because I have had great success on them. And another thing to mention with these prescription diets is it does the supplement for them. So if you were to choose something like JD with the metabolic component, it means that they're not going to have 2 financial outputs. They've got 1. And that can be really, really appealing to clients because they've already been bombarded with lots of other costs. And it also reduces some of the confusion as well. They don't have to think about diet and supplement and it's all done in one. Can we discuss supplements? Yes, we're going to do that now. Have people got the brain space to jump straight into supplements? Have you got the capacity? Let's do it then. Because you're going to be disappointed. No, let's just preempt this one here now. I am not going to be giving you a recipe. I'm not going to be going high five. Let's do this 100%. I'm backing this one. We're going to look at it in a little bit more of an overview manner. So let me just get to the right place. We'll jump over all those other supplements, no therapies, and we will find. So whilst I'm finding it, I will be honest. Supplements is probably the hardest part of what we do. Because there is such a strong emotional connection to supplementing your dog. It's as strong as pain medications are required. And what I tend to find is that they come hand in hand. So if you don't discuss them, you're kind of failing the owner because they're expecting you to. But they're also quite disappointed with the truth. So we'll run through a presentation that I wrote for another company. Let me just find it. Presentations. Supplements. It's doing it. It's doing it. It's doing it. Come on. You can do it. Right, whilst it's uploading, I'll come back and talk to you. So, are supplements pain relief? No. Okay. So that's one thing to deal with immediately. People will talk to you about the supplement that they bought on be it Amazon, or they bought it direct from the company, or they bought it from the pet shop, and they really do have a belief that they are dealing with the pain of OA. So let's just talk through that structure I was teaching about earlier. There's the disease that's happening in the periphery. There's the amplified nociceptive signaling. There's the consequences, and there's the acute flares. Where would I position supplements? I'd position them towards the disease. So when I'm creating my care plan and I'm ticking off, have I achieved this? Have I ticked that box? The supplement conversation for me slips into dealing with the disease. That's what we tend to do with them. Supplements are many and varied. Some are more established. Let's deal with the glucosamine one immediately. 20 years ago, somebody wrote a book, Arthritis the Cure. They jumped the gun on that one. So unfortunately, studies that now look at glucosamine, and we're translating a lot from the human sector, has really, really said, looking at big figure data, big numbers, big clinical trials, does glucosamine and chondroitin have a place in our strategy? And on the whole, no. So it was called the GATE study. And I think it 2,000-3,000 people. But when they subcategorized into like mild to moderate OA, they felt that there might have been a clinical benefit. So they're not saying it's completely no, but really specific category. And that's not how we kind of prescribe supplements. The nature of our work as veterinary professionals is we don't choose a supplement for the category of the condition. The paper that was released in 2022 was a review by Eric Tronci and his team did it, and glucosamine and chondroitin sulfate were completely poo-pooed. When they brought together all of the animal data and they compared these clinical trials, they were like, just push it off your radar. And that's due to like the bioavailability. They actually don't believe that what we're putting in by mouth has the ability in great quantity to get to the area of concern. The key players that have shown up to be of potential benefit are omega-3s. That's where everybody tends to sit quite comfortably at the moment. So let me just share my screen and I can get this presentation up. Slideshow. So we're going to jump through this. Remember, guys, osteoarthritis is a welfare concern. I don't know if you know this, but the work done by VetCompass, which is a little epidemiology kind of like study group off of the RVC, was looking at first line data in clinical practice. And these are the cases that we see. I don't know if you know, but historically, much of the evidence and material and the case studies that we've referred to for evidence have been done in referral practices. And that means that you get a very different audience, a different caseload. When we actually have the ability to tap into first opinion practice and what we see on a daily basis, it's been skewed 100% a different direction. And what they found is the biggest welfare concerns in small animal practice is obesity. Don't do that very well, do we? No. Dental disease? Don't think we do that very well either. Oh, and osteoarthritis. And osteoarthritis features because it's the condition that causes the most amount of suffering for the longest amount of time. So do not feel uncomfortable saying to your practice team, this is a welfare concern. I feel that we should do more about it because you have got evidence to back that. When I started off, I was saying that osteoarthritis is the leading cause of death. I didn't have any evidence to say that. I was winging it. But luckily, in 2018, they brought out a study where they looked at causes of elective euthanasia from VetCompass. And as you can see, musculoskeletal disease sits right up there, straight under all forms of cancer. But if you look at this list, it's not the diagnostic list. These are clinical signs. Collapse. How many dogs come to practice to be put to sleep because they've collapsed? Yeah. What about here, down here, no diagnosis recorded? Well, actually, the presentations of chronic pain is wide and varied. Maybe there's some in there as well. Non-specific signs. Incontinence. Dogs that actually got bladder overflow because they actually don't want to get up and move. So they've got bladder overflow. Cachexia. Is that cachexia or is that muscle mass loss because of compensatory weight shifting? Aggression, behavior and pain. So it does make you wonder whether musculoskeletal could be the biggest cause of elective euthanasia. So just remember these things. They're little ditties. They're haunting ditties to use in conversation, especially in your team. We all now know that the radiographic evidence of OA in young dogs, 40% of dogs between the 8 months and 4 years. So we have got the ability to start picking up on this disease a lot earlier. 40% of dogs between 8 months and 4 years old had radiographic signs of OA in at least one joint. This was a study of 123 dogs, and 24% of them had clinical pain associated with that joint affected. So do not feel uncomfortable now picking up signs that you think could be OA in a dog as young as 18 months. We've got data to support you being confident in that area. And these figures are just going up and up. So it's a young dog disease. Very briefly, just pain and behavior. I talked a little bit earlier about how clinical lameness, so people go, it's not lame, so it can't be arthritis. That's out the window. Because in this young dog cohort of 123 dogs, they didn't necessarily come in. Well, they didn't come in for lameness. These dogs weren't presenting lame. So we did an investigation in Holly's Army of owners that had dogs diagnosed at a young age and said, with high insight, What were the clinical signs that might have given you a clue right at the beginning? As you can see, it's big and varied. Gait changes, changed interactions with other dogs. I said, you're an arthritic dog and a dog comes at you and you step back and you pull your soft tissue around your hips and you go, oh my God, that hurt. You caused it. You're the problem. So we have associated behavior changes, change willingness. This is the thing that irritates me when you see, if your dog has difficulty doing the stairs, maybe we should be picking up if your dog has hesitancy to do the stairs. So there's ability to capture way earlier. But here also, owners noticed the dogs became more anxious, noise phobias, panting, licking and chewing. These aren't classically associated with chronic pain, but it really opens your eyes to how big the problem could be. So supplements. No, this is me. Yeah, this is how it feels. Talking about supplements is extremely hard work because the data is really, really varied. And we're talking about clinical studies where we're looking at their impact on pain, basically. So let's just go through this together. The clinical studies that are done in dogs, be it glucosamine, be it under nature type 2 collagen, be it boswellia, be it CBD, what are they measuring? They're measuring clinical presentation. Clinical presentation is capability, pain related, so their gait, etc. So have we got the ability to say supplements affect the disease? No, because we're not post-morteming them, cutting them up and histologically looking at the joints. So it's a very difficult thing. We're looking at what do supplements do to affect their outward clinical appearance. So that's a really difficult thing just academically, because can we definitely say supplements are not benefiting the disease? No, because we haven't looked at the disease in a histologically way. But what interests us about supplements, what do owners want from a supplement? They want them to show clinical improvement, don't they? So, you know, that's me thinking academically. Do they really have an impact on OA? And are we really assessing their impact on OA? But owners are buying them because they're expecting them to cause clinical appearance change. The studies that we've got in canines tend to be small. They tend to be very small. And when you look at a human study, it'll have thousands of people over 5 to 10 years. We're doing studies that are like 70 days with 24 dogs. So there is a really big lack of power in the clinical studies that we refer to. So what I'm going to try and do, understand supplements within the multimodal approach, review the evidence, compare regulation of supplements versus medications, and review common supplements managed used in the management of OA. But what I really want to do is give you practical advice of how to include them in case management, tips on how to help navigate the supplement world, and the skills and the confidence to advise on probably the most complex and emotive aspect of OA management. I really, truly believe this. So they do feature here in our multimodal management, and they do feature in the multimodal management. But I would outrageously say I think they're given way more attention than they're delivering. So sorry, Limp Bells, to be offended by this, but they need to be seen in their place within the multimodal management plan. If I had £100, would I buy supplements or would I buy a rug? I'd buy a rug. I'd buy a rug. So that's how I feel about them. I feel that they have a place. Don't get me wrong. I feel that they have a place, but I just feel that people's attention is drawn to them over other really practical interventions. And this is what you've got to navigate. With the data being so changeable, so quite hard to interpret, it being a really established market, it's within the owner's expectations. You've got to navigate making them fit in proportion into your plan. Does that make sense? I'm not saying don't talk about it. I'm not saying negate all of it. I'm not saying embrace it. I'm saying position it within your management plan to the degree of energy and time that they deserve. Don't do it at the expense of exercise. Do not do it at the expense of home management. Do not do it at the expense of pharmaceuticals. There is stronger support in that sector. So they are within owner control. They're in the volume of influence pyramid. But The clue is in the title. This is how I talk to clients. Clue's in the title. It's called a supplement. If it was the be-all and end-all, it'd be called the Holy Grail. In fact, it's not. It's called a supplement. So it supplements our plan. It's not our whole plan. And this is how we're going to position it. Okay? Simple sentence, but can be very powerful at getting the proportion of energy and interest and financial kind of commitment. It's a supplement. Is that helpful? That key little sentence there, right? So the thing is, public perception is strong, and there's strong marketing. You know, what I like about Limbels is that they are very aware of marketing regulations, and they stick to the rules to the best of their abilities. They use the appropriate terminology. They don't offer it being a pain relief. They offer it joint health. They position it in multimodal management. They do a lot of education surrounding supplements, and when they've done these campaigns, they don't focus just on what their product's going to do. They talk about the bigger picture. But we have to remember the social, psychological situation of the caregiver that's across the table from us, and what they have learnt, what they believe, what they're exposed to. Supplements come across as safe. Safe because they're natural. They have that organic bag look about them, don't they? Well, we don't actually know. We don't know because there's no reporting system. So if there are adverse events, they don't generally get reported. So how safe are they? Non-pharma, because they're non-pharma, they've got to be more safe and they've got to be better value. So they immediately come with this impression that they're going to be better value. But actually, when you cross-compare what people will spend on supplements compared to pharmaceuticals, many occasions there's not much in it. And that's worth just mentioning to her. Just say, just check in on yourself. How much are you spending a month on your supplements? Because there is an area of vagueness about their benefit. So if an owner's coming to you saying, oh God, can't afford this anymore, just say, right, let's break down the cost. Let's see where you're putting, where's your outlay? Let's make sure that we're investing these available funds appropriately. So joint health as well, it sounds more appealing, doesn't it? I'm gonna return that joint to where it was originally. It can lead you to believe that you're actually making that joint healthier again. So I won't lie, supplements have a massive advantage regarding marketing. They really are very appealing, and I can understand why my caregivers get very connected to supplementing. Let's also think about the power of the caregiver. They want to feel like they're playing their role. And I've talked about their wish to change the home, to do that benefit for their dog. Getting on their iPad at 10 o'clock at night and buying a supplement gives them that feeling of power. It gives them that feeling of support, gives them that appropriate dopamine fix of I'm a good owner. So we've just got to remember this, and we've got to respect how they feel. They're part of the plan. They are not the whole plan. Okay. So I've given you 2 sentences. They are a supplement, the clue's in the title. They are part of the plan. They're not the whole plan. In those 2 sentences, you've said nothing more that let's put them into the category that they need to live in. They're not going to dominate our plan. I stand by this, and I will stand by this to my grave. More rugs, less drugs, more rugs, less drugs, more rugs, less drugs. And when you look at any nice guidelines about OA management in the human sector, do they spend much time talking about supplements? No, they do not. They talk about exercise. They talk about lifestyle. They talk about self-management. They talk about education. Let's remember that, okay? So let's now talk about evidence base, because that's what you're wanting to have to give you confidence to recommend. So evidence-based medicine, evidence-based veterinary medicine, is combining clinical expertise, the relevant and available scientific evidence, the patient's circumstances and whether they're suitable, but also the owner's beliefs and values. They all come together to make a decision. And so what I'm talking about is, you know, we've got to look at the context of what the owner wishes as well. You might find that there's some owners out there that say, what do you think about supplements? I've got available funds. Where would you invest it? And you say, well, if you've got limited funds, then I'd invest it over here. Let's get you on Metacam. Let's get you on Simicoxib. Let's get you doing hydrotherapy. But you will have some owners that are very committed to it. We'll jump through this. So what vets must do, and this is what's interesting about supplements in the vet sector, is that we're supposed to be reflecting on the evidence behind the interventions that we suggest. And we should always be reflecting, analysing and improving our clinical advice that we give her. We should really focus on animal safety, clinical benefit, and the patient and client experience. And clinical effectiveness is it just achieving the desired outcome? And what's really fascinating about supplements, I don't know many people out there that really check in to see whether they're working. And this is just something I'm planting the seed of. We pop them on these interventions that can be quite costly. Do we check in to make sure that they're having the desired effect? And what does that look like? Now, I've been thinking about this for years. How would you be able to tell whether supplement is working when we know that they take quite a long time to effect? So we're not talking 24 to 48 hours, we're talking weeks to months for them to have benefit. So the way that they would show to be effective is that the acute flare profile would drop. So we'd have less acute flares if we were managing the lifestyle. There'd be less severe, less intense, less long, and the overall hopeful pain state would be improving. Now, that's what we're trying to achieve with our supplements. Clinical effectiveness decided on evidence. We aspire to have large randomized blinded placebo and positively controlled studies to deduce clinical effectiveness, but we don't actually have them in the supplement industry. They tend to be small studies, they tend to be case series, they tend to not be very well controlled. The way that they assess whether they're effective is not using validated tools. So it's a real minefield. And the paper in 2022, they attempted to bring together all available data and amalgamate it with a strength of evidence on each of these clinical trials. So they looked at the clinical trial structure, the way it did what it did, and it graded it. And if it was considered to be a well-constructed trial, that evidence was promoted when combined. If it was believed to be a poorly constructed trial, that evidence was demoted in the final assimilation of data. Now, just so you know, I'm sure many of you have seen this. This is called the evidence-based pyramid. And what we're really trying to hit is these dizzy heights of systemic reviews and meta-analysis. But unfortunately, most of what we rely on are case reports and case series. We don't have great randomized controlled studies that are blinded. They are large in number, etc. So we do have poor data that we've referred to, but the evidence, lack of evidence doesn't mean no evidence. We have to remember that. Remember, with that evidence-based pyramid, and this reflects on everything that we do with chronic pain management and everything we do in vet medicine, is that we have to always check in. Is that anecdotes? Is that a person's previous experience? Is that a person's opinion? Is that an N=1 experiment?